Before we get started, I would like to introduce Chaplain Gregorio Marin, Director of Pastoral Care for South Miami Hospital and West Kendall, to offer our invocation. Chaplain.
Good morning. Buenos dias. I greet you in the name of our Creator, God our Sustainer, and God our source of life. Let us pray for one another. So if you feel comfortable inclining your head or closing your eyes, please do so as we go before our beloved God. God of new frontiers, God of comprehensive love, everlasting God, an eternal source of comfort. In you, Father of all mercies, we find life, and in the quiet contemplation of your power, we seek your wisdom. Open our minds, open our eyes, open our ears, open our hearts to encounter joy in the work of healing that we provide for all the communities and countries represented here. Innovate and inspire each of us with knowledge and wisdom, looking at new experiences in medicine as an eternal source of hope for those that we provide medical care. Allow our imagination to walk into the gardens of creativity, guided by your holy presence. May we fulfill our purpose as we gather together. May all the talents, abilities, and time we work together build wonderful experiences for our patients, our families, our loved ones. May we see in the perfect detail of each presentation an argument of your divine wisdom and inspiration for us. May we serve everyone with love, compassion, and solid knowledge. Here we are, God, our provider, God, our healer, God of all comfort, Shepherd of humanity, Spirit of truth. Bless us today and always. We humbly ask. Amen. Thank you, sir.
Thank you. Thank you, Chaplain Gregorio, for such beautiful words. And on behalf of Baptist Health, I would like to thank you all for joining us. And thank you to all our presenters that we will have today that are taking their time to share their knowledge with us today. I would also like to express my gratitude to all of our guests traveled from Latin America and the Caribbean to learn more about the incredible work that is being done here at Baptist Health. En nombre de Baptist Health, me gustaría agradecerles a todos por acompañarnos y darle una bienvenida a nuestros invitados que viajaron desde América Latina y el Caribe para aprender más sobre el increíble trabajo que se está ejerciendo aquí en Baptist Health. Baptist Health is the region's largest non-for-profit healthcare system with over 12 hospitals and more than 27,000 employees, 4,000 physicians, and 200 outpatient facilities, and physician practices spanning across 4 counties, including internationally renowned institutes specializing in cancer care, heart and vascular care, orthopedic and sports medicine care, and brain and spine care. Baptist Health has grown to be the largest healthcare organization in South Florida, consistently ranked as one of the best companies to work for by Fortune magazine, one of the most ethical companies in the country, and being one of the nation's best hospitals according to U.S. News and World Reports. This year, Baptist Health was again most awarded healthcare system in South Florida, with Baptist Hospital ranked #1 in the area and Miami Neuroscience Institute ranked among the top 40 in the nation in neurology, neurosurgery, and all of our institutes earned top rankings in the latest U.S. News and World Report survey. Baptist Health invested in building its international operation 28 years ago, and today is one of the largest hospital-based international healthcare programs in the U.S., facilitating more than 14,000 patient visits each year from over 100 countries, prior to the pandemic. At Baptist Health International, our team strives every day to continue to support our mission and provide the highest level of attention to our patients and our colleagues, both at home and abroad. Our focus on family-centered care is unparalleled, with a welcoming, multilingual, multicultural staff committed to providing first-class patient care experience, patient-centered experience. We take pride in welcoming patients to our city and working closely with physicians to meet their needs and expectations. From an air ambulance or commercial air transfers to booking accommodations with our team from the hospitality and business relations concierge, Baptist Health offers 24 hours personalized services to our international guests. Our organization is truly a global leader in healthcare, the premier provider in the region for compassionate quality care. That being said, I would like to play a short video about Baptist Health. I really get inspired when I see that. And now it's my pleasure to introduce Ms. Alex Villoch, Chief Executive Officer of the Baptist Health Foundation and our direct leader, for some brief words. Alex.
Thank you. Good morning. Thank you, Roger. Good morning. Buenos dias. Bienvenido. I am thankful that you are joining us here in South Florida, in Miami, for these few days of learning more about us here at Baptist Health. with more than 1.8 million patient visits every year. 1.8 million patients that we see across our system every year. Patients and family from around the world travel to Miami for an extraordinary medical experience. At Baptist Health, we are anchored not only with providing extraordinary medical care, access to research and so on, but really anchored on our core values of centered around people, our beliefs, our compassion, providing that in a context of excellence and with integrity and transparency. It is what sets us apart. All contribute to offering a welcoming experience to you, to your patients, to their families when they travel here. For our employees, our physicians, our patients, and our community, we strive every single day to fulfill that mission. Our shared values connect and inspire us. And the way we live them every single day in our work reinforces our culture and aligns with the pineapple that you see everywhere. You see the pineapple. The pineapple is the international symbol of hospitality, of welcoming, of warmth. And we live that every single day across our system. Our people are the heart and the soul of Baptist Health. Every single day we say that is what differentiates us. And our values contribute to our identity. It's what sets us apart from other healthcare organizations. And I will say, I hope you felt it the minute you stepped yesterday. I know you toured some of our facilities, that you feel it the minute you walk into our facilities. We are different. Our values are more than just words and ideas. They influence our decisions, every single process, our programs, and our day-to-day work, so that we can better serve each other, our community, and our patients and their families. Our success, which Roger and you saw in the video, our success comes from this culture of quality and dedication that is part of every member of the Baptist Health family. It is because of the generosity, the compassion, and the commitment to clinical and service excellence that makes us South Florida's world-class healthcare organization, that increasingly people from around the world come and seek care here because of that. I'll just highlight one of our 4 institutes. In just 6 years, the exponential growth, which is unprecedented in our industry, has led Baptist Health Miami Cancer Institute, which I believe you toured yesterday, to become a nationally recognized cancer program, poised to be, and I say already is, a destination cancer center for the hemisphere. In the case of Baptist Health Cancer Care, it is recognized as one of the best cancer programs in the nation. In just 6 years, that speaks to our values, our purpose, the physicians, their care, the compassion of the people that have come together to create this institute. It has us in the top 10% for treating the most complex cancer cases. And Baptist Health Miami Cancer Institute was recently ranked the #1 cancer program in South Florida. Our 4 institutes are hubs for innovation, leading the way with the latest in clinical trials, technology, and pioneering medical advances. We are so very proud of the work that is being done right here on this campus and across our system. As Baptist Health looks to the future of healthcare in our region, research, training, and education are amongst our highest strategic priorities. Just last week, we signed an incredible agreement expanding our relationship with Florida International University's Herbert Wertheim College of Medicine, a very important alliance that will further support our research initiatives. Through this collaboration, as well as our partnership with Florida Atlantic University's Charles Schmidt College of Medicine, we are strengthening our research and educational ties with a common goal of improving the healthcare in the region while continuing to train and keep highly trained physicians here in South Florida to serve our community for generations to come. By offering access to the latest in trials, programs, and treatments, we are able to give patients and their families hope today and for many decades to come. Continuous technological advances combined with our emphasis on compassion will enable us to provide the best possible healthcare. We are grateful for the passion and the commitment of our physicians, which you will hear from many of them over the course of this symposium, our research teams, and our employees, which make it possible to pursue groundbreaking and impactful work every single day. And the most important thing, I think, as people from around the world come here, is that we're able to provide this within the context of the language and the cultural context that makes patients and their families feel comfortable at probably the most stressful point in their lives. Thank you so very much for joining us. Muchísimas gracias por su apoyo, and I really look forward to the next couple of days with you. Muchísimas gracias. Thank you.
Thank you, Alex. So before we start, I'd like to say that it was a nice experience yesterday when you all toured MCI. And I would like to please introduce who is here, Dr. Michael Zinner, who came to us from Dana-Farber to come and lead the Miami Cancer Institute and also bring together this collaboration of intellectuals that have come to be with us from all areas. So Dr. Michael Zinner is here with us today, and please, Dr. Zinner. During our break time, I would encourage you to please speak to him, and he is a wealth of knowledge. So thank you, Dr. Zinner. So we are going to move on to our first module of the day with our experts from the Baptist Health Miami Cancer Institute. The panel will be moderated by Dr. Manmeet Ahluwalia, Chief of Medical Oncology, Chief Scientific Officer and Deputy Director, and Fernandez Family Endowed Chair in Cancer Research. He will be joined by Dr. Guenther Koehne, Deputy Director, Chief of Bone, Blood and Marrow Transplant, Hematologic Oncology, and Benign Hematology. Dr. Minesh Mehta, Deputy Director and Chief of Radiation Oncology. Dr. John Diaz, Chief of Gynecologic Oncology, and Dr. Murugan Manoharan, Chief of Urologic Oncology Surgery, and Dr. Jane Mendez, Chief of Breast Surgery. Doctors?
Hi, good morning, everyone. While my colleagues join us on the podium, I would just again echo Dr. Ribas's and Alex Villoch's comment about welcoming you here. Could not be more excited about our interactions over the next few days. And before we begin, I obviously want to acknowledge again Dr. Michael Zinner, who's our fearless leader. And under his leadership, Miami Cancer Institute has grown from 24 physicians to now approximately 120 physicians. We believe in high-tech, high-touch, world-class, patient-centric service for our patients and their family members. Miami Cancer Institute has a very wide footprint. We see approximately 1,300 to 1,500 patients who walk through our corridors every day. And we believe that it's an opportunity for us to touch the lives of our patients, giving them a second chance. And as Alex had talked about, one of the big incentives for our institutes of excellence is taking part in the most cutting-edge clinical trials and innovation. And with that, I would say you are in for a real treat, because the next 5 speakers from Miami Cancer Institute are world-renowned authorities in their own respective fields. And you will see some of the latest and greatest advances which they are participating in and leading here and also worldwide. With that, to start us off, I would like to welcome first Dr. Guenther Koehne, who serves as the Deputy Director and the Chief of the Hematological Malignancies and Stem Cell Transplantation. Dr. Guenther Koehne is a board-certified oncologist as well as an internal medicine. He's a physician scientist who initially trained in Germany and then followed training in Illinois, and then spent over 2 decades at Memorial Sloan Comprehensive Cancer Center, where his special expertise is in leukemia, multiple myeloma, bone marrow transplants, and now CAR T cells and adaptive immunotherapies. Dr. Guenther Koehne is a highly coveted speaker as well as a researcher. He's leading multiple trials in these hematological malignancies, and I'm sure you'll be excited to see what he has to offer today. Guenther.
Thank you, Dr. Ahluwalia, for the kind introduction, and I welcome you to sunny but cool Florida. And you have to enjoy the day at 66 degrees. It's not that often the case. Now, within 12 minutes or 13, I just made a decision to give you a high-level overview of where we are and where we're particularly at Miami Cancer Institute with our hematologic malignancy and transplant immunotherapy program. And needless to say here, though, is that the landscape for hematologic malignancies has changed entirely over the last 3 years, if not the last 2 years. Now, there is a high emphasis on immunotherapies, and you may know that there are different ways of provide immunotherapeutic approaches. The CAR T cells is just one. Everybody talks about CAR T cells now, but I would not really wipe off the bispecific antibodies off the table, and then there are the antibody conjugates that are also being explored and administered. So just briefly, what's the difference and why do I say bispecific antibodies, particularly for lymphoma and multiple myeloma, are of relevance? CAR T cells are gene-modified T cells of the patient. They have to be collected, they have to be sent to a laboratory, they have to be manipulated by gene transfer to express the marker that binds to the tumor cell. That is a labor-intensive and very costly mechanism, and it's a timely procedure. So it takes 4 weeks, if not longer, sometimes to get the CAR T cells back for the treatment. Not every patient has 6 weeks to wait until the treatment is being administered. In contrast, bispecific antibodies are off the shelf and are available the minute you want them, and you can administer and start the patient if indicated. Now, the difference here is CAR T cells are infused as modified T cells, the bispecific antibodies, and that is the key. Recruit your own or patient's own immune system to the site. So the bispecific antibodies bind to the tumor cell, release cytokines, and your endogenous T cells are being activated. And then high emphasis, of course, is the allogeneic, the donor-derived stem cell transplant from related or unrelated donors. When I started in New York many years ago, I postulated that transplant is a form of immunotherapy rather than another way to save a patient with high-dose chemotherapy, and that is exactly where we are today. So the key questions, and I'm not able to bring this into conclusion today, is how do we treat the patient with what, when, and how do we sequence or do we combine? But I can tell you there are lots of activities of synchronizing and combining these therapies at the right time before and after transplant. Now, just to give you a number, this is the International Marrow Transplant Registry, to give you a flavor of how the CAR T cell world changed. And you see from 2015, or even if you look 2018, that's just 4 years ago compared to 22, there were 10,000 CAR T cells infused into patients with multiple myeloma and primarily lymphoma, in fact, and acute lymphoblastic leukemia. So that obviously has an impact. And I will easy to predict that the data for 2023 will be a lot higher, because now we have, as you can see here, just over the last 2 years, the FDA approved 3 or 4 different forms of CAR T cells for commercial use. And you can see on the left that the majority of the CAR T cells administered are commercially derived, and the other ones are clinical trial derived. But on the right, you can see the different CAR T cells that have been approved by the FDA. And you can see on the top the indications for CAR T cell administration driven by large B-cell lymphoma, primarily ALL. But now the multiple myeloma is coming out of the background, and there will be a lot of so-called BCMA-directed CAR T cell therapies, which we do here as well. Now, this is just to give you a flavor of how this changed the landscape. You can see the difference in the progression-free survival. It basically doubled the standard of care in blue compared to one of the CAR T cells, which is the lysocell. And they are all relatively equal in outcome. So the progression-free survival basically doubled, but you can also see still that there is room to improve. And although that now the progression-free survival, or at 5 years, or here it is at 3 years, is by 50%, that also means that 50% of patients, despite of CAR T-cell therapy, have a tendency to relapse. And what do we do there? Well, the answer is maybe antibody conjugates or some other treatments that follow this relapse at this time, or transplantation is not off the table. Now, this has been completely underestimated, I have to say, from even my perspective. The toxicity of the CAR T cells needs to be emphasized. And there are different ways of, you all heard about cytokine release syndrome and neurotoxicity and so on. But one point is also that the CAR T cells targeting CD19 not only kill the lymphoma cells, but they also affect your own immune system, because CD19 is expressed on the B lymphocytes, and therefore you ablate the B cell function, and with that the support of the T cells to cure and maintain you free from infections. So the reason why I'm saying this, these treatments are equally complex, and I say that by purpose, are equally complex than a donor-derived allogeneic stem cell transplant, and you should not do this in a private office or in the community hospital without having all the logistics and the expertise that there is. These patients are sick with neurotoxicity, with respiratory failure from cytokine release syndrome, and primarily completely underestimated the viral reactivations of viruses that we know of from allogeneic stem cell transplants, such as cytomegalovirus, adenovirus, HHV6, and you name it. I just have right now a patient in the hospital with CMV reactivation and adenoviral reactivation, with adenoviral encephalitis following CAR T-cell infusion. So that cannot be overemphasized. Now, the other effect that has not been recognized or has been early is if you give a CAR T cell with one marker, CD19 for example, and then as shown before, you relapse after 2 years, and you look at the tumor cells are not stupid, and we know this already, they don't regulate CD19. And so we have no choice to give a second CAR T cell of that magnitude. But here is the first in-human clinical trial with a dual specific targeting of a CAR T cell that I'm leading as a principal investigator here, as targeting CD19 and CD20 at the same time. That has been, we treated a few patients and it's very promising. We just have, because you're from Latin America now, just so you know, we just have an agreement with a few hospitals in Brazil that now send the patients here staying at this hotel for 2 months or 3 months for treatment, come down, we'll prepare the CAR T cells, we'll treat them, because in Brazil the CARs are not FDA approved and available, and that will hopefully help these patients to get the appropriate treatment. As it is on a clinical trial, that also entails a relatively improved financial background, of course. Now, transplant real quick, there are 3 issues that arise around allogeneic stem cell transplantation. The one is graft versus host disease, the other is infection, and the third one is relapse. So we do away with graft versus host disease because what we do here is, and you see this on this graph, you see the whole cell population that everybody has in the blood, and that is what you infuse with a conventional donor-derived transplant product. And what you really need only is the CD34 cell, which is the mother cell, the blood-producing hematopoietic stem cell, if you want. We can purify them in the laboratory by labeling them with a magnetic bead and then send them through a column that has a magnetic a magnet, and will select out the stem cells only, and all the T cells that are the ones that induce graft versus host disease get depleted, and we inject these cells and don't see graft versus host disease anymore. This is the conditioning regimen that I also modified. We got rid of total body irradiation for most indications. Patients with AML, MDS, myeloproliferative disorder don't really need total body irradiation at this high dose of 1,375 centigrade. We have a chemotherapy-only regimen that is very effective. Shown here, this is a selection of patients that are frankly transplanted, mostly in New York at Sloan Kettering, with AML, And you can see here in the wonderful progression-free survival with the CD34 selected transplant and chemotherapy only. It doesn't matter if you have a related or unrelated transplant donor, the outcome is equally well. And most importantly, you see here, there's 0 chronic graft-versus-host disease, and only, as shown here, 6% of acute graft-versus-host disease, which is at a grade 1 or 2. So that is significant, because also that most costly driven factor of an allogeneic stem cell transplant is the treatment of graft-versus-host disease after transplant. Those patients are on drugs, on prednisones and high-dose prednisone and other drugs that then only induce viral reactivation and infections, and all hell breaks loose, and patients are in the hospital for much longer than the transplant itself, and the costs just drive up. You can see there is no little graft-versus-host disease. In addition, we don't need to give immunosuppressive therapy after the CD34 selected allograft. These drugs have side effects on their own. Now, another proof of, it has been shown before, but I ask here in the landmark analysis, do patients with graft-versus-host disease have reduced relapse or not? And you can see the grade 0 or grade 1 graft-versus-host disease patients have the same relapse rate than grade 3 or 4. In other words, it's another proof that we do not need graft-versus-host disease to prevent relapse. I highly encourage you to forget about this statement, because this has been driven through all these years. Little bit of graft-versus-host disease is good for you. No, a little bit graft-versus-host disease is good for the doctor who has to explain why you have graft-versus-host disease. And there is no other effect that I would see is of benefit. Now, viral activations, cytomegalovirus were the driving factors for complications. That also needs to be revised now, because now we have prophylactic administration of letermovir, which shows you here that the reactivation of CMV in patients at risk for CMV reactivation dropped from 68% to only 7%. That's enormous. And those 71%, or 7.1% here have easily treatable CMV reactivation, which makes a whole difference before they had to go to the hospital for another 3-4 weeks of Foscarna treatment. Those days are largely over in the context of CD34 selected allografts. And here's the brand new one real quick, because, and you have to take some notes, because Dr. Ribas will ask you questions tonight at dinner. If you flunk the test, you have to pay for the dinner yourself. But here is what do we do for relapsed disease? Brand new, first in human clinical trial that I'm leading also. I'm proud to say that. But you see the 53% of relapse of leukemia after transplant is still an issue. Now, how do you treat these? Not so easy, because if you want to target leukemia cells specifically, you also run the risk to target normal cells that express the same marker. And therefore, what you need to do to create a treatment-resistant transplant product. How the heck do you do that? Well, we have CRISPR technology. CRISPR technology is gene editing of markers that you can silence and are not being expressed any longer on certain selected cells. And one of those markers is CD33. CD33, we know and have known, is highly overexpressed on acute myeloid leukemia cells, but it is also expressed on the normal hematopoietic stem cell. So if you now treat anti-CD33 with anti-CD3 agents, you will likely eliminate your bone marrow function by killing the hematopoietic stem cells. Now, here's what we do. CRISPR technology, silencing, as you can see here, the stem cell product is collected, CD34 cells are purified. This can only be done on CD34 purified stem cells, otherwise that product is way too big and comprehensive. You can go in with your Caspase-9, eliminate the expression of CD33 on the hematopoietic stem cell, and you have a CD33 negative, but CD34 selected transplant product. You can give this to the patient, and we did, I'll show in a moment. And obviously the question there, and then you can come in afterwards with specifically targeting CD33 on the leukemia cell, because the hematopoietic stem cell is negative for CD33. The first question, of course, is can we do this? Here, the first 7 patients that we successfully transplanted with this product, all high-risk AMLs, you can see on the left, TP53 mutated, very high risk of relapsing post-transplant. But most importantly, on the right, you'll see that the gene editing led to some I think the lowest was 80% to 91% purified CD33 negative hematopoietic stem cells. That's what we infuse into these patients. And the key question is, do we do any harm by preventing the counts to recover? And the answer is absolutely not. These are the median engraftment data for platelets on the for neutrophils on the left and for platelets on the right. Only 10 days and the neutrophils are back. Only 15 days and the platelets are back to normal levels, which is consistent with non-gene edited transplant products exactly. So when we then have the opportunity to give in these patients gemtuzumab, which you may remember is an anti-CD33 antibody, we could show that there's absolutely no effect on the platelet maintenance, the platelet count or the neutrophils. Interestingly enough then, and that's the final word to this one, is if we looked at the 81% gene-modified cells that we got in and treat with gemtuzumab, it went from 80% to 100% of negative cells. So what this means with the gemtuzumab post-transplant, then we'll eliminate the residual CD33 positive cell population within your blood, and we end up with CD33 negative cells only. And that indicates that we may have effect on the leukemia cells as well, because that's CD33 positive. So whereas the side effects are absolutely not existing, just no liver dysfunction from gemtuzumab, or no VOD, which has been a problem in the past. But here is now the real new one. This now allows us to have, and this is a new FDA-approved clinical trial for these patients post-transplant. We now have anti-CD33 directed CAR T cells from the same donor that provided the stem cells to eliminate residual disease and or treat for relapse post-transplantation. So it's a little bit too early. This was FDA approved. I have one patient on standby for treatment with this approach, but will likely allow us now to safely administer CAR T cells after allogeneic stem cell transplantation without eliminating the whole bone marrow function. So with this, just a quick overview of where we are and what we can do together, and pointing out that there are a lot of activities and new clinical trials and science going on. The complexity of this and the understanding is so rapidly evolving that I have my own seminar every year here in Miami at the Ritz-Carlton in Coconut Grove, and next year at the JW in Marriott, talking about immunotherapies and hematologic malignancies with the lead physicians from all over the world. And you're invited to come March 8 and 9. You will learn more details about everything that's going on there. And with that, I'll stop, and I think I'm right on time. Thank you.
Thank you, Dr. Koehne, for sharing really exhilarating research that is happening in the areas of stem cell transplant, CAR T cells, and adaptive immunotherapies. With that, we're going to move on to the next talk. Dr. Minesh Mehta is a world-renowned expert in radiation oncology, proton therapy, and cancer research. He serves as the Deputy Director of the Miami Cancer Institute and also is the Chief of Radiation Oncology here. Dr. Mehta got his medical degree from Zambia and then trained at University of Wisconsin, and then went on to be the chairman of the program there. He then moved over to one of his endeavors was setting up one of the most prominent proton centers in Maryland, which was, I think, the first and most robust program in entire Mid-Atlantic. We have been really privileged to have really succeeded in creating one of the most robust radiation oncology programs in the country under his leadership. He's also a great and well-known expert in brain tumors. But one of the other things that Miami Cancer Institute boasts is it has one of the most comprehensive radiation platforms that you'll find anywhere in the world. And so with that, Minesh is going to talk to us about comprehensive radiation therapy, uniting all modalities under one roof.
Thanks, man. Friends and colleagues, welcome to Miami. And several of you were able to do a tour yesterday. So you saw a whole bunch of machines and technology platforms. And today what I hope to do is to share with you on a day-to-day basis, practically, how we use this fleet for our patients, because that's what you're here for. Together, we take care of patients on a daily basis. And so what does this mean to our patients? That's the theme of my talk. As an overview, radiation oncology here is a world-leading facility with 12 radiation oncologists, who are all disease site specialized, and 24 medical physicists. As you can see, we have double the number of medical physicists relative to our physicians just because of the high technology platform footprint that we have. It is the most comprehensive technology footprint anywhere in radiation oncology, with a deep clinical research and clinical trial portfolio, with a national and international recognition and leadership, and impressive academic productivity. The goal of all of this is to change the outcomes for patients. So this is a snapshot, which is very busy, of all the different radiation technology platforms that we have. We started off with a handful of platforms that you see on the left-hand side of the slide. As of today, we have added 19 more platforms. This is a total of more than 30 different radiotherapy services. You can't find this under a single roof anywhere. But what does all of this mean? And I think the way to appreciate and understand that is to maybe take a journey through the eyes of the patients, because our best stories are told by our patients, and our best ideas come not from the laboratory, but from our clinical research teams who look at these patients every day. So let's do that journey using 3 patients as an example. This is our pancreatic cancer research team that uses a technology platform known as the MR-Linac, Dr. Michael Chong, Dr. Kate Mittauer, and Dr. Adil Kaiser. They have implemented an MR-Linac-based dose intensification radiotherapy program for an incurable malignancy, cancer of the pancreas. The national standards for unresectable pancreatic cancer with standard chemoradiotherapy and radiation yield 2-year survival rates of about 20%. This is a benchmark that has not been crossed in decades. In the last 7 years, using a highly dose-intensified, very unique approach with the MR-Linac device, our numbers stand at 50%. This is more than doubling of the national expectation, and a phase 3 randomized trial testing this concept is underway. For the patients, this is what it means. This is a patient who was treated here. As you can see, she became the topic of a newspaper story. The headline says she defeated inoperable pancreatic cancer through the most advanced radiotherapy platforms available at Baptist Health Miami Cancer Institute. This, of course, is our advertisement. What does the patient say? The patient says, there was no pain or discomfort at all. In fact, I felt nothing when the radiation was delivered. And this patient was actually sent to us by her medical oncologist at the Mayo Clinic in Arizona, who looked up the literature all across the country and told the woman, this is the place to go, because I don't think anyone can deliver a better outcome for your pancreatic cancer. So this is what implementation of technology can mean to a patient. Let's take a look at some of the work that's done by our Proton team focused on brain tumor research. I'm showing you 3 individuals, it's more than that. Alonso Gutierrez is one of our physicists. Rupesh Kotecha is our Doogie Howser. For those of you who look at US television shows, you'll get the analogy if you get to meet him. And I happen to just ride on their coattails. So let me start by giving an example of another patient. This is a young patient with a brain tumor that's circled in green. This is a very functional individual who came to her at her 4th recurrence. And we said, well, we're out of options. There's nothing we can do. It's time to go into hospice. She went onto a drug therapy regimen, which unfortunately did not work. And then she came back to us with her 5th recurrence, which you can see in the second panel. And once again, our answer was, there's nothing we can do. And her response back to us was, that's not why I came to Miami Cancer Institute. Figure it out. So we did. We developed a new technology called proton pulsed reduced dose rate radiotherapy, which is a technology that's not available anywhere else in the world. This is the only center that does this. And you can see her clinical response. This was the first patient treated with this technology. We now have a clinical trial. We have 7 patients on this trial, and they're all getting very dramatic responses. Early days were very impressive use of technology platforms. So technology is only as good as the driver behind the technology. You can put the race car in the hands of a truck driver, it'll drive like a truck. Or you could put it in the hands of a race car driver, and it'll perform very differently. Let me give you one more example. This is an example that comes to us showing the multidisciplinary nature of care that we provide. See Dr. Noah Coleman, who's our radiation oncologist who takes care of skin cancer patients. Dr. Jeffrey Young, who is a surgeon well known for head and neck and skin cancer work, and Dr. Vibha Chaswal, who's one of our physicists. They were confronted by this patient. This is an 89-year-old patient who came with squamous cell cancer of the scalp. This was heavily pretreated multiple times with surgery and prior radiotherapy. And in fact, this more than 6-centimeter recurrence had occurred within 3 months of a prior course of radiotherapy. The patient sought multiple opinions across the state and was basically told, you're old, you have a thin scalp. If we resect this, the scalp's going to fall apart. You've been heavily pre-radiated. This is never going to heal. You already had too much radiation. We can't radiate this. Just live with this. You can imagine the consequences of living with this. This is going to erode through the scalp and the skull, and this patient is going to die a horrible death. And so the patient showed up at our doorstep and said, find a solution. So this is my only physics slide. The solution lies in physics, in radium. Marie Curie, 1894, still relevant today. There is a new device that actually embeds radium within microbeads, exploiting the alpha decay chain of radium, which results in very short distance radiation that can be localized within tissue. So we can actually deliver tissue-specific radiation with no harm to surrounding normal tissue using this high energy, heavy alpha particle emitting isotope-based therapy. That actually requires a surgical operation and hence the multimodality approach to this patient. This requires a placement of numerous radioactive beads or seeds within the patient's scalp. And you can see that this is done layer by layer. And this is the seed implantation technique that is occurring. As you can see, it looks gory, it looks cumbersome, it looks complex. But that's the patient right after the procedure. This was all done under sedation and local anesthesia. He's giving you a thumbs up with the pineapple, as you can see, doing really well. That's the CT scan showing the seed implantation. The patient is now about 2 months out with a dramatic response to his lesion. So this is the use of innovative brachytherapy technologies to take care of disease and conditions that are otherwise unapproachable with standard techniques. Let me give you one more example. This is an example of lung cancer. Lung cancer is a lethal problem. Recurrent lung cancer gives lung cancer a bad name. This is a 71-year-old patient who came to us with stage 4 lung cancer with a rib metastatic lesion who had already progressed on 3 cycles of chemotherapy and unfortunately had few options left for them. This patient was enrolled on a clinical trial that we were running here, which uses a device that produces low voltage electricity. This is an electrical field therapy approach, and the patient was enrolled on this trial. It's known as the EF24 trial, and received a chemotherapy drug, docetaxel, with the electric field therapy, also known as TT fields therapy. This was on a clinical trial that Dr. Rupesh Kotecha, who's our thoracic radiation oncologist, led here at the Institute. We accrued the highest number of patients in the country, and at the ASCO meeting this year, the overall survival benefit in stage 4 metastatic non-small cell lung cancer from this trial was presented, which is practice changing and will likely garner FDA approval as a new modality to treat lung cancer. So not only do we implement technologies, but we bring them to phase 3 clinical trials and to FDA approval. I want to end by sharing with you some innovative science that we bring to the table by using clinical observations. This is work done by Dr. Michael Chong, who leads our GI program in radiation oncology. He came up with the concept that radiotherapy can be used as a vaccine to stimulate the immune system. And to test this concept, he designed a clinical trial in which patients who are receiving immune checkpoint inhibitor therapy and have become resistant to that therapy come for more clinical options. They have to have at least 3 lesions, and at the first pass, 1 lesion is radiated. And you can see that in the first column, first row. This lesion in the liver receives 40 gray in 5 fractions, and as you can see, the lesion disappears. You see a very nice response. A week later, or 2 weeks later, the patient comes back, and a second lesion, which was not previously irradiated, now gets irradiated. That's this lesion here. It's a rib lesion that got 30 gray in 5 fractions, and that also disappears. That's not surprising. This is stereotactic body radiotherapy technology application for focal disease, and we do see this quite often. But what is really surprising is that this patient was on an immune checkpoint inhibitor, which was continued. And the third lesion was deliberately left untreated, but that too undergoes a complete response. In other words, we can reactivate the immune system by causing release of neoantigens by using ablative radiation technologies. So radiation now becomes a vaccine. So this is vaccine dose number 1. This is revaccination, boosts the immune system, and voila, the therapy that had stopped working now starts working once again. We also do technology development in terms of device generation. And if I can get this movie to play, which I guess I cannot. Can you make the movie play from your end? It's a button at the bottom of the slide. Thank you, right there, yes. So what you see here is a little device that's moving up and down, and you can see an X-ray film here. This is our proton machine in the clinic that you saw yesterday. This is Dr. Gutierrez, our physicist, who's responsible for leading the team that has built this device. This is a shaping device. So this is the first dynamic proton collimation system in the world. It's still at an experimental phase. And as you can see from this kidney bean shape dose, we can actually shape the radiation effectively. This could change the way proton therapy is delivered in the future. So clearly what you're seeing is not just clinical development, but also development in the world of physics. We do all of this for a very simple reason. We believe that our research will change clinical practice, and changing our clinical practice changes outcomes in patients. And that teaches us lessons to do more and further future research. So our goals are very simple: to improve survival, to palliate better, to prevent recurrence of disease, to improve the quality of survivorship, to improve functionality, to address disparities in our patients, and drive practice change. So with that, I thank you, and thanks for visiting us once again.
Thank you, Manesh, for sharing some truly transformative work that you and your team are doing. And I think that's why patients like to come to comprehensive cancer programs like that we have here at Miami Cancer Institute. They're looking for a second chance. And in some of these cases, their third, fourth, or maybe their last chance. But it's really remarkable with the power of technology, innovation, that we can truly transform the outcomes for these patients. Now we would move on. Now the next 3 talks are more surgical talks. And so first off is going to be Dr. John Diaz, who serves as the chief of the gynecological oncology program here at Baptist Health Miami Cancer Institute. He also has real expertise in robotic surgery and leads that program as well for Baptist. Dr. Diaz was trained at University of Miami for his medical school, did his residency, and then went on to do a fellowship at Memorial Sloan Kettering Cancer Institute, where he's had a number of awards. He's highly published, highly coveted, great researcher, exemplary colleague to work with, always answers the phone call when you reach him. That goes true for all of our physicians here. Dr. Zinner makes sure that our cell phones are available for our colleagues and our referral physicians. Dr. John Diaz is going to talk to us today about advances in the treatment of gynecological cancers.
Thank you. Good morning. Thank you for having me, Dr. Ribas and the international team. Thank you for inviting me to talk about advances in the treatment of gynecologic cancers. It's really an exciting time in the world of GYN malignancies. And then they told me I had only 15 minutes to talk about this. So I'm going to do my best to get through this. This is our team, the Division of Gynecologic Oncology for Baptist Health Cancer Care. We're the largest division of gynecologic oncology in the state of Florida, and I'm very proud of the team that we've assembled here. So I'm going to start off with endometrial cancer. Uterine cancer is the most common gynecologic cancer in the developed world. There are over 66,000 cases in the United States, and that number is growing. Reason being is one of the risk factors for this is age. We have an aging population. And another risk factor is obesity. We have an obesity epidemic in the developed world, and we're seeing this now in Latin America and the Caribbean as well. The numbers of uterine cancer are increasing in these areas. Perhaps the biggest impact we've had in this is the role of immunotherapy. And this started back in 2017 when pembrolizumab, a PD-L1 inhibitor, was approved for the treatment of MSI-high endometrial cancers. And that's about 30% of endometrial cancers. And this was a great game changer that we saw in this. And shortly thereafter, we opened up our own phase 2 trial looking at pembrolizumab in those patients who didn't have an indication for that. And like anything, we try in the patients that are heavily pretreated in the recurrent setting, but we started to move this up. And I said earlier, only about 30% of patients would qualify for treatment for this. So we looked at how can we turn these cold tumors, that's 70%, into hot tumors. And we did this by combining immunotherapy with a TKI inhibitor called lenvatinib. And so now 70% of our patients could benefit from immunotherapy. And this has now been brought up to first-line treatment. In fact, this year at SGO, we had 2 trials, randomized phase 3 trials, looking at similar ideas, combining immunotherapy with traditional platinum-based chemotherapy in the upfront setting for advanced or recurrent endometrial cancer. And this completely changed the way that we treat endometrial cancer today. So one of these trials was the NRG-GO18 and the Ruby trial, which we had open here. Again, these were advanced endometrial cancer patients who were randomized to traditional chemotherapy with placebo or traditional chemotherapy in the Ruby trial with dostarlimab, another PD-L1 inhibitor. And you can see here, both in the MSI high population as well as in the overall population, a significant improvement in progression-free survival for these patients. In that same meeting, we presented the Keynote 868 study, again, looking at combination chemotherapy with pembrolizumab, both for maintenance therapy compared to placebo. And again, you saw this benefit in progression-free survival. And that same day, published both these papers in Journal of Medicine and completely changed the landscape for uterine cancer. And so this is kind of our cheat sheet. Every week we have a tumor board where all of the G1 oncologists, our radiation oncologists, our oncoradiologists, pathologists, geneticists get together and review each new cancer case presented here at MCI. And this is our cheat sheet for the management of advanced endometrial cancer. You can see it's very complex. We have the options of chemotherapy in combination with radiation therapy, immunotherapy, HER2 inhibition, VEGF inhibition. And so each case gets individually reviewed by all of us, and our treatment recommendations are guided by this. So the future trials for endometrial cancer include looking at combination, as I said before, combining PD-L1 inhibitors with TKIs to overcome this cold tumors and turn them hot. Looking at immunotherapy with PARP inhibition. This new class of drug, antibody-drug conjugates, which I'll talk a little bit more with ovarian and cervical cancer. And looking at molecular-directed therapy, HER2 new inhibition, T53, and hormone receptor therapy. So it's a really exciting time, and we're changing dramatically the way we treat endometrial cancer in 2023 than we did only a few years ago. But there are also advances in surgical techniques. Endometrial cancer now is treated by minimally invasive surgery. This is the standard of care, and this was proven in the LAB2 trial that GOG performed, where it showed no difference in lymph node counts, no difference in survival rates, but an improvement in lengths of stay, less blood loss, less complication rate, a quicker return to normal activities. And now from traditional laparoscopy, we've moved to robotic surgery, and this really is the standard. Baptist Health South Florida has completed over 64,000 robotic surgeries, making us one of the top centers in the entire country. In fact, South Miami Hospital, one of our hospitals here, is one of the top 20 institutions for robotic surgery in the entire United States. And so we're very proud of this program, which is not only limited to multi-port therapy with the Intuitive, but also orthopedic surgery. So we have a very robust robotics program here. And this goes on now to lymph node evaluations. I published one of the first papers looking at sentinel lymph nodes in GYN malignancies. This was over 10 years ago. And the thought here is you inject the target organ. With the robotic platform, we can then toggle from white light to this near infrared. And you'll see there the green lymphatic channels that lead to this lymph node. I'll toggle back here now to the near infrared. And you can see that shows you that green lymph node, that's the sentinel lymph node that you remove. This greatly improves our ability to identify those lymph nodes. It decreases morbidity for patients, and it improves detection rates. So this is the SELECT trial, which we participated in with Memorial Sloan Kettering and the Mayo Clinic. It's a 2-part trial, and we're the second largest accruers looking at this sentinel lymph node algorithm in the treatment of endometrial cancer. Ovarian cancer. Ovarian cancer is the second most common GYN cancer in the United States, but it's the deadliest, and we've really struggled to improve outcomes. But there's an article just published this month stating an improvement in overall survival in women afflicted with ovarian cancer, and this has been driven by maintenance therapy, particularly PARP inhibition. And although PARP inhibitors have been around now for a few years, I think it's important to go and understand this radical change in the way that we treat ovarian cancer. It used to be you got diagnosed with ovarian cancer, 85% of women were in advanced stage. Unlike other diseases, it responds really well to chemotherapy. So we're able to put women into initial remission. Unfortunately, about 85% of those women will recur, and that usually happens at about 12 months. So we've always been looking for how do we extend this disease-free interval. And in fact, we used to use dose-dense maintenance Taxol, and that actually worked really well, but it was very toxic. So in 2011, that paradigm shifted. We started to use VEGF inhibition with bevacizumab, and that improved our outcomes. And then 2018, we introduced PARP inhibitors, specifically olaparib. And now today, every woman with ovarian cancer should be offered some maintenance therapy. It improves their outcomes. The question is which way to go. So all women with ovarian cancer should be offered genetic testing, and their tumor should also be evaluated. About 50% of women with newly diagnosed ovarian cancer will have some kind of biomarker indicating which type of maintenance therapy they could benefit from. So the SOLO-1 trial was the first trial looking at PARP inhibition. These were women with advanced ovarian cancer who had a known germline BRCA mutation. In other words, they could hereditary pass this down to their family members, or a somatic mutation. That's where the tumor itself had this mutation. And in those women that were given olaparib versus placebo, you saw a dramatic increase in their progression-free survival. We actually started to look at potentially curing women with advanced ovarian cancer. We had never seen anything like this before in ovarian cancer. We then had the Apollo-1 trial, and this actually was an investigational trial in France where bevacizumab was standard of care for maintenance therapy. So these were women who had a biomarker for using PARP inhibition. So again, they were HRD positive. And these women were randomized to either bevacizumab maintenance therapy with VEGF inhibition or the combination of PARP inhibition with olaparib and bevacizumab. And you saw again here a dramatic improvement in progression-free survival. We then had the PRIMA trial. This again is looking at advanced ovarian cancer. This was a different group of women that had kind of a worse prognosis. These were the ones that we couldn't really optimally debulk. They were at a higher stage, and more of these women didn't have a complete remission at time of completion of their chemotherapy. But we saw by adding niraparib, another PARP inhibitor, to their maintenance therapy, we had an improvement in their progression-free survival. And so that's why I say every woman now diagnosed with ovarian cancer should be offered some form of maintenance therapy. And this is kind of the decision tree you have to go to when you see these patients. First of all, are you going to proceed with a primary debulking approach? The goal is to remove all of the tumor, or are you going to proceed with a neoadjuvant chemotherapy approach? After that, you need to decide, are you going to add bevacizumab to the treatment of these women? And if you do, once you get to that complete response or a partial response at the end of chemotherapy, which maintenance therapy are you going to proceed? If you use bevacizumab, then you have the option of bevacizumab or adding a PARP inhibitor based on their biomarker. If you elected not to proceed with bevacizumab, then you have the options of, again, different PARP inhibitions with biomarkers, but every woman should be offered maintenance therapy. And this has dramatically improved the outcome in ovarian cancer. It's the first time we've seen this in over 20 years in the treatment of this disease since the use of Taxol. Despite these advancements, we still know that many of these women will recur, and once they become platinum resistant, we have limited options that are effective. But something that's really been exciting in cancer research are these class of drugs called antibody-drug conjugates, and it kind of works like a Trojan horse. They have different receptors to bind to the cancer cells. Interesting in ovarian cancer is a receptor against folate alpha, and about 85% of platinum-resistant ovarian cancers express this, so it binds to this cell. The cancer cell then brings in this new drug and then delivers its drug in there, eliminating this cell as well as the neighboring cells. And so the first drug to be approved was mirvetuximab, and this was a SORAYA trial that was presented 2 years ago at SGO. The next drug that's now interesting is this drug called Sotriro-002, and actually we were part of the phase 1 trial for this drug, which was just presented at ASCO a few months ago, and the response rates were very encouraging. We're now moving forward with a phase 3 trial, which we hope to open here by next week, actually. And so this is a class of drugs that's really changing the treatment of ovarian cancer. It's offering a lot of exciting. When it comes to surgery for ovarian cancer, we continue to look at innovations, either with HIPEC chemotherapy. This was a randomized controlled trial from the Netherlands, demonstrated the benefit, both progression-free and overall survival, in adding HIPEC to the upfront surgical management of these patients. And in fact, we had a phase 2 trial that we did with Sloan Kettering, demonstrating our experience with this, with the feasibility and safety of adding HIPEC to aggressive steroid-reductive surgeries. And this is now gaining additional traction throughout the United States. And in fact, the GOG is performing their HOT trial, but only at select centers. And we were selected as one of the centers to run this trial. So the GOG 3068 will be open here, where we'll be incorporating HIPEC into the upfront treatment on a clinical trial. So futures for ovarian cancer research, again, novel combinations, immunotherapy with PARPs, VEGF inhibitions, ADCs, as well as traditional therapies with novel biotherapeutics. Biomarker-driven therapy, and again, looking at immunotherapy. Ovarian cancer has been challenging. How we turn these cold tumors hot. So I'm going to finish with cervical cancer. Cervical cancer is uncommon in the United States. Only about 14,000 new cases a year in the United States, but we know that in Latin America and the Caribbean, this is still something that you encounter much more frequently than we do here. And one of the biggest breakthroughs we've had recently is in the treatment of advanced or recurrent cervical cancer. Keynote 826 looked at using traditional platinum-based therapy with the addition of immunotherapy. Now, you had the option based on your clinical practice to use bevacizumab, and about 70% of women in this trial did receive bevacizumab, and you saw when you included immunotherapy, there was an improvement in progression-free survival in these women. Again, these are advanced stage metastatic cervical cancer. Most of these women died from this disease, and we're actually starting to see some cure with this combination. So this was a huge breakthrough in the management of cervical cancer. The other big breakthrough came at the time of recurrence. Unlike ovarian cancer, where a patient will see multiple lines of chemotherapy, cervical cancer patients don't do well. By their second or third line of therapy, that's probably the last time that they're gonna have ability to be treated. And so this new antibody drug conjugate called tizotumab vedotin, which was the first antibody drug conjugate approved for GYN cancers, and we had the clinical trial open here, looked at a great improvement compared to traditional physician choice use of chemotherapies. Now, with these new drugs comes a new concern, which are ocular toxicity, something we as GYN oncologists really didn't know much about. I can't remember the last time that I looked with an otoscope at patients' eyes. There's a great concern that this ocular toxicity, but really when you look at it, less than 1% of women experience a grade 3 or higher toxicity. So it's about educating our patients about the use of some of these eye drops, both before, during, and after treatment, and we manage these patients in combination with optometrists or local ophthalmologists. The other big thing that happened was the role of surgery in cervical cancer. So my good friend Pedro Ramirez did a randomized controlled trial looking at minimally invasive surgery for cervical cancer. And much to our shock, that trial demonstrated that minimally invasive cancer was worse for patients. Now, most of the patients who were treated in that study had a laparoscopic approach. And so when we looked at the data, we had to decide, how do we change our technique? And so this was a modified technique that I developed where you can still do the robotic hysterectomy radically robotically, but then you come in with a robotic stapler and you staple across the vagina. And so what this does is this now encapsulates that cervical tumor within a wall of the vagina so that at no time is this cervical tumor exposed to the peritoneal cavity. And that's one of the thoughts of how we had this worse outcome when you're doing this through a traditional laparoscopic approach. So we come in here with a robotic stapler, we staple across the vagina. We then incise the staple line in the vagina. We're now able to deliver the radical hysterectomy specimen through the vagina at no time exposing that cervical cancer to the peritoneum. And we believe that this is going to have improved outcomes. In fact, the GOG is now doing the ROCK trial, which is a robotic trial looking at cervical cancer. And it's looking, again, open to radical robotic hysterectomy. Both times you have to use some kind of tumor containment, and our technique was one of the techniques that was used. And again, due to our expertise, we were selected by the GOG as to one of the centers to be able to open this trial. So in conclusion, it's an exciting time in GYN cancer. It's never been so exciting. We have novel therapeutics to help improve the outcomes from our patients. We have novel surgical techniques, including robotics, and less radical surgery. We kind of borrow this a lot from breast. We don't have to be so radical in the treatment of this disease, which results in less morbidity, and a tailored surgical approach. Not every woman needs a full lymph node dissection. In fact, very few do. So we're improving outcomes for women, and I want to thank you all for your attention and time today. And I came in just in time. Thank you.
Thank you so much, Dr. Diaz, for an eloquent talk. And I think the take home is that we are getting better. We're getting distinctly better how we are recognizing cancer, how we are taking care of cancer with some of the smart drugs, designer drugs now. Dr. Diaz talked about those Trojan horses, where we are just delivering chemotherapy to the cancer cell. Previously, we used to give chemotherapy, and as a result, our patients would have side effects in terms of nausea, hair loss, and other things, because anything that was rapidly dividing would get killed by chemotherapy. But now we're getting very specific. And one of the other things he highlighted was the biomarker-driven trial. So here at Miami Cancer Institute, we have actually partnered up with Caris Life Sciences, which has the most robust whole exome and transcriptome analysis to understand what are the genetic drivers of cancer, so we can pick the best trials or the best drugs for our patients. Dr. Diaz also talked a lot about some of his exemplary work he and his team are doing in robotic surgery. So moving on the robotic theme, I would like to invite next Dr. Manoharan, who serves as the Chief of Urological Oncologic Surgery and Director of the Robotic Urology Surgery Program here. And as you know, these are highly accomplished physicians, but Dr. Manoharan actually has been trained in 3 continents, which actually started in India, and then he went on to Australia, to get further training. And then he went on to the Royal College of Surgeons in England for fellowship training. And then he came over to the United States. So this is the fourth continent he actually trained in. And he's highly coveted researcher, speaker, has spoken in pretty much all the continents except Antarctica, I'm presuming. But he's going to talk to us today about surgical management of prostate cancer, some of the recent advances. Thank you.
Good morning, everyone, and thank you very much for the kind words, Manmeet. And I have nothing to disclose. And as you all know, prostate cancer is the most common solid visceral cancer among American men, and about 250,000 patients are diagnosed with prostate cancer every year, and about 30,000 patients die from the disease every year. I have about 13 minutes to talk, so I'm going to touch upon only 2 or 3 things which we do at Miami Cancer Institute and Baptist Health. And I want to start with the basics of the prostate, mainly from the perspective of the patient. And as a surgeon, I call the prostate as a user-unfriendly organ, similar to a pituitary gland. It's located deep in the pelvis, and any direction you go around the prostate, we get into trouble. For example, if you go to the apex of the prostate, we have the sphincter, you can become incontinent. The base of the prostate is the bladder, neck, and the urethral orifice. Behind the prostate is the rectum. I don't want to make a hole there. And when you go to the sides of the prostate, you have the nerves for the erections. Obviously, you don't want to hurt that. So any direction I go around the prostate, some difficulty is there. And the prostate effects from patient's perspective is that many people believe that it has got something to do with the sexual function and erection. In reality, prostate has got no role in erections or sexual function. And they also think they're related to the production of testosterone and sperm production. The prostate has got nothing to do with this, but the only thing it does is that it produces certain enzymes which will liquefy the semen when you ejaculate so that the sperms can swim away and fertilize the egg. That's the main role of the prostate. And when you deal with the prostate cancer diagnosis and screening, on one hand, you do not want to over-investigate and over-diagnose the cancer. On the other hand, you do not want to under-investigate and miss the opportunity to cure the cancer as well. So what is the problem? Because most of the patients with localized prostate cancer, they are totally asymptomatic. So most times they go to the primary care and they get the PSA blood test, the prostate-specific antigen, which is elevated, then they are subjected to further investigation. Occasionally, you can do rectal examination, find a nodule as well. You have a plethora of investigations like a blood test and genomic testing, whom to biopsy, whom not to biopsy, when to treat, when to offer salvage treatment. We have a number of new things like a PSA 4K test, ISO-PSA decipher test. At Miami Cancer Institute, we offer all these things to select the patients correctly, whom to offer biopsy, whom not to offer biopsy. But the most important development in the last 10 years is the multi-parametric MRI of the prostate. The important thing is to do a 3 Tesla magnet and do it in a particular way. And this is done in many big centers across the thing. And Miami Cancer Institute, we do a number of multi-parametric MRIs, which are very, very useful. No imaging test is perfect, but MRI of the prostate very rarely miss a very significant cancer. So when I do an MRI, you can see a lesion, the anterior aspect of the midzone of the prostate in this particular slide. And this had lesion 8 prostate cancer. MRI does 2 things for me. One, it shows the lesion, helps me to decide whom to biopsy or not. But more importantly, it allows me to do what is called as a MRI fusion biopsy of the prostate so that I can selectively and precisely biopsy them. What happens here is that we get the MRI done, then using the computer software, we create a 3D model and superimpose in the ultrasound. And during the procedure, I can get a 3D model. And then I have a biopsy needles, which has got a tracker like a GPS system. It allows me to track the needle and precisely take the biopsy from the lesion. This allows me to diagnose it, not to miss a cancer. And the yield of the biopsy is much better, and you can diagnose the patient more accurately. And at MCI, we almost do 400 to 500 MRI fusion biopsies every year. And this has changed the way we diagnose it, and we also less underdiagnosis happens. The next thing I move on is the robotic surgery, which Dr. Diaz talked about. And as you know, surgical robot is not a machine. It is an intelligent information system with arms. We have multi-port robot, we have a single-port robot. Those who have not been exposed to the robot, it is a master-slave system. We have a console where the surgeon sits in the console, he's a master, and the robotic arms are the slaves. I have about 6 degrees of freedom to move the arms, and being a machine, unlike human, they don't have tremors, it's a tremor-free, and I have a huge magnified prostate or any other structure, and we have a 3D vision. With that, I can improve the surgery with precision accuracy, and it actually makes the surgery better and easier for the surgeon. And this is the way the setup in the OR. But I want to specifically talk about, very briefly for 2 minutes, about the robotic radical prostatectomy. The main reason, like people think that acceptance for the robotic prostatectomy is the improved cancer control, early return to activity, urinary continence, and sexual function. But the studies have shown that what is the important thing for the patient is a sexual function preservation. And the studies clearly showed that the nerve-sparing prostatectomy is the biggest benefit of robotic surgery and the major reason why patients prefer and choose robotic surgery over traditional removal of the prostate. And I just want to show you 2 quick videos, 1 minute each, to show the advantages of robotic surgery. When I do open surgery, when I go deep into the pelvis, many times I can't see very well. I do many things blindly, and there's a bleeding and a blunt dissection. Here you can see that I'm very deep in the pelvis. I'm behind the bladder and in front of the rectum, but because the camera is so advanced and I'm close to the structure, I'm able to see it very well. These robotic arms, like the tip of the instrument is only 1 millimeter, and the exposed instrument is only 7 to 8 millimeter in size. I'm able to see every single fiber and everything else. I'm inside the peritoneum, and now I'm going to go behind the bladder and the prostate, and you can see that the moves are really gentle, and it's a very fine surgery. And little by little, I can advance further with very minimal bleeding. If the same thing I'm doing with the open surgery, I have to do it many times bluntly. I have to bend down, the vision is not clear, and you can encounter bleeding, and we can get with the rectum and the wrong planes. Whereas in this particular thing, and very, very clearly I'm able to see them, and right now you're able to see the vast difference in seminal vesicles. The retractor with the suction is on the rectum, and you can see the very fine dentalized fascia, and you can see them. I can actually incise that. I can go further all the way up to the apex of the prostate, which is the main part of the surgery. So the whole procedure is done with a clear vision, with minimal bleeding, and also, even though it looks slower, it's actually very quickly, can move further up, and this is the dentalized fascia, and I can make a quick incision and without hurting the rectum. And that is the main advantage of the robot in performing a robotic prostatectomy. The second thing is important for us is the nerve sparing. The nerve bundles for the erectile function are very close to the prostate. You can't even see them very well. And with the robotic surgery, now this is the prostate. You don't even see the nerve bundles. The left side is the prostate. And with the robotic arms, with a very gentle and fine moves, you can gently tease them, and suddenly you'll be able to see the bundle, which can be separated. Now you're starting to see the bundle, and very fine moves. And I make only little moves. I don't use electricity or diathermy because you don't want to hurt the nerves. And now you can see that with the very fine moves, I'm able to separate the nerve bundles away from the prostate. That allows me to remove the prostate completely without affecting the nerves. And the moves are very, very small and gentle, and the bleeding is almost very minimal. Now I'm separating the nerve bundle, which is important for the sexual function, and clipping the blood vessels supplying the prostate. I don't use diathermy, and we cut the bundle away, and then the bundle is now, in a minute you'll be able to see the bundle is completely separated from the prostate, and thereby you are able to protect the sexual function. That is the nerve bundle. One on the left side is the prostate. I just want to give a sampler to tell you the advantage of the robotic surgery. And at this point, as you know, we opened up the MCI in December 2016. At that time in Baptist, we had done about 16 robotic prostatectomy. At this time, I want to thank Dr. Zena and leadership for supporting and goodwill and confidence they had in us. With that help, we are able to increase the number of radical prostatectomy we've done over the years. In 2023, we have performed so far about 256 robotic prostatectomy, where we started with 16 despite the COVID, with a better experience for the patients and outcome as well. And I'm grateful for all the support. The next thing I want to bring it up is the ablation therapy, which we perform at the MCI. And ablation means in situ destruction of the tissues using some energy. You can either ablate one half of the prostate, called as like a hemiablation, and preserve the other side in the nerve bundle, or you can even ablate the 3/4 of the prostate and preserve one nerve bundle. But what is more common these days is the focal ablation, where we destroy the cancer tissue and a little bit of a normal tissue around it, but protect the sphincter, the urethra, and both the nerve bundles, which is called as a focal ablation. But focal ablation is not suitable for everybody. You need to choose the patients wisely and correctly, and for the right patient, the ablation offers all the potential benefits of treatment while minimizing the side effects. And we can use a thermal or a non-thermal energies. Thermal energies, you can use ice to cryotherapy or heat it up like a HIFU or a radiofrequency ablation. In a non-thermal thing, the most common thing is the irreversible electroporation or a nano knife. We can use photodynamic therapy, and as Dr. Minesh said, we can use a stereotype ablation, brachytherapy or a focal brachytherapy can be done as well. At Miami Cancer Institute, we offer all of these things, particularly the HIFU and the nano knife and the radiation as well. I want to talk briefly about 1 minute about the nano knife for irreversible electroporation in prostate. In nano knife, we send low impulse, electric pulses with high voltage through the tissue, through the cells. What happens is that the intact cell membrane, we create multiple small micropores. When you make a micropores in the cell membrane, the cell leaks and the cell dies. That is the basic concept of nano knife. And in this particular thing, this is from a liver hepatocyte. It's a single cell with electron microscope. On the left side, you see the normal cell, but once you've done the IRE, you can see the micropores and the cell leaks and the cell dies. That's how it happens with the nano knife treatment. What happens here is that we have a small machine. This machine is very portable. You can take it to different operating rooms and different hospitals. The needles are similar to any other cryotherapy or ablation needles. And in this particular thing, what the advantages are, once you place the needles, it might take some time for certain specialties. For us, it's easier. The procedure itself is quick. It's about 5 to 7 minutes procedure, and the patients can go home same day, and there is no incisions as well. And if you put the needles correctly, any tissue between the needles will get ablated. It's very, very reliable. But what is more important is that the prostate structure is not damaged, meaning if the patient recurs, we can always perform a radiation treatment. We can always perform a radical prostatectomy again as if nothing has been done. That is the biggest advantage. And when I have this, like a tumor, like an eggshell, I place about 4 needles around it, 1, 2, 3, 4, and we send electric impulses between the needles, which allows to destroy the tissues completely all around. Once that is done, the entire the cancer cells and the normal tissue around it is destroyed, and the needle is removed, and the patient can go home after that. So moving on, I got about a minute or two. The prostate cancer, the complications, I wanted to bring up one topic. As you know, the most common and important complication is this, right? But however, with the robotic prostatectomy, the advances in the last 20 years is really it's important. And the urinary control is significantly improved. And currently in 2023, the patients, if I see them in 3 months, 6 months, or 1 year, the pad-free rates are 98%. It was 85% about 20 years ago. Now it's 98%. But it depends on the patient, the surgeon, and the skill sets and how the surgery is done. Similarly, when you do the potency test, the studies from different centers have shown that if the patient is potent before, if you do the nurse pairing, these are the numbers. But I want to bring up something for the patient's sake about the sexual function. A lot of people think that if you lose the erections, your sex life is done. But that's not true at all. We need 4 different things for sexual function. One is if you're cancer-free, your sex drive and libido and confidence will be great. Once you have a sex drive, you need to get stimulated by touch, by vision, by radio, whatever it is, and those nerves are not affected. But the erections, if I hurt the erections by surgery, radiation, ablation, let's assume that patient's got no erections at all, but still the orgasmic nerves are elsewhere, and so their orgasm, ability to have climax, and sexual pleasure are not affected. Out of the 4 things, only one is effective, is the erections, and the erections can be fixed by medication, by injection therapy such as Trimix, pumps, and the prosthesis. And we offer all these things at Miami Cancer Institute and Baptist and give the erections back to the patient and make them cancer-free. That allows them to have a better quality of life. And the future-wise, we have a number of new things like amniofix, lipogem, stem cells. In the next 10 years, we might get a 3D bioprinting of the sphincter or the nerve bundles as well. So with all these things, the idea behind it is that to offer effective treatment for every single stage of the disease, cure the disease, control the disease, at the same time provide a good quality of life for the patient. Thank you very much for your attention.
Thank you so much, Dr. Manoharan, for sharing all the really, truly transformative work you and your team are doing. Obviously, the theme here is we are in the era of precision medicine, precision oncology, and now you can see precision surgery, right? How every millimeter is extremely important when you deal with nerves which are involved with important functions of the body. So moving from the most common cancers now in males, which is prostate cancer, to now the most common cancer in the females, which is breast cancer. We're going to hear from Dr. Jane Mendez, who's the chief of breast surgery here at Baptist Health Miami Cancer Institute. Dr. Mendez received her medical degree in Mount Sinai, New York, completed a residency in surgery there as well, followed by a fellowship at Memorial Sloan Kettering. So actually, Memorial Sloan Kettering is a theme here. We have a lot of fellowship-trained people from Memorial here on the podium. She's been given a number of awards. She's worked with a number of foundations and is a very big driver of the breast surgery program here. And a lot of you know her here in the audience. I interacted with several of you last night who've worked with her. She has a very big footprint in Latin America and the Caribbean. And with that, Dr. Jane Mendez is going to talk to us about breast cancer beyond biology and challenging dogma.
Good morning. Thank you for Dr. Ribas and Dr. Hakim for inviting me to be here this morning. Buenos días. Quiero darle las gracias al Dr. Ribas y al Dr. Hakim por la invitación de estar aquí con ustedes esta mañana. So I'm going to be talking this morning about breast cancer being biology and challenging dogma. It's going to be a whirlwind because they only gave me 30 minutes and I cut the presentation as far as I could, but here I go. Put your seatbelts on. So here we are. A lot of you got to tour our facility yesterday, and it's a beautiful building. But what most important is what happens within that building. And over the past 6 years, we really built a very strong breast program. So I'd like to talk this morning about the breast cancer burden worldwide, discuss the importance of the multidisciplinary approach to breast cancer and individualized care, and then talk about some of the challenges that we still have pertaining to breast cancer. Every 2 minutes, a woman is diagnosed with breast cancer in the United States. And even worse when you think about it in the world. 1 of 8 women will be diagnosed with breast cancer. We know that the African-American women have 42% higher mortality as compared to Caucasian women. And it is the most common cancer in Latin American women. As cause of cancer is the #1 cause of cancer death in Latino women. In other words, 99% of the cases occur in women. And a good problem that we have now is that there are 3 million survivors in the United States and more so worldwide, secondary to all the advances, the technology, and the research that we have available these days. And it does not matter where you are in the world. Breast cancer accounts for anywhere between 19 to 28% of cancers around the world. And unfortunately, depending upon where you are treated or diagnosed, that's what determines your outcome. If you're in a well-developed country, we expect 80% survival rates, whereas if you're in underdeveloped country, we expect more like 40% rate. And I don't need to tell this audience about the factors contributing to that, having to access to cancer, technology, education, et cetera, et cetera. So obviously, this is another graphic chain, showing similar data worldwide, Central America, South America, and the Caribbean. So it does not matter, and I'm sure all of you have experienced this, when somebody feels a mass in their breast, a woman, it's a sense of urgency and anxiety. They wanted things done yesterday. But as clinicians, insurance, and brokers, we have a fundamental task, determining whether it's a benign lump or this is something malignant. That is our task. And in order to do so, obviously, we've had significant advantages over the past 50 years. It started with very radical procedures of radical mastectomies. Then we modified the radical mastectomy to lumpectomy, so now sentinel lymph node biopsy. It's been a combination of clinical trials that led to us today. The forefathers of modern breast surgery, Dr. Fisher and Dr. Baronesi, in the United States and England, respectively, challenging the dogmas to take us where we are today. And we couldn't be where we are today, where if we have a stage 1 breast cancer nowadays in 2023, we expect 99% survival rate at 10 years. And it's secondary to the incredible multidisciplinary approach to breast cancer. I couldn't do my work as a breast surgeon without help from my medical oncologists, my radiation oncologists, the plastic surgeons, the pathologists who sit behind closed doors, telling us what we need to do for those tumors. And certainly all those other ancillary services that we also provide, genetic counseling, psychosocial issues, exercise, nutrition, that are vital to these survival rates. And you know, the paradigm keeps changing. Sometimes we get chemo before surgery. Sometimes we get chemo radiation before surgery. Sometimes surgery goes first. So it really is a complex set of interactions trying to determine what's best for that particular patient. As we've started to understand a lot better the biologic heterogeneity of breast cancer. There's not just one type of breast cancer, there's myriad and many multiple types of breast cancer. And it is our job to try to see what's best for the particular cancer the patient has. And we've discovered many targets over the past 50 years. We have the ER receptor as a target. We have the HER2 receptor as a target. That's allowed us to really improve our outcomes while we minimize the treatment, and certainly the genetic explosion of information. Since the Human Genome Project in 2005, we've been able to see many genetic mutations that are associated with breast cancer and understand much better the impact it has in the biology. So we move from histologic markers now to genomic profiles that really help us determine the best treatment for the patient and also their outcome. So needless to say, one size does not fit all. We have to really see what's individualized therapy, and obviously no one size fits all. So with that, in surgery, for example, we really modified the management of the axilla. It used to be that all patients are all their lymph nodes removed in the axilla for no good reason, just for staging purposes. Now we know that's not really necessary, because obviously it causes the morbidity of lymphedema, which we'd like to reduce because that significantly impacts the quality of the life of the patients. So what information does it provide that really warrants us removing all those lymph nodes in that patient and exposing them to the 20% risk of lymphedema? In the neoadjuvant setting, doing biopsies of the sentinel node with a needle, so that then we can check after neoadjuvant therapy, check that lymph node to see whether it's converted or not, to see if it's really warranted to perform that axillary dissection. Being critical of what we do, not just doing it because we can. From the chemotherapy standpoint, the genomic profiles have become extremely helpful in deciding chemotherapy versus no chemotherapy. It was first introduced in 2005, and since that time, we really minimized the need for unnecessary chemotherapy. Chemotherapy has a lot of side effects that the patients have to deal with way past their treatment. So if the patient is not going to benefit from my chemotherapy, why expose them to that added risk? And not to talk about the cost to the healthcare system, besides the personal cost of the particular patient who has to undergo to that chemotherapy. So taking advantage of those genomic profiles in helping us decide these tough decisions. Proton therapy. Dr. Mehta obviously has every single toy under the earth for radiation, and we're very happy that we can offer our patients the best technology available, and specifically the proton therapy has some benefit for some of the patients with left-sided breast cancer, so we can minimize cardiac toxicity. So again, we can do it. It's not the right approach for every single patient, but having the ability to minimize the risk when needed. So to reduce that collateral damage. It's bad enough to get diagnosed with a cancer, so we can reduce the collateral damage to that patient. That's our main aim. And obviously, a breast talk couldn't be complete without talking about Angelina Jolie, and we are really happy that here we have two geneticists who work with us. A lot of our breast patients, have 5% of breast cancer patients have a known genetic mutation that is actionable. So having the ability to test our patients for those genetic mutations to better inform us in terms of the treatment for that patient, and also prevention strategies, because depending upon if a mutation is identified, we can then prevent other cancers, such as ovarian, if it's a BRCA mutation, with P53, ATM mutation, colon cancer. So it really informs us so that we can better guide our patients. And we're very lucky that we have a very strong genetics team to help us in that effort. We have an incredible team of plastic surgeons who can provide incredible, for those patients who are good candidates, being as nipple sparing mastectomies. As you can see here, this patient looks great after her nipple sparing mastectomy. Again, not all patients are good candidates for this procedure. We're taking into consideration anatomic as well as oncologic factors in deciding who's a good candidate for, but as you can see, the outcome is incredible. So we can marry both an oncologic outcome with a good cosmetic result. This is the right fit for the patient. No doubt that this is a great procedure to offer a patients with oncologic safety. And I don't know how many of you are familiar with the flat closure and the flat movement. They started in New York several years ago, and these are women who come to us. They're not interested in any reconstruction. They just want to be flat. Okay, and with that, we have these aesthetic flat closures that we can perform ourselves, the breast surgeons, or in conjunction with the plastic surgeons. But again, this movement has taken over many parts in the United States, and it's the woman's choice to decide how she wants to proceed, and being able to provide this for those who wish to proceed with this treatment, we can. 99 versus 21. Breast cancer does not discriminate with age. Though the likelihood of developing breast cancer increases as you age, certainly my youngest patient has been 21 years of age. I didn't want to believe the diagnosis. She was actually preparing to take her MCAS to apply to medical school. She had come to see me for a second opinion. She had a lump. They thought it was a fibroadenoma. She was 21, most likely 21 years old, but her mother had a BRCA mutation. And they have recommended 6-month follow-up. But I said, you know what? It's so easy to do a needle biopsy. We can do it, and that will give us so much more information. And that way you can focus on your studies, you can relax. If it's something that we need to worry about, then we know, and we can do something about it. Sure enough, it turned out to be a breast cancer, and she ended up having positive lymph nodes. So I was really happy that she pursued the recommendation and had the biopsy performed. 99 years old, the oldest patient I've operated on. She presented with a mass that was larger than an orange, okay? She had never had a mammogram done. I thought, you have been delinquent for 99 years, okay? And she not only, she needed a mastectomy because it was a triple negative, it was a really large mass. She only took an aspirin per day. I presented in our tumor board because I said, how am I going to operate on a 99-year-old lady? But I had no other options. So her family, as well as the tumor board recommendations, were to proceed with surgery. And not only did she have her mastectomy, she went home the same day. She was an outpatient mastectomy. By the time she came to see me post-op, she said, Doctora, I made a decision. And I said, oh, what have you decided? If I win the lottery, my breast reconstructed. I'm like, good for you. And I said, and I see those billboards that Baptist has in the highway. I want one with my picture and saying 99 and beat breast cancer. That is the attitude. And she actually turned 100 years old, March 10. I will never forget her birthday because it was monumental. Okay, and she's still alive today. So 99 and 21. We really have assured here, and one of my focus here at MCI is to really do what's right for the patient, as I told. So the younger patients, the other end of the spectrum, to right to the needs that they need from the psychosocial standpoint, the extra role, fertility preservation. We have a team of oncofertility that can help us with that, because certainly it's a whole different set of issues that really inflict the younger patient as compared to the older patients that we have to pay attention to. So it is our goal, Dr. Manaharan also touched upon this, doing what we can from the clinical standpoint. We don't want to overtreat the patients, but we don't want to undertreat them either, as we try to keep this very delicate balance between maximizing the breast cancer cure versus quality of life. So that's a challenge that you have, and we take this extremely seriously here. And we still have some challenges to tackle. Because obviously breast cancer, there's a whole slew of socioeconomic and cultural factors that impact the whole spectrum from prevention to survival. And as we have more and more survivors, more and more issues to deal with in that setting. And we have service lines in all of this. We have a benign breast clinic. We have a high-risk clinic also to target all the different parts of this spectrum. We have a very diverse patient population, which helps us so that we can try to obviously individualize from that end as well. COVID-19, we're still recovering from that, and it really forced us to think outside of the box, like sending a patient home after the mastectomy the same day, outpatient mastectomies, doing it with the right proper setting, education, as well as support to the patients. And certainly each patient who walks in through our doors, many of you walked in through these doors last night for the tour, we know that each patient brings their own story. And we really take pride in treating patients in a patient-centered approach, so that way we can really provide the patient with what they need. It's a long journey, the breast cancer journey, and we have all the complements of that journey in terms of quality of life, patient navigation, which is key. Once that patient is diagnosed and they're gonna go through that journey, having oncologic nurses who walk with them from service to help them answer questions as an added resource, as well as support groups, as well as help for their family members. And I think as we continue to move forth with certainly research, the advancement in technology, as well as the clinical care, will continue to catapult forward, and changing dogma. Because the fact that we can happen and that's the way we do it today certainly doesn't mean that that's the way we'll do it forever. As we go from maximally tolerable to minimally effective, from anatomical to biologically appropriate, from rest additional to basic science-based and evidence-based, from science to treatment planning, and ultimately to preserve quality of life. And we're all under one roof. I'm really privileged to work with an incredible team of colleagues, not only surgeons who are all here, Dr. Lopez Penalver, Dr. Giron, Dr. Mautner, but also the whole team of medical oncologists, as you can see here. And the list goes on and on, breast radiation oncology, our breast imaging service, everybody with this latest technology and knowledge to help our patients, our prevention clinic and the plastic surgery service. So it takes a village, but we're here to support you and your patients. And as we continue, Dr. Zinner, our CEO, from the beginning, he was about how to take high touch. And this is what we're here to do for all our patients. And thank you for entrusting the care of our patients to us here at the breast service at MCI. Thank you.
Thank you, Dr. Mendez, for your work and how we are transforming lives in patients with breast cancer. One take home is obviously age is just a number. As we have an aging population, cancer is a disease of aging, and we'll be taking care of more and more patients who are older. And between our programs here at Miami Cancer Institute and our other institute, Lynn Cancer Institute in the north in Boca Raton, we have a distinct ability not only to take care of cancer patients, but also patients of Hispanic origin and patients who are older. And the reason for that is, as you saw, some really remarkable progress that was discussed by a previous line of speakers. Most of the trials that actually get approvals for the FDA drugs have a very minimal representation of minorities. So only 3 to 4% of those patients tend to be Hispanic in origin, or 3 to 4% African American in origin. So as we see patients from Caribbean, Creole descent, or we see patients from Latin America, we have a special expertise. We do have a Center for Equity in Cancer Care and Cancer Research, where we are really pushing forward for clinical trials in focusing on patients on minorities. Obviously, I told you at the beginning of the session that you are due for a treat, and I am sure you enjoyed these 5 talks. There are numerous other physicians in Miami Cancer Institute under leadership of Dr. Zinner, who are really world-renowned and trained at some of the best centers in the country, and who are delivering care under one roof. The other message was, it takes a village. And as Dr. Mendez said and showcased, one of the key themes here at Miami Cancer Institute is we really embark on a multidisciplinary management of our patients. And that's also demonstrated by 6 experts that you see on the podium: medical oncologists, radiation oncologists, surgeons, but also people you don't see on the podium. We have some of the latest technologies in terms of imaging, supportive services, to help our patients. We have experts who really focus on exercises, because in the era of immunotherapy, we are finding out not only the drugs are important, but people's level of physical activity is really important. what's their microbiome. So we are trying to get a holistic and integrative approaches for our patients as well. And one of the other themes I wanted to say is whenever we have cases, we actually discuss them in tumor boards, which is typically on an average 20 to 30 to even 40 experts actually who are discussing cases. So if you have patient cases that you really want us to discuss, you can reach out to Dr. Ribas and the international team, and we can really discuss the case. And if we feel that we have better technologies or clinical trials or innovations which will give a better degree of care for your patients, we'll be very pleased to take care of them and then keep you informed while we take care of them and then return them back to you to be near their loved ones. With that, right now we're going to have next 15 minutes or so about a panel discussion, and I would invite you all to ask questions of our esteemed experts here. And I'm sure we have some microphones in the audience. While we are waiting, I'm going to start off with Dr. Mida. Minesh, you talked about some of the really transformative work you're doing. So, when we started with radiation, we had like kind of one modality. Now we have multiple modalities, and we picked like 6 weeks of radiation. And I know you and your colleagues are really dabbling with that, and you showed us even pulse dose reduced. So what do you want to, and can we have a microphone here also on the podium, or Dr. Mehta's microphone is on. Talk about some of the ways you can really modulate up or down, because sometimes the patients, when they come from overseas or other places, can we deliver those innovative technologies in less duration of time?
I think the key challenge in radiation oncology is expanding the therapeutic window. We want the maximum tumor cell kill and the minimal normal tissue cell kill. And historically, when our techniques were very poor, what we had to do is we had to give very, very low doses of radiation every day in order for normal tissues to repair. And that's why we have the legacy 6, 7, 8, 9-week courses of therapy that you frequently see. With advances in technological platforms and precision delivery, we can minimize the radiation dose to normal tissues using these technologies. And therefore, we can increase the amount of dose that's delivered every day, so that in certain situations, we can give all of the dose just in one treatment, in one fraction, sometimes in as short as a 1 or 2 week course of therapy. What this has done is it has converted radiotherapy into a much more user-friendly therapeutic modality, as opposed to coming every day for numerous sessions, which several of our patients still do today. Many patients can come for shorter schedules. And of course, it's very patient dependent, very anatomy dependent, size and location dependent. But the move in general is towards this phenomenon known as hypofractionation. I like to say that hypofractionation is a friend and a foe. It's a friend because we can give more radiation dose in a shorter time. It's a more efficient way of killing the tumor. It's a foe because it's also a more efficient way of destroying normal tissue. So if you don't know what you're doing, it's like putting a race car in the hands of a teenage driver. You have to be very, very careful with it.
Thank you so much. If there are any, we have a question back there.
Thank you, Ludwig Bacon from Nicaragua. I have 2 questions. Ladies first, Dr. Jane, we have a lot of neoadjuvant drugs that give us a great response in neoadjuvant setting. Do you believe for those patients with clinical response, complete pathological response, maybe in the near future we can stop the surgery? How do you see this approach? And for the urologic team, for those patients with intermediate disease, how do you design between radiation approach or surgery approach? Thank you.
Sure.
Thank you for your question. So you're talking about the use of neoadjuvant chemotherapy and having a good pathologic response, what to do pertaining to surgery. So there's 2 ongoing clinical trials right now in the United States, one being led by MD Anderson, the other one by Memorial Sloan Kettering Cancer Center, looking exactly at that. Patients, we've gotten so good and effective with the use of neoadjuvant chemotherapy that especially those patients with HER2 positive tumors have, at least 70% likelihood of a complete pathologic response. So therefore, in that setting, they're doing biopsies of the area where the cancer was, at least 12 biopsies, and they've seen that it works, but it's only a pilot. So we're not, at this point, we're not ready to abandon surgery, but very soon we'll have the information for these clinical trials that's part of that continue to challenge the dogma and the practice, but may be possible in the next decade. I see it might be feasible for selected patients with good response. Yes, so stay tuned.
Thanks, sir. So I think the question which was asked is if you have an intermediate risk prostate cancer, which way I go? I assume that's a question. First thing you do is to stage the patient correctly. We have a number of tools. We have a good MRI, we have PSA, PET scan, PSA. Then look at the patient, look at various factors, the age, his expectations, what is important to him. And then you have a very meaningful discussion, like a patient and the physician discussion, both with the surgeon and also with the radiation doctors without bias. And then the patient, we make the patient come back second time or even third time, because in prostate cancer, we have time on our side. Just like surgery has improved a lot, radiation has improved significantly. They have minimized a lot of side effects as well. So you need to present all these things to the patients correctly. And this finally, the decision is going to be a joint decision between the patient and the doctor.
While we're waiting for the next question, Manesh, do you want to take about the proton and how we are using that in prostate cancer here at Miami Cancer Institute?
So I think the gist of the question is, when you have multiple choices, what do you choose and how do you choose what you choose? It's like going into your favorite restaurant and you got 15 things you love. What are you going to get that day? So obviously you get what you really, really want and what you feel you want that day. In other words, you're using your own bias, your own choice to make that decision. We may think this is trivial, but this is actually extremely important to patients. So as Dr. Manoharan pointed out, for patients, there are different perspectives. There are some patients that will come to us and say, I don't care, just get that cancer out of my body. I don't even want to live with the thought that there's a cancer in my body. I don't care about the side effects. I don't care about anything else. I want no worries, get it out. For that patient, beyond a shadow of a doubt, surgery is going to be the most satisfying therapy because they're willing to live with whatever the complications or consequences of surgery could be. There are other patients that will come to us and say, I have so-and-so as a relative or such and such experience. I never want to go through surgery. For that patient, radiation, with all its consequences, whatever they may be, is the right option. For most patients, however, they're somewhere in between. They're undecided. And so for them, a very robust discussion about the balance between risks and benefits is the key thing. And then we have the next level discussion that Dr. Manmeet Ahluwalia pointed out. Say a patient says, I want radiation therapy for my prostate cancer. Which modality of radiation do we choose? So it's a very, very nuanced discussion. For some patients, it might be a very short course, CyberKnife-based 5-fraction therapeutic choice. For other patients, it might be treatment of the prostate cancer itself, but also the seminal vesicles, and maybe even the lymph nodes in the pelvis. And if that's what needs to be treated, then perhaps proton therapy is a superior choice because it can preserve the bone marrow and the bowel from toxicity of radiation. So highly individualized, highly tailored to the patient's own goals.
So I think one of the takeaway themes here is that, sometimes the evidence we have was generated several years back, and the advancements are taking place so quickly. So having that multidisciplinary management where people are actively discussing cases as we do in tumor boards are remarkably helpful. And a lot of times the patients may have caveats that may be different from the trials that were, given rise to the standard of cares that we have. So we obviously look at evidence-based management, but some of these luminaries are actually the people who have helped create that evidence-based management through their work. Next, I would want to move on to Dr. Diaz. So previously in cancer, whenever we have new improvements, the hazard ratios that he showed were used to be 0.7. What that meant was that there was an improvement in survival by 30%. That if we could increase someone's age by 2 to 3 months, we thought that was great. But some of the endometrial trials that you showed today were had hazard ratios of 0.28, 0.3, which is so exhilarating. We are probably living in the best era of human mankind to help our patients. So would you want to elaborate on some of these new technologies, innovations that we have participated in or we are leading? What would be your recommendations to our colleagues here for referring patients to you, or what kind of patients?
Yeah, it's a very exciting time. And as you saw with those curves, sometimes you have to look real close to see separation. This is obvious, as David Scott Miller said, you can put the thumb right between those two curves. And so some of these things were just recently approved. The FDA just recently approved the addition of immunotherapy to the upfront therapy. So many of these medications are available throughout the world, but some are not, and some are unique to treatment here. And we can certainly initiate some of that treatment and discuss with their local oncologists how to continue that maintenance therapy locally. And so I think the vast improvement that we've seen in uterine cancer, in ovarian cancer, and cervical cancer is a testament to the improvement we have in the surgical innovation and the drugs that we have available for these patients today. And so it's really, as I said, an exciting time. 15 minutes is no way enough time to share all these innovations. But as you alluded to, the last 3 years, we've really improved outcomes with GYN cancers. And that's something we haven't seen in the last 2 decades.
No, thank you, Ivan. Again, we have a second opinion program. If you have complex cases, feel free to reach out to Dr. Ribas and the team, and we will be happy to discuss them and get back to you. With that, I'm going to move on to Dr. Koehne. Obviously, some really remarkable work now coming up with CAR T cells. We all remember the case of Emily, the patient with ALL, who did not have any outcomes. Actually, her parents were told to consider hospice, and she just recently celebrated her 10-year cancer-free survival. So I think CAR T cells has truly transformed. Carl June and Dr. Sutherland, who you work with at Memorial Sloan Kettering, really transforming this care. Would you want to talk about some of the CAR T cell adaptive therapies and the other works that you're leading here and throughout the country?
Yeah, thank you for bringing this up. I think the broader scheme is moving away from more chemotherapy to more immunotherapy, and that is crystal clear. The way I grew up, and that disturbed me when I started my career as a transplant physician and immunotherapist, it was the saying, the more chemotherapy you can give, the better the outcome. You need to kill the last cell with chemotherapy. Never happened. So now we have immune therapies that recognize the last residual tumor cell, be it a leukemia cell, multiple myeloma cell, and can eliminate it. Now, the strategy with the CAR T cells, they will not necessarily replace transplant, but they will add to the armamentarium that we have to eliminate the last tumor cell. Multiple myeloma landscape, for example, 15 years ago, we had 2 drugs, thalidomide, melphalan. You relapse, sorry. Now, that changed significantly, and the combinations thereof are developing. Leukemia, acute myeloid leukemia, for 25 years, 7+3 was the only chemotherapy combination that we had. Now we add in FLT3 inhibitors, change the modification, do the transplant, and we have post-transplantation immunotherapies. Now, I like to switch a little bit the question, and I get often referrals for patients with myeloma or leukemia that got freshly diagnosed. And the saying is, on Friday afternoon, you get the diagnosis of a leukemia and you need to treat immediately, otherwise the patient will not survive too long. That's a mistake, because often they get referred after induction chemotherapy has been initiated, and that messes up the whole program that we have, because what you do in the beginning may affect the outcome afterwards. So that's an additional remark to this one. CAR T cells, I was just at a meeting with Michel Sadelain and Carl June, are changing, the dynamic of the CAR T cells are changing as well. So right now there is a lot of 100 million cells or 200 million cells of CAR T cells to be given to have the effect, and that induces a lot of side effects that are pointed out in my presentation. Modifications of the CAR T cell sensitivity now, and Michel just got an FDA-approved clinical trial to modify the CAR T cells that allow to give only 10 million cells with the same effect, and that will likely reduce the side effects. So this field is developing fast, and it's just the beginning, and will be modified even further in the near future.
No, sure. Thank you so much. So I just want to re-emphasize some of the themes that we had today. We are in the era of precision medicine. We want to provide the most cutting-edge care in the most benevolent manner to our patients. We work in a multidisciplinary environment, and that is very clear to you. You obviously toured the Miami Cancer Institute under direction of Dr. Zena, with support from the leadership, Bob Bellinger and others. We have some of the truly most remarkable technologies in the world, and we're just starting out. And so I think the best times is ahead of us for our patients and their families so that we could touch their lives and truly help them transform that. If there are no further questions right now, we'll take a very well-deserved 10-minute break, and Dr. Ribas will have some taking notes.
Thank you, Dr. Ahluwalia and the team for an amazing presentation. We are going to move towards our next module, so we're a little bit behind, so we're not going to be doing the coffee break now. I would ask Dr. Zinner if he can please come up so we can have a picture with the MCI team. And I really appreciate all of you coming here and dedicating the time to be with us, and thank the MCI team. Yes, good job. Okay, thank you. Good job. Dr. Hayes. We're now going to continue the session with our experts from the Baptist Health Neuroscience team. Before that, I want to remind everybody that this is being presented virtually, so please feel free to forward to your friends, and they can actually continue to follow us. And I'd like to say hello to all our friends watching us in the virtual world. Because we believe in patient care first, we have a little bit of a change. Dr. McDermott will be having to deal with some patient care situations. So we are going to have a change, and the moderator will be Dr. Diego Torres Risuto. He's the chair of neurology and chief of movement disorders. Dr. Michael McDermott will be presenting. He's our chief medical executive and the Ima and Kalman Bass Endowed Chair in Clinical Neuroscience. Also joining him is Dr. Italo Linfante, Director of Interventional Neuroradiology. We have Dr. Michael Gomez, Director of Minimally Invasive Spine Surgery. And Dr. Guillaume Dabous, Co-Director of Interventional Neuroradiology and Vice Chief of the Department of Neuroscience. And Dr. Vitaly Sioman, Medical Director of Cerebrovascular Surgery and Epilepsy Surgery and Co-Director of Skull-Based Surgery. If I can welcome the doctors to the podium. Thank you.
Okay. Dabous. Yeah, thanks, Roger. Morning, everybody. I see there's a few people getting coffee, but I think we'll proceed for the sake of time. My name is Mike McDermott. I'm a neurosurgeon. I was originally from Canada, born to Irish immigrant parents, so my Spanish is limited. But thank you for attending. And we're going to start off actually with Dr. Sioman, who's a double-trained neurosurgeon, trained first in Moscow, then he did a fellowship in pediatric neurosurgery in Tel Aviv, followed by a clinical fellowship in Toronto with Mark Bernstein for 1 year, and then he repeated his neurosurgical training at Cleveland Clinic under the direction of Gene Barnett, Michael Vogelbaum, and he's going to talk about microsurgical management of cerebral aneurysms. Bit? Yep. Yeah.
Thank you very much. It's a privilege to be with you here and share some of our experience here at the Miami Neuroscience Institute. So I'll talk today about microsurgical options for the management of cerebral aneurysms. They're quite common. Aneurysms can be found in 1 to 6% of the population. There's very minimal evidence for congenital or inherited weakness of the arterial wall. Most likely etiology is hemodynamic injury, shear stress on the walls, especially at bifurcations. And they can be found in some patients with associated connective tissue disorders, such as Marfan, Ehlers-Danlos, FMD, and other conditions. There are multiple in 10 to 30% of the patients, especially in vasculopathy patients, and the patients become symptomatic at the age of 40 to 60 years old. Most common clinical presentation is subarachnoid hemorrhage, and they typically present with the worst headache of their life, cranial neuropathies, visual loss, seizures, and there's different scores to measure the severity of the hemorrhage clinically and radiographically. About 20 to 30 of the patients, percent of the patients never even make it to the hospital. They just die on the scene. And out of those who reach the hospital, a significant number remain permanently disabled, no matter what we do. The risk of rupture in patients with unruptured aneurysms is actually not very high, especially in patients harboring small aneurysms. In patients with anterior circulation aneurysms that are smaller than 7 millimeters, this is a relatively old data from unruptured aneurysm trial, the risk of rupture is way less than 1% per year, as opposed to posterior circulation aneurysms, and especially larger aneurysms. The risk may increase to up to 2% over 7.5 years. And the controversial part of this data is that a significant number of ruptured aneurysms actually are not very large. They're 5 to 6 millimeters in diameter. That's why the paradigm is shifting of whether you treat smaller aneurysms versus larger aneurysms. Some of the risk factors are cigarette smoking, cocaine abuse, that may lead to vasculitis, intimal injury, and patients may eventually have symptomatic presentation. Female sex is another risk factor. Family history of aneurysm and other conditions such as polycystic kidney disease, SLE, high blood pressure, and aneurysm shape also plays a role, such as when you see irregularly shaped aneurysm with some Murphy's excrescences, these patients should be monitored very carefully and maybe move toward more aggressive management. So what are the treatment options in patients with unruptured aneurysms? Some of the patients you can follow, some of the patients will undergo clipping. Other options include bypass with clipping, wrapping, anterior ligation historically, coiling, stent coiling, and flow diversion. In patients with unruptured aneurysms, you obviously cannot follow, but the treatment options remain the same. The goal of any treatment is to achieve as complete of an obliteration as possible. It frequently involves a multidisciplinary approach, and here at Baptist, we utilize the expertise of a neurosurgeon, interventionalist, frequently neurointensivist is involved, and at some later stages, we invite rehab specialists, and neuroradiologists is also important to discuss the morphology. So, advantages of coiling. So just, it's not exactly my topic, it will be covered later, but it appears to be less invasive. It is associated with lower disability and mortality based on the ISAT trial. The risk of vasospasm was lower in patients who undergo endovascular treatment. It gives us also an advantage of injecting intraarterial medicine to resolve the vasospasm. It was felt to be better in patients with posterior fossa aneurysm, better tolerated by elderly and patients with poor neurological grade. And it's also associated with a lower risk of seizure and cognitive problems. When it comes to surgery, you just see like the hair needs to be shaved. You have to have a skin incision. The head is clamped. General anesthesia. This is an example of clipping of a ruptured the ruptured pica aneurysm. You can see the brainstem over here, the cerebellum. Everything is retracted. Big exposure, cranial nerve morbidity is one of the risks. And obviously the patient is just, when you present something, especially to a patient with unruptured aneurysm, it's a big deal. Surgery is obviously a big deal. Coiling, on the other hand, is not that simple because it also requires a very highly trained interventional radiologist. It's hard to handle complications, especially if you have an intraoperative rupture. Patients require anticoagulation and antiplatelet therapy for prolonged periods of time. Cost in some places might be prohibitive, especially in this country. The cost is quite high. It's not feasible for all aneurysms, especially the smaller ones that less than 3 millimeters in diameter, and more than 4 times more patients treated with coiling in ISET trial require additional treatment for ruptured aneurysms than craniotomy or clipping cases. 20% of the patients end up with incomplete obliteration, and there's a higher risk of rebleeding. In the US, coiling cases cost 1.5 times more than clipping. It's as opposed to, I pulled the data from Taiwan, for instance, and the vascular coiling is costs about 14 grand per patient, and surgical clipping is just slightly more expensive. In the US, it's different. Clipping of the aneurysm requires a highly trained neurosurgeon. It's typically one procedure because you don't need to redo the cases. And those aneurysms that are clipped, the treatment is mostly definitive because 98% of the patients do not require any additional treatment later on. The risk of recurrence is extremely rare, and it's probably more versatile than coiling for most aneurysm shapes. You can also evacuate the blood clot and hopefully prevent the vasospasm, although this is controversial. And there's no evidence to increase mortality at 5 years in the ISET trial, which is also kind of controversial. Clipping involves various technical tenets. We utilize induced hypotension, CSF drainage. You can put the ventriculostomy drain through the Payne's point. Mannitol administration, hyperventilation. We utilize minimal brain retraction. I typically do not use brain retraction for the dissection part and exposure of the dome of the aneurysm, the neck of the aneurysm. It's only when you start clipping, I put the retractors over the rubber glove sliders to just keep the brain lobes apart to make sure we don't cause some collateral damage. Preservation of the veins, as you can see on this picture, is important because this is where your blood outflow comes from. Some patients may develop venous infarct after sacrifice of the vein. And always keep the adenosine ready for circulatory arrest. You never know. The aneurysm can burst open. It may be difficult to control, and the circulatory arrest can help in some cases. I'm not going to go to the details of the ISET trial for ruptured aneurysms, but the take-home message is that the craniotomy and coiling are both associated with relatively high chance of poor outcome in patients with ruptured aneurysms. So it's something to remember that a ruptured aneurysm is a bad disease, oftentimes associated with very poor outcome. Craniotomy patients had a 30% chance of poor outcome in 1 year. Coil patients, almost a quarter of them had poor outcome. The absolute risk reduction 1 year follow when comparing aneurysm coiling to aneurysm clipping was about 7%. Some of the data was reproduced in a Barrow aneurysm trial. Poor outcome was observed in 33% of the clipping group and in 23% of the coiling group. Their conclusion was that the policy of intent to treat favoring coil embolization resulted in fewer poor outcomes than clip occlusion. And then they reanalyzed the data 6 years later, and they found that at 6 years, the results show that there's little difference in outcome between coil and clipping for anterior circulation aneurysms. For posterior circulation aneurysm, the embolization provides significantly better outcome. And obliteration rates in BRAT were significantly lower and retreatment rates significantly higher in the coil patients. So which aneurysms should be clipped? And we go over several groups of patients that we feel are good candidates for surgical clipping as opposed to coiling. These are young patients because clipping provides lower recurrence rate, again, maybe 2-3% in most series. And these patients have typically prolonged life expectancy. That's why it's important to secure the aneurysm well and give them the the freedom of living their life without worrying too much about the aneurysm recurrence. In older patients with significant vessel disease, arterial kinking, when manipulation and advancement of the catheter might be challenging. Ruptured aneurysm with ICH mass effect, it's kind of like a no-brainer. You have to evacuate the hematoma, resolve the mass effect, and clip the aneurysm. And most of the dissection is already done for you by the blood clot, which is there. Aneurysm with wide necks, especially MCA aneurysms, where the bifurcation is diseased, it's very complex, and some of the vessels with coiling and stent placement might be compromised. That's why it seems to be ideal treatment modality. In patients with giant aneurysms, especially recurrent giant aneurysms, patients with distal aneurysms, and when distal branches originate from the aneurysm itself, in patients with failed multiple coiling attempts and ruptured previously coiled aneurysms. It's interesting, all of these cases are not really trivial. So when you think about it, so and there's obviously a paradigm shift and a treatment modality shift in multiple residency programs. So as residents, we neurosurgeons do not really get a lot of experience in clipping very straightforward PCOM and very straightforward ACOM aneurysms because they're all coiled nowadays. So when we come out of training, we have to deal with something like this, which is not really fair, and that creates a problem for training, for maintaining your skill, etc. But it's a kind of different topic. Some of the technical tenets, we utilize temporary clipping. Up to 15, 17, 18 minutes is considered safe. You have to do careful monitoring. Burst suppression is utilized. We induce hypertension to maintain the blood perfusion to the parts of the brain that might be affected by temporary clipping. Always consider neck of the aneurysm calcification, because it might be a red flag and might be a setup for trouble, because when you put a clip, you may not completely obliterate the neck. If you have a calcifix right there, you may need some augmentation of the clip by a higher pressure clip. Intraaneurysmal thrombus is another problem that you can encounter intraoperatively. Atherosclerotic plaque, you have to kind of navigate your clip placement around the plaque so that the plaques would not be dislodged and obliterate the normal vessels. Always spare STA for bypass, you never know. Consider neck exposure for proximal control in some aneurysms, especially the parophthalmic aneurysms. And intraoperative angiography will be touched on one of the slides at some point later. So this is an example of the ruptured aneurysm clipping. So the strategy is to clip the aneurysm and evacuate the hematoma. That helps you, again, to resolve the mass effect, maybe eliminate, maybe decrease the chances of vasospasm. In unruptured aneurysm, clipping strategy is somewhat different because much is at stake, higher expectation, much to lose. These patients are frequently asymptomatic. Aneurysm is found incidentally because of some dizzy workup or a headache that neurology orders an MRI for. And here you go. We are competing as neurosurgeons, we're competing with endovascular coiling procedure, which does not even require an incision, no surgical risks whatsoever. Some of the general principles are just as we discussed previously. This is an example of an MCA aneurysm bifurcation clipping. You can see multiple aneurysms. I use this technique that is called a picket fence reconstruction of the bifurcation. It can be used not only in MCA bifurcation, also for ACOM aneurysm ideals, especially with larger aneurysms, especially when you have branches originating from the aneurysm dome. So this is a good technique to utilize. 3D thinking is important in when you think about how you're going to put the clips. This is an example of MCA bifurcation aneurysm clipping. So we utilize this picket fence technique and use different size and shapes of the clips. In many cases, we have to apply cotton to the disease aneurysm bifurcation, where you have very thin walls, and the cotton placement induces the scar formation, hopefully provides some protection. This is an example of intraoperative angiography with IC green utilization. This is how you can literally dance around the fusiform aneurysm. The patient has extensive atherosclerosis, and you have to put the aneurysm with various shapes, aneurysm clips with various shapes to avoid compromise of the normal blood vessels. This is an example of a ruptured PCOM aneurysm where you evacuate the blood clot and place the aneurysm clip, also trying to avoid the dislodging the atherosclerotic plaque. This is an example of an ophthalmic aneurysm, ophthalmic segment of the carotid artery aneurysm clipping. So this case requires extensive clinoidectomy, opening up of the optic nerve sheath, mobilization of the optic nerve to be able to visualize the entire neck of the aneurysm, and then you place a clip and the aneurysm is punctured to deflate the sac so that the optic nerve would be decompressed. And the patient had a good restoration of the vision, which was affected preoperatively. There's another example when the aneurysm is clipped, but no matter what clip shape we tried, the clip locking mechanism would be, the spring of the clip would be compressing the optic nerve. So I sewed the clip to the dura that was covering the optic nerve, and that moved the clip away, so that requires some microsurgical sewing of the intraoperatively, a skill that you can just learn from doing the bypass surgery, and we've been published on that. Ruptured ACOM aneurysms, the problem with these aneurysms is that there's multiple perforating vessels originating from the ACA complex, and it's important to navigate your clips around them to minimize the chances of their damage. There's an example of giant MCA bifurcation aneurysm when it was felt to be not a good candidate for flow diversion. In that case, there's different treatment strategies. We decided to proceed with performing a high flow bypass, and after that, after harvesting of the radial artery graft by the vascular surgeon, we performed the craniotomy. The bypass was performed between the carotid artery on the neck and the inferior division of the MCA, and then the aneurysm was coiled endovascularly. This is the tunneling of the radial artery graft between the cranial exposure and the carotid artery exposure. There's another case of a giant MCA bifurcation aneurysm when a high flow bypass was required. So this is the giant aneurysm over here. You see the dome and the two branches, the superior and inferior divisions. The bypass was created between the superior and inferior divisions so that the blood would flow from the inferior division to the superior division, which was subsequently clipped at the origin of the aneurysm. So this is the intraoperative angiography showing patency of the bypass. And the aneurysm was endovascularly coiled, filled with a coil mass, and the clip was placed just proximal to the takeoff of the superior division. Aneurysm clipping can be performed using an exoscope. We're going to acquire this strategy, and it's going to be available hopefully next year. And it gives you the whole room can participate. Everybody gets 3D glasses. We can watch this, and you can have a very nice three-dimensional, in-depth view of the surgical exposure. Oops, we'll don't have time for that. So intraoperative angiography, we substituted it predominantly with the ICG video angiography and use conventional angiography selectively. Complications, obviously there's morbidity. Mortality and morbidity increases with the increase in the size of the aneurysm. Up to 10% risk of intraoperative rupture. You have to be prepared to deal with that. Temporary clipping helps. There's a risk of stroke, venous infarct, seizures, and craniotomy-related complications, as you can see in this slide. Conclusion, surgical clipping is well-established treatment options. It will remain an option for selected patients, even though endovascular coiling has supplanted microsurgical option in most institutions. Microsurgery should be strongly considered in younger patients, in patients with anterior circulation aneurysms, with wide necks, in patients with giant aneurysms, some older patients with tortuous vessels, and coiling failure cases. Multidisciplinary approach is essential, and you have to be prepared for everything, including with utilization of your skull-based techniques. There's actually a picture. It's one of my patients. She had clipping of 2 aneurysms, and she had her staples removed, and she made this very nice necklace and bracelets with this. And on that, I wanted to finish. Thank you very much. This is our team. Team is super important as a multidisciplinary collaboration. Thank you very much for coming over to Miami.
Hi, bonjour. Buongiorno, bon dia. very, very nice day today. Muy buenos dias, everybody. I'm Diego Torres Rusoto. I'm the chair of neurology at the Baptist Miami Neuroscience Institute and the chief of movement disorders. And as you heard, Dr. McDermott had to go urgently to the hospital and will be back to present at the end. So I'm going to be covering for the MC portion for now. So it is my honor and pleasure to introduce to you our next speaker, which is Dr. Italo Linfante. Dr. Linfante is an internationally renowned interventional neuroradiology and endovascular expert. He's the medical director of our interventional neuroradiology program here at MCVI and the Miami Neuroscience Institute, and a clinical professor at the Florida International University. He has trained in amazing places, La Sapienza in Rome, Harvard, Baylor, and is a member of multiple editorial boards in very important international journals, member of the executive committee of the International Society for Interventional Neurology, as well as an executive committee of the Society for Neurointerventional Surgery. So you're in for a treat. Dr. Linfante, please come in, and he's gonna be talking about new frontiers in the treatment of cerebrovascular aneurysms and ischemic stroke.
Thank you, Diego. Thank you for having me with such a kind introduction. Whatever I say is going to be fine. So this is usually a topic for like 3-day conference. I'll do it in like 15 minutes. I'm not sure how can I do that, but we'll try my best. These are my disclosures. Dr. Suomi says about hemorrhage, a horrible disease when aneurysm ruptured. Mortality, it's used to be high, but it's getting much better due to the new advancement you have in our field. And we are, Dr. Dabus, myself, Dr. Suomi, Dr. McDermott are involved in clinical trials and really advancing this field. So some of the papers I'm going to quote, that's actually our papers. But the good news is that you can see that there's some mortality trends for subarachnoid hemorrhage is coming down, and coming down because besides having clipping, like Dr. Suomi shows, we have endovascular embolization. Like you guys know, probably it's a minimally invasive procedure from the femoral artery or the radial artery, and you put coils inside the aneurysm. But things are getting better. This is a classic example, for instance, ACOM aneurysm ruptured before and after calling. But things are getting better because what about other type of aneurysms? And we are involved in clinical trials and translating basic science discoveries into clinical practice. So for instance, this case of this fusiform giant dissenting intracranial aneurysm, absolutely untreatable. It was a 16-year-old woman with this horrible aneurysm. And that's how it looks like, impossible to treat. I don't know if we can start the video. The video doesn't work. Can you start the video? If you click on it. Yeah. Anyway, so one way to treat this aneurysm is using flow diversion, which I've been working with the person who actually invented, Dr. Waklu. It's basically a device that changes the dynamics. I can steal from this very simple equation between convection and diffusion. Based on this equation, you can create a device that diverts flow from the aneurysm to the parent vessel. And then this becomes basically a scaffold to produce endothelial growth and close the aneurysm. That's how the device looks like. These are basic data on experimental models. And then that's how we treat this aneurysm. We basically started with a construct of multiple devices, one inside the other. And there was a final result. So you can see stagnation of the contacts inside the aneurysm. That was before and that's after. This was done a few years ago. That's aneurysm before, the aneurysm after. So amazing results. And that's the patient 5 years later. So great advancement. With Dr. Dabus and Dr. McDermott, we published a paper on endovascular treatment of giant intracranial aneurysms, 45 cases treated. But we're expanding our frontiers to using flow diversion also in ruptured aneurysms. There was a patient with subarachnoid intraparenchymal hemorrhage, has this horrendous dissecting a large MC aneurysm that we reconstructed with flow diversion. Again, with excellent result, aneurysm before and aneurysm after. 6 months follow-up angiography, complete occlusion. What about blisters aneurysms? We publish on those. Those are very, very small, ruptured small aneurysms. We published the first paper many years ago, Dr. Booth and myself, using flow diversion for these aneurysms as well. We ended up with a follow-up paper also on a large case series. This is a patient, I don't know if you can see it on the screen, this middle cerebral artery with the little aneurysms on the side of the vessel. We reconstructed with a very small flow diverter in the middle cerebral artery. It's like a 2 millimeter vessel, 2.5 millimeter vessel. That's the deployment of the device from the groin into the middle cerebral artery of this patient, and patient did very well. This is just after deployment. That's the 3D that shows complete reconstruction of the artery. 8 months follow-up angiography shows complete reconstruction of the artery, and patient did very, very well. She's now well out, and now 10 years later, patient is doing fantastic. So, and then there's technology advancing. We have and flow diverters that are coated with a polymer that prevents platelet aggregation, so the future is even brighter. Quickly about stroke, I don't know how many more minutes I have. Stroke, it's amazing. Progress in the last 10 years, we turned a deadly disease into a treatable condition. That's what happened when a large artery of the vessel of the brain is occluded. You can have a massive infarction, like you see in these cases with death of the patient. This is a slide that gives you some ideas. If you have an H-stroke scale, which is our way to measure clinical symptoms of a stroke of 17 and above, which is a typical patient with hemiparesis. Sorry. We have a relative risk of death to the disease 84%. If I have a malignant MCA syndrome at 80% mortality, I see a T occlusion, 73% mortality, and of course, basilar artery is occlusion, it's incompatible with life. So what we do in these cases, we started developing a device, looks like a stent, you can see here, that grabs the clot and endovascularly, you grab the clot and you pull the clot out. Does this work? We were part of one of the trials, 5 randomized clinical trials were published in 2015 that shows a remarkable difference, incredible difference between a patient with treated with endovascular thrombectomy compared to medical management. So since then, we have a new treatment for stroke, which is pretty amazing to see witness this journey during our lifetime. But the future is even brighter. So before we used to just grab the clot, now we are developing devices that are large bore aspiration cutter, like in this case. And so you just aspirate the clot instead of trapping it. And we publish on the a big trial that shows that the techniques are pretty much similar in terms of efficacy. I want to show you some patients, 95-year-old man, atrial fibrillation, narcosis from the field, an age of 18. So very tortuous aorta. Sorry, that's another patient. 87 patient, aphasia hepatitis, TPA, and that's the occlusion of the internal carotid artery. I don't know if you can run the video. There's a video afterwards. Can you click on the video? Yeah, click there, right. So you can see this in real time. You can see the device going up into the blocked artery. That's the wire that crosses the occlusion, and the wire looks like it's floating in the brain, but it's actually me pushing the device. You can see the device is going up. You can see the device moving to reach the clot. At a certain point, once we reach the clot, then we do aspiration. And I don't know if you can click on the other two. Yeah. Now you can see complete resolution of the occlusion with the beautiful flow into the vessel on both sides. And that's the clot that we pulled out. So there's a revolution in acute stroke treatment. So we went from 80 to 90% of disability to maybe 10 to 15% death and 20 to 40% minor disability, but we're not there yet. So although we can recanalize the artery probably 95% of the cases, we don't have 90% good outcomes. And so we publish on that too. And that's what happened because once you block the artery, there's a small area of stroke which is damaged, and the rest of the stroke is under apoperfusion, and it's called penumbra. So we're trying to preserve the penumbra. How can we do that? I mean, the technology is pretty much give us the best device we can possibly do. So we're going to how can we buy time? And there's a concept called neuroprotection. One thing that we have been working on at Baptist Health is to increase collateral circulation, to improve perfusion after occlusion. And we did several work in basic science regarding to find an agent that could possibly increase collateral blood flow and preserve the penumbra while we're doing our procedure. This has been done in models of middle artery occlusion in animals. I'm going to go very quickly on this. Basically, rats have similar to us core and penumbra and have a collateral circulation. So it's a good model at this point. We close the artery in the rat model. And then after 2 hours, we recanalize the artery. So very similar to what happens in vivo. And also we can study collateral circulation like showing this. So I'm really grateful to be working with Ray Kohler from Johns Hopkins and Marian Cipolla. We do a tremendous amount of work on a very interesting compound, which is called carboxyhemoglobin oxygen carrier, PP007, which is basically hemoglobin. So we take the hemoglobin from the red blood cells, conjugate with a polymer, and add carbon monoxide. So this has the advantage of delivering oxygen much better than the red blood cells because it's just transported by a polymer instead of red blood cells, and also can reach small vessels. And carbon monoxide is a vasodilator, so dilates the collateral circulation and improves oxygen delivery for about 24 hours. So we publish on this. I can show you all the papers. There's a beautiful paper we published on spontaneous hypertensive rats in JCBF, Marian and myself. And then we publish a review on neurology. You can see if you're interested in. So, and we came up with a trial that we started here. Dr. Dabus is a principal investigator for Baptist. I'm the national PI for the trial. It's basically safety and tolerability of this compound in acute ischemic stroke patients. So I'm very proud of this effort. Clinical sites involved in the trial, ourselves and UPMC and Grady Memorial in Emory. 21 patients enrolled so far. We passed actually 4 DSMB reviews. So far this compound seems to be safe in these patients. This is the NA stroke scale after giving this medication in this very small group of patients. It seems to be an improvement at 24 hours and 7 days in this patient treated with this compound compared to controls. So that's kind of interesting result too. And what we really knew that this compound lasts for 24 hours. This is pharmacokinetics data that we obtained in these patients showing that the medication lasts about 24 hours. So in summary, safety and tolerability passed 4 DSMB reviews and imaging core analysis. This medication stayed for 24 hours compared to preclinical size, very exciting. And so we're moving to EMERA-2, which is the randomized clinical trial. Hopefully we'll start soon for efficacy, and we'll see. And I really want to thank the steering committee, our friends, Dr. Noguera and Dr. Liebenskind from UPMC and UCLA, and of course, Dr. Dabus and Dr. Wicks from our center, and our staff. So just want to show you with one patient we treated with this compound, 91-year-old, who right side plegia, global aphasia, and deviation, age of 22, 91-year-old with an aspect of 9. So really very, very poor candidate for pretty much anything, but we did an endovascular thrombectomy. As you can see the middle artery occlusion and a big mismatch on perfusion imaging. So we randomized him and enrolled in the clinical trial. So we did thrombectomy and give the medication. That's the thrombectomy, MC occlusion before, MC occlusion after thrombectomy. And we gave the medication at the time of thrombectomy. That's the medication. How did this patient do? 91-year-old, and H22 stroke onset, and HO2 at the day after, 0 at discharge. So the thing I want to show you for this case, and we can show the video on MRI of this 91-year-old. If you can click on that, yeah, there, yes. If it works. Anyway, so on MRI, there's basically not much on this patient brain, a 91-year-old in a monocclusion. So it's kind of interesting. So I'm done. Endovascular embolization, brain aneurysm, new devices to achieve even better outcomes. Mechanical thrombectomy for ischemic stroke is evolution of structural care, and maybe thrombectomy is the future. And then thank you very much.
That was great, Italo. Thank you. I want to thank all the folks at Baptist Health International for the work they do and for bringing all of you here and for inviting us to speak. I'm going to be reviewing diagnostic and therapeutic updates in epilepsy and movement disorders. So neurological disorders are important. The impact is huge. As you know, we have an immense growth of dementia, and stroke, traumatic brain injury, and dementia are the 3 of the top 6 causes of mortality in the United States. And neurology is extremely underserved everywhere. It is impossible for neurologists to take care of all of the neuro patients. So everybody has to learn neurological care because the neurologists are unable to take care of all of the patients. We end up seeing the most complex, the most severe, the most difficult. But stroke kills 1 out of 19 people in the United States who die. So it's really extremely costly and produces a lot of disability. In terms of headaches, 60% of people has some type of headache constantly, and the lifetime prevalence is higher than 80%. Right now, I'm having a migraine, so if I start speaking in Spanish, you know what happened. I lose my language when I get the migraines. And the prevalence is 16%. It's huge. It's affecting a lot of people and producing a lot of disability. And migraine, really, many patients do require, about 3% of the migraineurs, 3% of the population requires advanced therapies in migraine, things that sometimes general practitioners, not even general neurologists, are able to provide. And therefore, subspecialty care can be needed. And then seizures and epilepsy. So 1 in 30 people will get a seizure. So if we have 100 people here, we know that 3 of us will get a seizure at some point in our life, and 1 in 100 will develop epilepsy, and the projected 10% growth on national seizure volumes. So what's the difference between a seizure and epilepsy? A seizure is a convulsion that is produced by this imbalance of excitation and inhibition in the brain. Instead, epilepsy is a disease. And what's the criteria for diagnosing epilepsy at this point? You have to get 2 unprovoked seizures or 1 unprovoked seizure, and then a higher risk for a recurrence. And that would be an indication to start treatment. So we start treatment on everybody who fulfills criteria for epilepsy. Now, provoked seizures are those that are caused by something else, and what we need to fix is actually the cause of the induction of the epilepsy. And now the new classification of seizures has changed, but we are learning a lot about seizure pathophysiology. For example, we didn't know what was the event that was behind the interictal spikes that we see in patients with seizures, and it's due to paroxysmal depolarization shifts. And then when you have a lot of those at the same time, that's when you end up developing a seizure. Based on all of the new knowledge and the new therapeutics that I'm going to be reviewing, the new classification framework for seizures is more based on the onset rather than the final result of the seizure. So we based it on either focal onset, generalized onset, or unknown onset. And this helps us a lot in terms of deciding how to treat it and how to address these patients. The counseling, what do we do? What do we tell our patients when they have the first unprovoked seizure? What's the risk of seizure recurrence? Well, the chance for a recurrent seizure is greatest within the first 2 years after that one seizure. And, it's between 21 and 45%. At 2 years, the risk of recurrence for the first unprovoked seizure is 40%. And if you have a normal EEG and a normal MRI, that risk goes down to 25%. But if you have epileptiform abnormalities on EEG or a prior injury on the brain, then the risk is about 60%, which is equal to having a second unprovoked seizure. And that meets epilepsy criteria from the criteria that I just discussed. What increases our risk then for seizure recurrence? Those things that I talked about, and one more thing that is very interesting, and it's nocturnal seizures. So it's not the same to get a seizure during the day than during the night when it comes to risk of recurrence. So how do we go about treating epilepsy and the management of seizures? One unprovoked seizure, we do an EEG, we get the MRI. If all of that is normal, then probably we don't need to treat. But if any of those things are abnormal, then we do counsel the patient to consider treatment. 2 unprovoked seizures, it means epilepsy. And therefore, we need to not only do the workup, but also start anti-epileptics. And this is extremely important, guys, and because when you don't treat, the more seizures you get, the higher the risk of seeing more seizures down the road. So seizures seem to be epileptogenic themselves. So the more seizures you get, the more seizures you will get. And that's why we need to treat them properly. And then we have this concept that is extremely important, the medically refractory epilepsy. And that has been changing over time, but over the last 10 to 15 years, the diagnosis of this is that a patient who continues to have seizures, any number of seizures, despite being on 2 or more appropriate anti-epileptic drugs. So what that means is that if the patient is already taking 2 medications that should be fixing the type of seizure that they have, and they're still having a seizure once a year, once a day, doesn't matter the frequency, that is considered medically refractory epilepsy. And it's something that we must do, we must treat differently. We need to consider advanced therapies, including epilepsy surgery and neurostimulation. So what are the surgical interventions for drug-resistant epilepsy? You have surgical options and neuromodulation. In the surgical options, we have collosotomy, hemispherectomy, lobectomies, targeted resection, lesion surgeries, laser ablation. On the neuromodulation side, we have vagal nerve stimulation that has been out for a long time, deep brain stimulation, and responsive neurostimulation, which is the new kid in the block. So responsive neurostimulation was approved in 2013 for these patients. And the way it works is that the device detects the seizure is about to happen and produces a stimulation back to the brain to stop that seizure in its tracks. And it has produced a 75% reduction in seizure frequency compared to baseline at 9 years. And with improvements on quality of life, and what is more important, a reduction in SUDEP, which is the sudden unexplained death in epilepsy. And this is a big deal. Let's look at the results here. As you can see, the seizure frequency reduction changes, increases, improves over time. And that's sort of the trend here. It's like, the more seizure you prevent, the better the patient's outcome is going to be. For deep brain stimulation, this was approved in 2018. It has been used for movement disorders for a long time, but now for seizures in the anterior nucleus of the thalamus. It's an open loop system, and it has provided also a 75% reduction in seizure frequency on these patients who are treatment resistant. So that's a big deal. And you can see here the trend as well. The longer the system is working, the better the reduction in epilepsy. Let's talk about movement disorders now. which are neurological conditions that impair normal mobility or cause abnormal movements. They're classified as either hypokinetic, meaning loss of movement, lack of movement, and hyperkinetic, like tremors and dystonias. And they are extremely common. The prevalence of the common categories of movement disorders is about 30%. So what that means is that in this group, about a third of us will develop a movement disorder before we die. One of the common ones that I have listed there below. And there are a couple of things that I want to highlight. One of them is, we must not miss a certain list of diagnoses that are treatable or curable, and I have listed them there. The second one is that any patient with dystonia or with Parkinsonism at some point deserves a trial with levodopa. Dystonia, because dopamine responsive dystonias can be basically cured by giving the medication. So we shouldn't allow the patients to endure suffering long term. I'm gonna quickly touch upon a few of the movement disorders. So this is the tremor algorithm that we have developed and actually are testing in research, where we find what's the joint that is shaking, and then we ask the patient to move the joint and see if the tremor increases in amplitude or decreases in amplitude. It's a different way of thinking about resting versus action tremors. And when we diagnose a resting tremor, then we're thinking about Parkinsonism and all of the conditions that are listed there. But then when we're thinking about action tremors, we need to be thinking, we need to be splitting that into ataxic tremors and simple kinetic tremors. And the differential diagnosis is complex, and as I am showing there. But the tip for resting tremor identification is that if you have a joint that is shaking, then you identify it. In this case, is the wrist. You activate the muscle that shakes. And if the amplitude decreases, right, that's a resting tremor. But if you're moving the joint that is shaking and the amplitude actually increases, then that's an action tremor. It's a much easier way of thinking about tremor diagnosis. There are many treatment options for essential tremor, and we offer all of them here at Baptist, including active cancellation of tremor devices, the CALA trio device, which provides nerve stimulation from the wrist up into the brain, high intensity focus ultrasound, which is a lesional surgery. We are one of the main centers in the United States, have performed multiple of these procedures successfully, and also deep brain stimulation surgery, as we discussed previously. This is our protocol here at the Miami Neuroscience Institute on how we evaluate the patients with tremor for all of these advanced therapies and decide whether to go for HIFU or FIT for deep brain stimulation. And this is one of our patients within the OR, and as you can see, there is no tremor whatsoever. No tremor. Do you see the tremor? No tremor. Yeah. How about dystonia? Dystonia is excessive muscle contraction. It's excessive muscle spasm, and it can present in many different ways, as you can see in this picture. And our new classification is helping us, but how do we differentiate somebody who's shaking? Is it an action tremor, a dystonic tremor, an intention tremor, which would be a cerebellar disorder? And one of the things that we look for is a sensory trick. So if you have a cervical dystonia and the head is turning excessively, and you just touch the chin, and the patient is able to go back to normal, the neck muscles are very strong. Just by touching, you should not be able to stop the movements, right? So that's a sensory trick in French geste antagoniste, and it's very characteristic of dystonias and definitely absent in patients with essential tremor. So on dystonic tremors, we look for abnormal postures, we look for a jerky movement, and that helps us differentiate. Movement disorders are best cared for by multidisciplinary teams. Why? Because they're difficult to recognize and classify, the large and complex differential diagnosis, and many treatment options with an explosion of diagnostic tests and also treatments. So in terms of the diagnostics that we have been using in movement disorders lately, we're using advanced MRI systems, PET and SPECT. We're now doing SIN1 skin biopsies on patients with Parkinson's disease to actually find the alpha-synuclein and have a pathological diagnosis. We use electrophysiology labs and motor unit labs to define what we're seeing. The autonomic lab is key on many of our diseases. We use wearable devices to see how the patients are doing back home continuously during a long time. And we're also providing advanced genetic testings for many of the diseases that we treat, which now are starting to make a difference in the type of treatments that we're able to provide. For example, for Friedreich ataxia, which now has a treatment. And then we use a number of advanced therapeutics, including deep brain stimulation, HIFU, as I mentioned, chemodenervation, clinic using botulinum toxin, intrathecal baclofen pump, duopa pumps, subcutaneous pumps, the Cala Trio device that I discussed for tremor, and also the very specific genetic-based treatments. So movement disorders really are the best example of multidisciplinary comprehensive programs. And here you can see the many different type of people who are involved in the patients that we evaluate at the Miami Neuroscience Institute. And with that, I'm going to close and thank you for your attention. Our next speaker is Dr. Michael Enrique Gomez, and Dr. Gomez is going to be speaking about minimally invasive lumbar surgery. Dr. Gomez did his college here at the University of Miami, and then did his medical school in Tulane, residency at Parkland Hospital, UT Southwestern, and is a fellow of the American Association of Neurological Surgeons, board-certified neurosurgeon, and the director of minimally invasive spine surgery at the South Miami Hospital. Please help me welcome him.
Hi, good morning. It's like a change of pace going from the top to the bottom now. So I'll talk about advances in minimally invasive spine surgery. I'm a consultant with DePuy Synthes Spine. And today we'll understand the advantages of minimally invasive techniques, understand changing patient demographics, and also understand the array of tools at our disposal in spine surgery. Basically, we all know that we're dealing with an aging population. 70 is the new 60. And the most rapid increase in spine fusion rates has occurred in patients of Medicare age. We've seen a 138% increase from 2004 to 2015, for example. And lumbar fusions account for one of the top 3 areas of annual Medicare spending. So as the population ages, it's expected that the number of elderly patients with degenerative spine diseases requiring fusion will continue to climb, right? And so it necessitates a greater sort of characterization of the risks and benefits of MIS surgery in the elderly. In 2015, the total cost for elective lumbar spine fusions was estimated to be $24.3 billion. It's a 152% increase since 2004. So the considerations when planning surgery include bone quality, presence of a deformity, and the patient's comorbidities. So one of the things to consider is bone quality, right? Osteoporosis, currently estimated to be a major public health threat. 80% of women will deal with it. At least back in 2005, the economic burden was $17 billion. And in spine surgery, it contributes to hardware loosening, contributes to subsidence where the implant sinks into the bone, and it also leads to vertebral fractures. Essentially, these patients will over time experience worsening degenerative changes. So that causes new problems in spite of successfully treating the original problem. So we're talking about people who've had a lumbar discectomy and then they have a recurrent disc herniation in the future, recurrent spinal stenosis. They develop instability or a deformity after undergoing a decompressive surgery. And it's all because degeneration results in a deformity. And so these patients will then require some sort of revision surgery for stabilizing the spine, correcting a deformity, or if they've had a prior instrumentation, they need extension of hardware. So we've already shown that MIS surgery, has comparable fusion rates and functional outcomes compared to open procedures with less associated morbidity. Basically, the MIS approaches result in lower blood loss, reduced tissue trauma, less postoperative pain, which means that we can get those patients up and moving around sooner and potentially even going home same day as surgery or the following day. So I kind of group the advances in minimally invasive spine surgery into approaches, into the retractors, into the material development, and finally navigation and robotics. So basically, the cartoon on the right shows all the different approaches to the spine, right? You can operate on the spine from the front, from the side, from the back. Traditionally, the spine's been approached from the back, which requires bigger incision, lots of muscle retraction, greater blood loss, more inflammatory changes. And so the idea of minimally invasive spine surgery is to take traditional approaches and then try to find a way where you reduce the tissue trauma by utilizing either alternative approaches, so addressing the disc issue rather than from the back one and from the side or from the front, or if you have to go from the back, then using different retractor systems so that you can create less tissue trauma in the end. So I'll start with retractors. The retractor technology has really allowed us to address the spine by sort of taking notes from general surgical literature and approaches and applying it to the spine. So one of the biggest advances has been the use of tubular retractors and expandable retractors that rather than making, say to approach the spine from the side, rather than making some big shark bite, with a thoracic surgeon, we're able to make a small 1 or 2 inch incision. The retractor goes in closed, you open it, and then you basically have a nice view of the spine. And then with lighting technology, LED lights, we get to visualize the spine nicely, and that helps to reduce our complications. So on the left, for example, you see a muscle splitting technique where on one side we're using percutaneous screws, on the other side we're using a small retractor to expose the spine. In the middle, traditionally ALIF surgeries, an anterior lumbar fusion surgery, required a big exposure in order to let light into the spine. And in this case, the retractor's small, it has a nice little LED light that allows you to work through a small incision and still get the same visualization you would with a big incision. And finally, all the way on the right is a lateral lumbar interbody fusion where it's a lateral retroperitoneal exposure to the spine. And we use expandable retractors in there that either split the muscle or move the muscle out of the way completely with a nice LED light, which lets us do our work safely. Materials are a big deal, right? We talked about aging population, right? And so spine surgery is not one size fits all, and we have to account for bone mineral density. And so the idea, 20 years ago, we used cadaver, fibula strut grafts, but that bone's really hard. And so now we're typically using titanium cages that are laser cut. And so it helps to match the modulus of elasticity of the patient's bone. And the modulus of elasticity is essentially, it's an index of how hard or how soft an object is, right? So the whole idea is to match the hardness of the implant to the hardness of the patient's bone. Expandable cages sort of further that idea where rather than forcing too big an implant into a space and risking rupturing the vertebral body, we place the implant in closed and then gradually jack it up in order to restore disc space height. Allograft is a big deal. Traditionally, we would take harvest rib, harvest iliac crest, and patients will recover from the surgery, but they'll complain about the iliac crest harvest for years. So we're using cadaver bone with mesenchymal stem cells to essentially stimulate the patient's bone to grow and fuse that segment. And then going back to the topic of osteoporosis, there's times where we really need a solid anchor point for our hardware. And so by using screws that are fenestrated, they basically have little holes around the edges of the screw, we can inject cement through those screws to give us a more solid anchor point, and that allows us not only to correct deformities, but also to get a more solid fixation of the spine. Then finally, we come to navigation. This is kind of one of the biggest developments in the last 10 to 15 years. In brain surgery, we've used navigation for many years now. And so now we translated that to the spine, and we basically use a intraoperative CT scanner, and comes in, we scan the patient. We have a reference array that you can either clip onto the spine or you put it into the posterior superior iliac spine. And so we get the CT scan, we register it with a computer, and then that allows us to navigate our hardware, as you see there in the right-hand picture. And so what that's allowed us to do is improve our accuracy. In a 75-year-old spine, the joints are really big. When you're doing this without navigation, it's very easy to have your instrument skive, and sometimes it's hard to place the hardware effectively. So it allows us to size our screws properly. It improves accuracy, allows us to work through smaller incisions, and it also reduces our radiation exposure. So if you're doing 3 cases in a day as a surgeon, that is a lot of radiation you're getting. And we're wearing lead aprons, but your lenses are still getting it. It's and the patient's getting the radiation as well. So basically, the minimally invasive procedures are kind of split into two. The 2 most common are going to be an MIS T-lift, which is a traditional posterior approach, typically through 2 small incisions. Blood loss about 25 to 50 cc's. OR time is about 2 hours, 2 hours and 20 minutes. And the disadvantage is that we're working through a very small space between 2 nerves, so we have to use small implants. And if you recall, high school physics, pressure is related to force and surface area. So the greater the surface area, the less pressure you have exerted on a surface. So the smaller the implant, the more pressure on the bone. And when we're dealing with osteoporotic bone, there's a risk that implant kind of sinks in. So the alternative is a lateral retroperitoneal approach, similar blood loss, a little quicker to do, and allows us to use much larger implants. We basically can match the implant to the size of the disc space. So it's stiffer, there's more surface area for bone ingrowth, and it reduces the pressure at the bone implant interface. In the end, most surgeons are going to choose what they feel most comfortable doing, right? So with familiarity comes efficiency. So, most surgeons are going to choose a technique that allows for less blood loss, reduced tissue trauma, restoration of alignment, especially lordosis, which is the natural curvature of the spine, because that helps to reduce the stressors at the levels above or below. We want adequate spinal fixation and successful nerve decompression, and then the least amount of time under anesthesia. So this is a meta-analysis that looked at the outcomes and complications of minimally invasive T-lift in the elderly. And essentially, it showed that the overall complication rate in patients, this is kind of perioperative complication rate, is about 25%. And those are, there's major complication like a hematoma, infection, screw malpositioning, heart attack, PE, things that change how the patient progresses. And then there's minor complications, about 20%, which would be confusion after, say, Percocet or a muscle relaxant, UTI, anemia. What they found is that age does not affect the actual approach-related complication rate. So essentially, surgery is safe. The rest kind of has to do with the patient's physiology. There's a 90% fusion rate for single level at 2 years, which is comparable to an open procedure. And we're seeing a 6% adjacent segment disease rate, which essentially is the percent of people that then go on to require another surgery at another level. This is another systematic review article that looked at patients undergoing lateral lumbar interbody fusion, and essentially said the same thing, that elderly patients do not appear to experience a higher rate of approach-related complication, unless you're doing multiple levels, and it had a comparable fusion rate of about 90% at 2 years. So this is an example where we basically kind of threw everything we talked about at one patient. This is an 84-year-old lady, frail, with 48 hours of Koehne syndrome. So urinary retention, perineal numbness, severe lower extremity pain, and weakness. And she has severe stenosis at L4, L5 with a deformity. So we had to correct her deformity and decompress her nerves. This is her CT scan. And so basically we used a muscle splitting technique, so small retractor. In the sort of left side of the operative picture you see kind of what looks like a little antenna there, and that's what we use for navigation. The little towers that are coming out of the skin are percutaneous screws. So we're doing 2 small incisions, minimal blood loss. We are using paddle distractors to distract across the disc space, and we're using a laser-etched titanium interbody cage to match the modulus of elasticity. And then finally, in order to completely pull that vertebra back, we use fenestrated screws with cement. And then on the right-hand side is a post-operative film, I think at 3 months after surgery. So nothing loosened, nothing slid. The patient recovered her lower extremity strength. She recovered her bladder function. And I think at 6 months, she was doing well. So MIS techniques allow surgeons to tailor their surgical approaches to patient needs, anatomy, and medical comorbidities. They provide equivalent outcomes to traditional approaches. And so I think that whenever possible, we're sort of, we're obliged to try to use the least invasive approach as possible. And then even with minimally invasive options, elderly patients are always going to be at an increased risk of complications just based on their own physiology. And so by sort of tailoring our approach, keeping surgery short, trying to minimize blood loss, we can hopefully reduce those complications. My references. Thank you very much.
Very good. Our next speaker is Dr. Guilherme Dabous. He is our director of the Fellowship Program of Interventional Neuroradiology and Neurovascular Surgery here at MCVI MNI, and trained at the University of Campinas in Brazil, and had a neuroradiology fellowship at Northwestern, and then interventional at the Mallinckrodt Institute in Washington University in St. Louis, and also in Harvard. He is the current vice president of the Society of Neurointerventional Surgery, and is going to be speaking to us about the management of carotid artery stenosis. Please help me welcome Dr. Dabous.
Thank you, Diego. Thank you very much for the very kind introduction. So we're going to be talking a little bit today about carotid artery revascularization with like an emphasis on the stenting techniques, including carotid angioplasty and stenting transfemorally, as well as TCAR. So these are my disclosures. I'd like to acknowledge that, our carotid disease team here at Baptist is truly a multidisciplinary team. We have like interventional neuroradiologists and the vascular neurosurgeons. We have our vascular surgery colleagues as well, both at Baptist Hospital as well as South Miami Hospital, as well as our interventional radiologist friends. And a lot of those cases we discuss together, a lot of times we're scrubbing together. So I think it's important to really keep in mind that we do use this multidisciplinary approach. There's 3 great modalities to treat carotid disease. And I think it's very important with the support of our friends from cardiology that do most of the medical management to really have that vision of a cohesive, collaborative effort to treat these patients. I would like also to thank my colleagues at the CREST-2 Interventional Management Committee. I'm part of the CREST-2 committee for many, many years, and I reviewed like probably hundreds of interventionalists around the country to allow them to participate in CREST-2. So basically, interventional neuro is basically a discipline that we're part of MNI nowadays, but we're directly and intrinsically related to MCVI as well, since we use the vascular system to achieve our end organ, which is the cerebrovascular system. And basically, I like to see this as the intersection between 2 really great institutes here at Baptist, and really allows for treatment of all the cerebrovascular diseases that we perform, again, with the help of our colleagues from vascular surgery, interventional radiology, cardiology, neurosurgery, neurology, everybody. So basically carotid disease. So there's one big picture that we want to really talk about, is that if you look into a carotid plaque, usually calcified, fibrotic, irregular, soft, hard, no matter what you see, we see that the end result of this a lot of times may be this. And this is what we want to prevent. What you're seeing here is basically an infarct, cerebral infarct on a pathological specimen. So basically, the whole idea is to prevent the carotid disease from causing this type of problem. Now, how did we get there? How do we start treating carotid disease more aggressively? Well, the first study from the 80s actually was the NASCET study. The NASCET study pretty much randomized people to medical management, which at that time was pretty much aspirin versus endarterectomy. And what the NASCET study showed is that if you have a symptomatic lesion greater than 70%, the risk of you having a stroke if you're not treated aggressively with surgery was extremely high compared to if you had endarterectomy. And this led basically to, okay, so now we understand if you have a symptomatic carotid disease greater than 70%, you do need to have to be treated. And basically, you know, endarterectomy has been the main treatment for carotid disease in many, many countries because of its availability and because of the data about it. However, more recently with the advent of stents, really we had another alternative to treat these people with carotid stent. And a lot of places this is the main alternative. And carotid stent has been studied throughout many, many years. And one of the things that we notice with it, as you can see here in this graph, is that the experience, and as time goes by, our complication rate for carotid stent decreased significantly. So which put carotid stent in the mapping. And this led to the CREST study. The CREST study was basically a randomized study compared endarterectomy to stenting, angioplasty and stenting. And it was a beautiful study for symptomatic patients mostly. And what the CREST, which is this, we're going to refer as CREST 1 because now we have CREST 2. But what CREST 1 showed is that the overall results are very similar when you talk to a composite of death, stroke, and MI. However, there's a slightly greater risk of stroke or any stroke in the stenting arm compared to the endarterectomy arm, even though the numbers were pretty much similar on the composite outcome. At the same time that the MI rate was higher in the endarterectomy arm. However, when you split up the stroke that happened in both arms, you're going to see that the vast majority of the strokes that happened in the carotid angioplasty and stenting arm were due to minor strokes. So then you're now comparing, this created a lot of debate, of course, in the vascular surgery community, interventional radiology, neuroradiology, neurosurgery, and neurology communities, because, you know, what does that really mean? So you're talking about if the overall results are very similar, there's no difference. However, there's more MIs on the endarterectomy arm, and there's more minor stroke in the angioplasty and stenting arm. So the CREST 1 investigators actually looked into that, and what they were able to show is that MI was a predictor of mortality in the long run, whereas minor stroke, of course, was not. So basically, it's worse for the patient to have an MI than to have a minor stroke. So I think that's a very important thing to take into consideration, because when you're talking about, oh, there's more stroke in the angioplasty and stenting arm, that's actually mostly because of very minor strokes. The other thing that the CREST actually showed very interesting and counterintuitive is that the people that did better with carotid stent were actually the younger patients compared to the endarterectomy, which were actually on the older side. And this has to do mostly with the anatomy of the patients, the difficulty of crossing lesions, and tortuosity of older patients, and worse plaques probably on the older population, which actually leads to probably, you know, a little bit increase in risk for angioplasty and stenting the older the patient gets, particularly if they're older than 80 years old. Now, when you're talking, so this was like for symptomatic patients. So there was no question nowadays that a symptomatic lesion, nowadays we treat symptomatic lesions above 50%, they need to be treated aggressively with either endarterectomy or stenting. When we're talking about asymptomatic lesions, it's not so clear. There has been a lot of studies like from years, from the 2000s, the ACST, the ACAS, but it basically showed that compared endarterectomy to asymptomatic lesions that were treated, randomized to endarterectomy versus medical management, and again, medical management only with aspirin at the time, with stenosis that were greater than 60%, those patients did do well, but this result was not as significant as it was for the symptomatic lesions. The difference is about 1% per year for the patients that were treated with endarterectomy versus 2% per year for the people who were treated with only aspirin, which is not even the medications that we use nowadays. We have much better medication to do that. So this marginal question still, you know, induce people to be treated for asymptomatic lesions, but it's not as clear as for symptomatic. So more recently, the ACST2, which was a randomized trial compared carotid angioplasty and stenting to endarterectomy in asymptomatic patients, did show similar results as the CREST-1, which was for symptomatic, which that means that the results were very similar in both arms. However, the minor strokes were more prevalent in the angioplasty and stenting arm, but those are really non-disabling minor strokes. So what does that mean? Pretty much, probably not a lot. You see here in the graph, it's very clear. When you talk about all the results, there's a little bit more stroke in the angioplasty and stenting compared to the endarterectomy. But if you exclude the minor strokes, which is non-disabling, actually the results are very, very similar. You see both curves really interact similarly. The other thing that we know is that there's some new data that actually asymptomatic carotid disease is actually may not be as benign as we initially thought. And actually the risk of having a stenosis or a stroke, if you have an asymptomatic lesion greater than 70 and more importantly, greater than 80%, can be significant, up to like 15 to 20% in 5 years, which puts you, about like 3 to 4% risk of stroke per year for asymptomatic lesions greater than 70%. Now, as I told you, we don't know exactly right now if asymptomatic lesions do necessarily need to be treated with intervention. And why? Because we have a lot of new medication. We have statins, which were not used for the ACST or for ECAS. And of course, we use them nowadays. We use much better blood pressure control. We use much better diabetes control. We use dual antiplatelets sometimes. So basically, there's a big study being done, which we're part of, which is the CREST-2, which is basically randomizing patients. To asymptomatic patients greater than 70% to either medical management on the current standards of statin, dual antiplatelets, blood pressure control, diabetes control, modification of risk factors, versus intervention. The intervention could be either carotid angioplasty and stenting or endarterectomy. So basically, that's the discretion of the center to make that decision. And of course, actually the surgical arm just finished enrollment a few months ago, and now we're waiting for the carotid stent arm finish enrollment. So hopefully with the follow-up in the next few years, we're gonna have the results of the CREST-2 trial, which probably will determine if asymptomatic carotid disease should be treated aggressively or not. So carotid stent, why? Well, it's pretty straightforward, patient comfort. Disadvantage requires dual antiplatelets compared to endarterectomy, of course. But it's a very straightforward procedure, technically speaking. If you have a well-indicated case, these procedures tend to go very well. And you have here an example, very irregular asymptomatic patient, very irregular plaque. You use this little, I don't think I have a pointer here, but it's okay. You put this umbrella-like device, which we call like a distal embolic protection device. So what that does is that when you do the angioplasty and put the stent, it captures any kind of piece of plaque or lipid core or anything that can actually go up there, potentially cause embolization, is captured on that filter. As you can actually see here, there's like a real filter with a little bit of debris inside. This is a typical case, symptomatic patient, small stroke, non-disabling, but comes in, has a severe carotid stenosis, fairly young patient. You see the velocity is extremely high. That's like 80 to 99% carotid stenosis. And then you see here on the angiogram, you have really a tight stenosis at the origin of the internal carotid artery. And then you pass a filter. This is the filter device. And then you do the angioplasty and place the stent with a very good result. We usually follow these people only with a duplex. So you can actually see here on the duplex, the velocity, which are like 500 over like 150. Now it's like 54 over 21, which is really like, systolic and then diastolic with very good results. Another case here, typical case, patient comes in with a stroke, we treat them, but then they have residual carotid stenosis, we bring them back with antiplatelets, and then we treat them straightforward, putting the filter up there on the distal carotid, do angioplasty pre, put the stent, sometimes require angioplasty post, and this is the final result, and this is usually very durable. This patient will have no problem, very likely for the rest of his life. There's another plaque here. We use a lot of different modalities to do. This is a CTA demonstrating a very regular ulcerated plaque here. Again, this is a 3D reconstruction of the angiogram. You can see exactly where the plaque is. And this, just showing like a very nice result. We don't look for a perfect result, look for a durable result, which a lot of times just, improving in the flow to less than like 20 or 30% residual stenosis is usually pretty good to achieve that, okay? Now there's another modality, which we call TCAR, it's transcarotid artery revascularization, which is angioplasty and stenting, but with like a direct incision in the neck, with a sheath placed directly in the neck, And then with flow reversal as a protection device, which is very robust and works very well, it's where the angioplasty and stenting is done. This is a procedure that has gained a lot of traction over the last few years, particularly in the vascular surgery community. The results are good, but does require an incision. You know, it's been used for a lot of people that could potentially, or that cannot have like an attracting for risk factors, and it has been done. And you know, the same disadvantage of for carotid angioplasty and stenting transfemoral is that it requires dual antiplatelet agent. So some people may not be on it and may not be advantageous to be on them. So endarterectomy may still play an important role for some of these patients, okay? So why again TCAR and why not carotid angioplasty and stenting on a femoral or transradial approach? Because sometimes you find arches like this, and that makes it, or even like internal carotids, which are extremely tortuous, that makes it very difficult to catheterize through the femoral or through the radial, or to go up there and put a filter on like a vessel that is very tortuous because the filters are fairly stiff. So that's a problem. So how does the carotid TCAR works? So basically the vascular surgeon, or any surgeon actually that is actually certified to do this procedure, does an incision, supraclavicular incision, finds the common carotid artery, put a ligature around the common carotid artery, punctures the common carotid artery distally, okay? And then they create basically through a sheath on the femoral vein, they connect the sheath in the common carotid artery to the femoral vein. And because of the system here, which has a filter here, it creates a flow reversal, which is very, very robust. If you've done these procedures, you can really know how robust the system is. And then when they're ready to do the procedure, they ligate temporarily the common carotid artery to completely reverse the flow. And then very simple, I'm sorry, I'm just going to show here. You pass the wire, you do the angioplasty with the flow reversal, then do the angioplasty, put the stent, and you see here, sometimes you get a lot of debris on those filters, which is impressive because it's very uncommon to get debris in the filter when you're doing a carotid stent with a distal embolic protection device. But in TCARs, you see usually a lot of debris. It could be because of more aggressive angioplasty, but it's still like, it's a great result. And the results are very good. The studies had shown great, very promising results with very low risk of complications such as stroke or MI. Another case here really quick, again, severe stenosis, angioplasty and stenting with a TCAR. You see the spreader here. And you know, the important thing about this is that, you know, some of these people have follow-up MRIs the next day, and really there's not even like a little dot, just proving that the flow reversal that you achieve with this connection between the common carotid and the femoral vein is extremely very, very robust. Okay, so just the takeaway points I want to say is that treatment of carotid disease has really progressed a lot. We have carotid angioplasty and stenting, we have TCAR, and you know, we have better medical management options. And we still have endarterectomy, which is a great method, okay? Current evidence does support treatment of symptomatic carotid stenosis greater than 50% and asymptomatic greater than 70 or 80%. Keep that in mind, it's extremely important. This has just been approved by the CMS in the United States, so basically that means that we can be reimbursed for this type of treatment. As I mentioned, we don't really know if asymptomatic stenosis should be treated with medication or invasive methods. This result will actually, what's going to determine this is going to be the result of CREST-2. So, you know, keep a look on that for that. Like it's probably going to happen the next few years. And then it's important to address this case in a multidisciplinary way to really tailor the best treatment option or best treatment option for a specific patient. I appreciate your attention. Thank you very much.
All right, that'll conclude the neuroscience section. I'm going to make sure all the attendees get all of our emails. I'm going to make sure that my presentation is converted to a PDF format. I'll send it to you with my email and cell number, and then we'll make way for the cardiac and vascular session next. Thank you very much.
Okay, so this is fast moving. And I apologize with some hiccups, but patients come first, and we've had to take care of some of our patients. Next, it's my pleasure to introduce to you the experts of Baptist Health Miami Cardiac and Vascular Institute. The moderator for this module is Dr. Tom Nguyen, our newest addition and Chief Medical Executive, Director of Minimally Invasive Valve Surgery, and the Barry T. Katzen Endowed Chair. Joining him is Dr. Govindarajan Narayanan, Chief of Interventional Oncology, They turn my page. Here we go. Chief of Interventional Oncology, Dr. Joseph McGinn, Chief of Cardiac Surgery, Dr. Ramon Quesada, Medical Director of International and Structural Cardiac Innovations and Research, and Dr. Constantino Peña, Medical Director of Vascular Imaging. As many of you well know, MCVI was our first center of excellence that we would market internationally, and we're really proud of this team that we have here today. And so with that, I will ask the physicians to join us.
Should we just start? All right, good morning or good afternoon, everyone. My name is Tom Nguyen. I'm the Chief Medical Executive at MCVI, and we are really honored and excited to really lead into this next session here to showcase a lot of the exciting things that we're doing at the Miami Cardiac and Vascular Institute. As many of you know, probably don't know, for the first time in U.S. history, migration patterns are to the east and the south, and a lot of people are actually moving to Miami. And it's a great place to be right now at the MCVI Institute. So this next session, what we're going to do is we're going to showcase and highlight some of the really exciting things that we're doing here, and just a kind of small fragment of some of the things we're doing here in cardiac surgery, vascular surgery, interventional radiology. So I'll go ahead and start. If we can have my slides, please. So I'm going to talk a little about minimally invasive heart surgery. The future is here. These are my disclosures. You know, I'm a minimally invasive surgeon, but what I really believe in is a lot of transcatheter therapies. And as a surgeon, I really appreciate the future of our specialty in our field is really in transcatheter devices. This is us doing one first-in-man mitral device when I was in Houston, Texas. And it's pretty clear that, you know, we live in a world of wires right now, and that's where the future is. People want small solutions to complex problems. And we're right here in Miami, and many of you are kind of scattered around the world, and we really appreciate all of you being here. And it's a new era of Tiger. This is Mick Jagger 6 weeks after a transcatheter aortic valve replacement. I do a lot of complex open surgery. I do a lot of minimally invasive surgery, but have to admit, you know, I probably can't get someone to dance like that 6 weeks after a procedure. We're operating now not only on septenarians, octogenarians, and nonagenarians, but also centenarians. They're actually doing really well. And the top right panel is explosive growth of TAVR in the United States and beyond, and many of you have probably experienced TAVR as well. This is aortic valve universe, looking at the STS and the NCDR database. And in 2016, something unique happened where TAVR exceeded the number of surgical isolated aortic valve replacements. It's something kind of really unique and special happened in 2019, where TAVR exceeded all forms of surgical aortic valve replacements. That includes combined cases as well. So it's pretty clear that this is the future. And the mitral space isn't really that far off. This is surgical mitral valve replacement, and the middle line is transcatheter edge-to-edge repair. And you see that we're heading in that direction. Actually, in Germany, there are actually more TEER performed than surgical devices. In the United States, about 33,000 patients with TEER that have been performed since 2021, and about close to 4,000 TMVRs in the United States. So it's pretty clear that the future is there. But as we increase our volume, we're actually improving our quality as well. This is mean length of stay of TEER. As you see, as a function of time, the length of stay is continuing to decrease. And also with TMVR, which was previously kind of a novel technology, the outcomes continue to improve. So as cardiologists, interventionalists, and surgeons, this is kind of what we see ourselves as. And you know, many cardiologists, interventionalists will pride themselves on kind of small incisions and Band-Aids, and most surgeons will kind of pride themselves, the bigger, the gorier, the better. But my bias, and I think the way we kind of frame the MCVI Institute, is something that's very multidisciplinary, very collaborative, And my bias and our bias is that the future is really kind of very disease-specific approach to care. And really the super physician is a super hybrid team where we're actually able to do both, be very collaborative, and approach things very openly, but also very minimally invasively as well. This is a editorial from one of the cardiology journals, and the authors write, in the current era, interventional cardiology is becoming more and more invasive, while cardiac surgeons tend to prefer minimally invasive techniques. A hybrid strategy is a combination of tools available in the cath lab with those available in the operating room in order to gain maximum profit for both of them. So it's pretty clear that we need to more lean towards a direction where we're doing a little bit of both. We also believe that as a specialty, we need to be kind of multidisciplinary, because it's pretty clear that if you have a hammer, everything looks like a nail. So we need to really kind of tap into each other's expertise as much as possible. But the reality is what patients want. And patients, don't want a 1/4-inch drill, they want a 1/4-inch hole. So patients really don't care or know who's doing the operation. They just want to feel better. And that's our goal, to make sure they feel better. They don't know what an interventional radiologist is. They don't know what a minimally invasive cardiac surgeon is. They just want to get their mitral valve regurgitation fixed and go home and feel better. That said, it's pretty clear that patients don't want a sternotomy. And I haven't had any patient come to my office begging me for a sternotomy. And thus we see the big explosion in transcatheter devices. So this is how we've done surgery in the past, and this is how we do it present in the future, through minimally invasive approaches, through smaller and smaller incisions. This is a patient that we did a minimally invasive aortic valve replacement on. This is a present, this is a future. And I think if we're doing the same thing in the future that we're doing in the past, I don't think we're making progress. I think this is how the future really looks like, with minimally invasive incisions, small techniques with transcatheter approaches. But I think that personally, the exciting thing about our future is that if you look into the future, we really don't know what the future will bring. It should be something novel, something that we haven't thought about yet. And hopefully a lot of that technology and birth will happen here in Miami. So the next part of my talks will focus on the aortic valve and the mitral valve. First, aortic valve disease. I do a lot of my aortic valve either via a transcatheter approach or through a minimally invasive approach. And I always talk about safety to try to address the pathology and the incision location. I think we are very confident doing this via the minimally invasive approach through a right thoracotomy. It can be very straightforward with a stepwise approach. We have a lot of surgeons who come and visit us and try to learn this technique. This is a patient with a bicuspid, a Siever's type 0 bicuspid valve. As you can see, you have a very direct view of the mitral valve, of the aortic valve there. We use these long shafted instruments, and one of my mentors and bosses would say that, there's like chopstick surgery. And I'll say, well, you're not going to teach you how to use chopstick surgery. Here's, chopstick surgery 101. So we can do that there. But also, he sometimes feels like it's complicated. So there's even easier ways to use chopstick surgery by these tools here. But I do think that the future really involves kind of long shafted instruments, minimally invasive approaches. People always ask why right thoracotomy as opposed to a upper hemisternotomy. My bias is I think it avoids, it preserves sternal stability. There's less bleeding. There's faster recovery. It's more ergonomic. And in some ways, actually use it for higher risk patients. So that's kind of the contrary. People say, oh, you should use it for low risk patients, but for the high risk patients are the ones that I think the minimally invasive approach is better. At the very bottom is cosmesis. It's probably the last reason why I do it, but it's a benefit for some. This is a testimonial from a patient who had a minimally invasive approach. How long ago did you have surgery? Approximately a week ago. So that patient had a surgery 1 week ago, and he's in our clinic and doing well. People ask why a right thoracotomy. So next time you look at a CT scan or an angio, the aortic valve actually points towards the right chest. And if you do upper hemisternotomy, there's a lot of rotation you have to do to kind of get that valve into place. So ergonomically, it does make sense, to me at least, to approach the aortic valve via the right chest. It doesn't necessarily increase OR time. In fact, when we do the operation, it takes less time to do it minimally invasively than via a sternotomy approach. So when you do a sternotomy, this is what you're being exposed to, the aortic valve. What you see there, when you do minimally invasive, that's what we see. We still see the same thing without having to open the entire chest. So it makes sense to be able to do it minimally invasively if possible. So again, to the left sternotomy approach, to the right minimally invasive approach. See, we see the aortic valve just the same. There are definitely benefits, even in elderly and frail patients. In fact, again, these are the ones that we prefer the minimally invasive approach. Even obese patients, we prefer the minimally invasive approach. And then those with poor ejection fractions. And even those with multiple comorbidities. That doesn't necessarily shy us away from doing the minimally invasive approach as well. So again, you see a very direct en-face view of the aortic valve. Here, the valve is being implanted. And I'll skip the cannulation, but we're leaning towards a lot of percutaneous cannulation approaches. We don't do cut downs as much anymore. when we do cannulation for put the patients on cardiopulmonary bypass. Really quick summary of a mini AVR. So this is a patient, that's the incision we have. We'll make a small incision in the upper right chest. I will go between probably the second or third intercostal space. We'll divide the internal mammary artery, the right internal mammary artery. And I found that hasn't really been a consequence of at all. And that said, we're pretty aggressive about using bilateral mammaries when we can, but I have to admit, it's rare to need to use bilateral mammaries in a 70 or 80-year-old. So we'll divide the right internal mammary artery. I actually stopped shingling the rib. I found like we don't need to do that anymore, and I can get pretty good exposure without having to do that. We'll put in a soft tissue retractor to really kind of push the soft tissue to the side. And sometimes you'll see a lot of adipose tissue there, a lot of fat. You just gotta be careful, slow and careful about removing the tissue. And then in a little bit, you'll see that we have excellent exposure of the aortic valve. So here we're actually entering the pericardium. I like to enter the pericardium right at this junction between the aortic valve and the right atrium. There's usually a gap there. I can enter that pericardial space pretty safely with the Bovie cautery without having to worry about really injuring anything. If you look, you see the aortic valve is still pretty medialized, and I'm pretty aggressive about pericardial retraction sutures. And that really kind of drags the aortic valve into view, and you see the aortic valve aorta right there. And here we're exposing the right superior pulmonary vein. I put an LV vent for drainage, put a CO2 line to help de-air later on. And now we're putting in the LV vent, again, to help de-air whenever we eventually take the clamp off. I'll kind of skip through this for the sake of time. So now you have the aortic valve exposed. We're going to size, and we conduct the operation kind of similar to the typical aortic valve replacement approach. Switch gears to the mitral valve a little bit. My approach to the mitral valve is through a lateral right thoracotomy. I believe that the lateral thoracotomy actually has a very direct en face view of the mitral valve, and for many of you, I think you should really appreciate that the mitral valve is a very vertical and posterior structure. So the best way to approach the mitral valve is actually via the right chest, via lateral approach, as you can see there. So ergonomically, I think the best way to approach a mitral valve is via the right chest. And just so happens, if you go to the right chest, you can make a small incision or a big incision. We tend to make a pretty small incision with the right chest. Even obese patients actually think it's a lot easier to do mitral surgery through the right chest. As you can see in this picture here, if you did a sternotomy, you have to go through all that layers just to get to the mitral valve, but that's our small incision there, and we have a perfect view of the mitral valve, again, even through obese patients. The top panel is in a sternotomy. You see you have a very canted view of the mitral valve, and the bottom picture is a mitral valve through a right thoracotomy, a very direct en face, direct view of the mitral valve, as you can see here. So this quick video goes to our standard minimally invasive mitral valve repair. Again, 2 surgeons working at the same time. Usually we're done skin to skin about 2.5 hours or so, very small incision. I'm entering the chest while my assistant works on the groin. Here we've cross-clamped, we've opened up the left atrium. We're exposing the mitral valve. You can see you have a P2 prolapse and a flail. My approach is usually to use neocords. I usually put at least probably 5 or 6 neocords into the papillary muscles and then into the edge of the posterior leaflet. We test again, and we have a pretty competent mitral valve there. So again, probably in and out of the OR in 2.5 hours. And the last thing I want to talk about is some more complex things we do at our program, which is TMVR in MAC. And this is a case that Dr. Casada and I were talking about yesterday during our valve conference. So this is a patient, 70 years old, mitral stenosis, severe MAC, pretty high risk. This is what you see if it's the cardiac surgeon's room. When you see that, it's going to be a long day, and especially when you see that, it's going to be a tough operation. When we see this operation, this is what you get kind of nervous about. And again, for the AV, for the surgeon's room, this is an AV dissociation, and that's kind of the dreaded complication in cardiac surgery. When that happens, you have to call home and say you're gonna be home a little late for dinner that night because it's gonna be a long, long day. But I'll advance a little bit to the way we do it for these patients with severe mitral annular calcification. We always try to prefer a transcatheter approach if possible, but if we can, we try to do a open, minimally invasive transatrial approach. I'll advance to the technique slide in a second. That's some data just kind of showing the pros of using the transatrial minimally invasive approach. And again, even for obese patients. So here we have exposure of the valve. Now I'm opening the pericardium for the mitral valve. Again, it's all about exposure, using the pericardium as your friend and really kind of pull the area of interest into view. Here we have the valve exposed. You can see a very calcified valve. We put annular sutures around the mitral annulus. Some parts of the mitral annulus is pretty thick, and it's actually hard to put the sutures all the way across, but we do the best we can. Then after that, what we do is we size a valve. The way I like to size a valve is we use a lot of CT guidance beforehand, about balloon size in the operating room to get a good idea of what size to use. Most of the experience so far has been with the SAPIEN valve, and most valves are either a 26 or a 29 valve. This one ended up being a 26 S3 valve. We prepare the valve on the back end. I usually suture a felt skirt around the valve itself to minimize the risk of paravalvular leak. And I'll have our assistant do that while we are in the chest. And then we'll deploy the valve, as you can see here. And we've been leaning towards initially a 50-50 deployment, but now I've been leaning towards more of an 80-20 deployment to make sure that the valve sits in the atrium as much as possible to minimize the risk of any left ventricular outflow tract obstruction. So then this is completion. As you see here, the mitral stenosis is essentially gone. You have a competent valve. We'll anchor the valve with the surrounding sutures. So significant increase in mitral orifice area before, after, pretty big increase. So as I wrap up, I think it's pretty clear we live in a world of wires. This is how we've thought about physicians in the past, interventionalists, surgeons, small incisions, big incisions, but I think the world is moving very different. I think we need to be thinking about hybrid approaches, multidisciplinary approaches, and I think the future of our specialties, future of medicine, is really towards kind of a super hybrid surgeon, a super hybrid program where we're doing all the above. I want to wrap up with kind of this Venn diagram of knowledge and to kind of emphasize the importance of teamwork and the valve team and the heart team and everything that we do. So there are things that we know, there are things that you don't know, there are things that you don't need, that you don't know. So the things that you don't know, obviously that's where teamwork comes in and why that's important. But sometimes there are things you think you know, but you don't know. And that's why I think teamwork's important. And then lastly, I think sometimes there are things that you don't even know that you don't know. So I think that's where teamwork is important. So as I wrap up, this last video really highlights the importance of teamwork and everything that we do and kind of watching each other's back and supporting each other.
Which one of you took all the Pepsi from the machine? Who did this? See? You're exposed. It's me. It's him. It's him. It's him. It's him. It's him. It's him.
So as I conclude, I wanted to thank you for your time. For the sake of time, I realize that we're holding you back from lunch. So we're going to try to make this as quick and efficient as possible. I want to introduce our next speaker, Dr. Narayan, who's the Chief of Interventional Oncology, for his talk. Again, thank you for your time.
Thank you, Dr. Wen. Good afternoon, everyone. Can I have my slides, please? So we're going to, first we'd like to thank Baptist International for the invitation, and from minimally invasive cardiac surgery, we're switching gears now to minimally invasive cancer care. So interventional oncology is a subspecialty of interventional radiology where we use imaging guidance to treat cancer with either needle-based technologies or catheter-based technologies. And we're proud to say it here at MCVI, we have the most diverse interventional oncology program in the country where we offer all the transarterial and the transneedle-based treatments. So today we're just going to feature one technology where we treat tumors using needles and using electricity as the energy, and that's called irreversible electroporation, or IRE. I'm going to talk a little bit about the technology, introduce it to you, and then some of the technical aspects, and then where we use it in different types of cancers, some of the challenges, and where it fits into our practice. So the commercial name of this technology is called NanoKnife, although there's no knife involved. It uses needles. So these are thin needles, about 19 gauge in size. And the technology has been around for a few decades, where they've used it to introduce a genetic material and chemotherapy into cells, but at the voltage of about 1,000 volts. And scientists at the UC Berkeley, when they were working with the technology, they found that when they increased the voltage to 3,000, they were able to create pores in the tumor cell membrane and cause tumor cell death without the use of chemotherapy, and it was called irreversible electroporation. And then the commercial name for that device is NanoKnife. So this is the third generation of the device, and what you see on the far left is what we call the generator. In the middle, you have the needles or probes. We call them electrodes. So these are called monopolar electrodes. You need at least 2 of them to create a treatment zone, and you can go up to 6 of these depending on the size of the tumor that we're treating. And on the far right is called the AccuSync device. Since we're delivering up to 3,000 volts of electricity locally to the patient, it can cause the heart to go into some kind of irregular beat. So what the AccuSync does is it's gated to the patient's EKG. It detects the rising slope of the R wave. It sends a signal to the NanoKnife machine, and the pulse is delivered during the refractory part of the cardiac cycle. And anytime you treat a tumor and you use 2 needles, the treatment time is actually 70 seconds, but the procedure itself, it needs general anesthesia and complete muscle relaxation. And once we have all the needles in place, we use CAT scan guidance to place the needles. You saw minimally invasive incision for cardiac surgery. Here we use even smaller, so you can call it minimally invasive. It's a couple of millimeters. So after we make the nick, we use CAT scan guidance, place the needles, and once they're in the appropriate position, we start the treatment. So why is this technology different from the other ablative modalities that we also use, which is thermal ablation, where we use heat or extreme cold to kill tumors? Here, because of its electricity, it's considered a non-thermal technique, so you're able to go near blood vessels and critical structures where we could not place needles in the past because of the risk of collateral injury. With IRE, the blood vessels have a collagen scaffolding which is not impacted by the treatment, so we're literally able to treat tumors which are about 1 millimeter from the vessel. Assuming that this is an animation of a tumor and we place these 4 needles, we can program the treatment pairs on the workstation. And once the needles are in place, like I said before, you start the treatment and the machine delivers 70 pulses between one pair and then automatically switches to the next, and that's how you create a complex area for treatment. The mechanism of healing is also different in these patients. This is a patient with metastatic neuroendocrine tumor. You can see the area circled in the left lobe of the liver, which was a metastatic deposit. After the IRE, you can see that the zone looks bigger and darker. And what you're seeing next is actually the 5-month post where the area is healed and you can hardly recognize the area. That's because the mechanism of healing for IRE is by apoptosis, whereas with microwave or cryoablation, you're going to have fibrosis and scarring, and therefore the treated area looks pretty much the same. What are some of the unique applications of this technology? Because of its non-thermal nature, we're able to treat tumors which are very close to blood vessels and other complex locations, such as colon, gallbladder, bile ducts, without having to displace those structures. We use it uniquely in the pancreas. 10 years ago, you would not think that treating pancreatic cancer without surgery would be a possibility, but currently we do the maximum number of percutaneous treatments of pancreatic cancer in the country with this technology. I'm not going to go into prostate, but that's another big area where this technology is used. Our urologists at MCI use it to treat prostate cancer. Once again, because of the non-thermal nature, it preserves the function and it's widely used in prostate cancer patients. A little bit about the data. This is one of the earliest publications. A few years after I used with IRE, we looked at about 158 blood vessels which were in close proximity to the treatment zone. Anything within 0 to 1 centimeter of the ablation zone was analyzed, And we found that of all the vessels that were treated, only 7 of them showed changes, and interestingly, all of them were in the portal vein, which could be secondary to the low flow state in the portal vein, and we had 1 patient where there was complete occlusion. So the overwhelming majority of the blood vessels were not impacted, and we concluded that this technology is safe, although it has been studied before that in animal studies. We were able to show that this was the case in humans too. So here's an example of a patient with a metastatic neuroendocrine deposit right next to the aorta. Before this technology, this is not a space where interventional radiologists would have a role to play. So this patient would require open surgery, which would be pretty big. And here now, with a couple of millimeter incisions, we're able to place the needle precisely right in the area where the tumor is involved. And the far right is the post imaging of the patient, where you no longer see the uptake. We'll switch gears to metastatic colorectal cancer. As one of my colleagues and friends in Amsterdam, they've done a lot of work with prospective trials using the same technology, which is IRE. And this is one of the most recent trials that they published called the ColdFire-2. And they treated 50 patients with 76 lesions using IRE. And the primary endpoint was met in the study with the local tumor progression-free survival of 68%. And the median survival from the first IRE was 2.7 years. Here's an example of a patient where we would use this technology, a solitary lesion, but in very close proximity to the artery and the vein. Again, without this, you would have to, if you use the thermal technology, you have the risk of injuring or damaging the blood vessels. The other option would be to go through the catheter and use particles to either radiate this whole area. But now with this technology, you can precisely target just that lesion. And that's the immediate post-scan of the patient, where you can see the blood vessel running right through the middle of the treatment zone. Here's the 2-month follow-up of the patient, where we still show the patency of the vessels. Another example of one of our patients here at MCVI, after resection for metastatic colon cancer, you can see the PET positive area, which was right next to the portal vein. And again, this was targeted with 4 needles with IRE. Immediate post, patency of the vein is maintained. 3 months out, the PET is negative. 29-month follow-up with no evidence of local recurrence in this particular patient. Moving to hepatocellular carcinoma, this is a technique you can also use in primary liver cancer. This is a space where we have multiple treatment options from interventional oncology, both needle-based and catheter-based. But some of the areas where we would bring in IRE would be tumors which are close to the bile ducts, gallbladder, and other critical structures where the volume is low and you don't need a transarterial option. This is another recent study that looked at the role of this technology in HCC, where they looked at 23 patients who had 33 HCC tumors that were treated. Again, these are smaller tumors. Median size was about 2 centimeters, and the local recurrence-free survival was 34.5 months. Here's an example of one of our patients. What you see as a dark spot in the liver was a previously ablated tumor with radiofrequency ablation. So that's a thermal technique. So you see the treatment area is dark. The patient had tumor recurrence right next to the recanalized umbilical vein, which was then treated with IRE. And at 15 months, you can see the thermal ablation zone still looks the same, whereas the healing with the IRE is different, and that area kind of blends with the background. Another patient with the tumor next to the gallbladder, this is a primary HCC. You would not place a microwave here because once you turn on the machine, it's going to burn not just the tumor, but also the gallbladder. So you have to do some protective maneuvers if you're going to use other techniques, whereas with IRE, you don't have to do those. This patient at 18 months did not have any local recurrence and went on to have a successful transplant. Switching gears to one of the most important areas which I'm passionate about, which is pancreatic cancer. About more than a decade ago, interventional radiology was mostly involved with palliative care and pain management and biliary drainage in these patients. And using this technology, surgeons were able to treat pancreatic cancer in an open approach, where they open the patient's abdomen and expose the pancreas and place the needles under direct vision or with ultrasound guidance. We've now taken that to a more minimally invasive approach and using imaging guidance. As you know, the cancer is a very poor prognosis, with 40% of these patients considered inoperable or stage 3 locally advanced pancreatic cancer. Even though it has not gone past the pancreas, the inability of the surgeon to get a clean R0 margin prevents surgery. And another 50% of these patients are not surgical candidates because they have the tumor has spread outside the pancreas to stage 4. So we badly need additional treatment options in these patients. And till now we had either chemotherapy or radiation, but now you have the third option. So this was the first human experience using this technique in pancreatic cancer that we published back in 2012. So just a small cohort of 14 patients where we showed that it was safe, but we were able to downstage 2 of these patients to R0 margin surgery. This was followed by another series in 2017 with 50 patients, where we showed that the median overall survival for these patients was 27 months from diagnosis. To put this in perspective, with the current standard of care, if you get 11 to 14 months with chemotherapy and radiation, that's a good thing for these patients. So we were able to almost double that, and that was also replicated in other studies around the world, in Amsterdam, in Japan, and the UK. If you look at that, you can see a signal to improve median overall survival from anywhere from 17 to 27 months in these patients. And once again, another prospective study from Amsterdam. This was a study looking at the safety and efficacy of IRE in pancreatic cancer. The difference between the other studies you saw on this one, this is prospective. And the study met the endpoint. These were patients who had induction chemotherapy and then were treated with IRE. And those who had induction chemotherapy with FOLFIRINOX met the endpoint of 17 months of survival after the treatment. So we then started the direct study with the FDA approval, which was a randomized controlled trial and a registry for treating pancreatic cancer patients. The study is closed. We did not have much success with enrolling patients for the RCT because most patients who were offered the registry took the option of getting treated. So there are almost close to 200 patients in the registry, but the RCT is currently closed. Going to leave you with an example of a patient who was given 3 months to live with a 4-centimeter pancreatic body tumor. Surgery was considered not an option in this particular patient. So here we are treating this patient with, with IRE. And so this is the immediate post where you can see, you don't see much difference when you look at it just when you look at the CAT scan, but when you're going to look at the PET scan of the patient before and the PET scan of the patient after IRE on your right, you're going to see a dramatic difference. So this patient had 2 treatments done back in 2016 and 2018, and currently somebody who was given 3 months to live is still out there playing golf, and they've stopped his chemotherapy treatments. So that's 19 months. So some of the complications you can have, like any other procedure, you can have bleeding and infection. There are potential risks with this procedure. And finally, we'll look at role of this technology in renal cell cancer. We can treat RCC in a minimally invasive way. This is a patient who was treated with cryoablation because it's more of an exophytic and easier location to treat. But when you have the same tumor involving the central part of the kidney, again, if you use cryo or microwave, you can cause collateral injury to those structures. So this patient would require surgery. So with IRE, we're able to treat it minimally invasively with 4 needles. And that's the immediate post. You see that the area is not enhancing. And this patient's follow-up at 6 months with no evidence of tumor recurrence in the treated area. And another area where we're using it is in solitary lymph node metastases, where patients have exhausted all their treatments but still have metastatic disease in a solitary lymph node. We presented our experience at CERSI. Here's an example of that, where we're able to go near blood vessels and critical structures. And finally, I'll leave you with the future directions. At Baptist here at MCVI, we were the first center in the country that introduced robotic guidance for placement of ablation needles. We've now treated about 50 patients using robotic assistance. Not only does it help guide you place the probes, it also helps you plan the treatment and assess the ablation success. So that's a new addition that we've added to our group here. So in summary, IRE offers an alternative. It's not a replacement for the other technologies that we have, but a great complement where we're now able to offer such a minimally invasive option to patients where these options did not exist before. Thank you very much.
Thank you, Dr. Nariam. I want to introduce Dr. Joseph McGinn, who's the Chief of Cardiac Surgery here at MCVI. He's going to talk about, the most common operation we do as cardiac surgeons with this CABG surgery, but he's going to talk about cardiac surgery being reinvented via the CABG approach. Dr. McGinn.
Good afternoon, everybody here, and also those that are on the signing in from outside the hospital. Appreciate y'all's attention. What I'd like to do is, let me get to the next slide here. What I'd like to do is try and convince you guys that we have one of the most outstanding cardiac surgery programs anywhere. And I'm going to try and do it by looking at the different buckets in cardiac surgery that you can see listed on the bottom of the slide. I'm not going to go over all of them, but I'm going to focus a lot of my attention on revascularization. The reason I'm going to do that is because revascularization is the most common operation done in this country for the heart. There's about 350,000 of them done every year in the United States, so it's a big market, a lot of patients getting this surgery. But I want to convince you guys that not only are we delivering outstanding care, but our outcomes are unmatched. We're very innovative, and I'll show you a couple of slides about that. And because we're able to handle just about anything in the cardiac surgery realm in a very innovative way, I call ourselves very dynamic and comprehensive. So I'm going to go to just a little look at our program. It's grown dramatically over the last few years because of our innovation, but not only because of our innovation, but also because of our outcomes. But you can see on this slide that last year we did just a little under 500 heart surgery cases. This year we're projected to almost hit 650 heart surgery cases, and including TAVR, we're going to hit almost 1,000 cases. So we're clearly the leader in this market and probably most of Florida. Skip this one. What I'd like you to draw your attention to is the bottom right-hand corner of that slide. What I did was I tried to look at all the cases we did and see how many of them were done in a very innovative fashion, meaning either off pump or minimally invasive. And it turns out that 60% of our cases are done in some fashion by a minimally invasive technique, which is mind-boggling compared to most places. I actually looked at the research. 92% of all cases nationwide are done in a traditional fashion. So we're way ahead of the game as far as innovation is concerned. But not only are we innovative, but we're also amazing at quality. And I'm very proud of the teams and what they've done to get this dashboard so green. We're leading in every metric, basically, through the STS in outcomes, and we're very proud of that. Because of that, we gained a 3-star designation. If you went to a hotel that was a 3-star designation, you probably would be dissatisfied. But in the STS world, a 3-star is the best you can get. So we really stand out as far as our quality is concerned. So think about it. We have amazing innovation, amazing quality. I can't see what else anyone would ask for. Well, how do we do it? And I think Dr. Nguyen said it also. Teamwork is the key, and it's all about the teams that we've put together. It takes more than 8 disciplines to do a heart surgery case. I'm not going to go over all of them, but you can imagine how complicated it is to build those teams and maintain those teams. And that's what gives us those great outcomes. And that allows us to do these very fancy operations. I'm going to introduce you to an operation called mixed CABG. It's minimally invasive cardiac surgery, coronary artery bypass grafting, basically coronary bypass grafting through a little hole. I'm not going to dwell a lot of time on. Do we have a pointer on this thing by chance? I don't see it. All right. Well, anyway, the procedure is basically 3 holes. One on the left, a mini thoracotomy on the left side, just under the breast in women and just under the nipple in men. There's 2 other portals, one at the subxiphoid and one in the 6th intercostal space. And I'll have a little video clip of that coming up. But before we get to the video clip, I just want to give you a little idea of why I came to develop this procedure and why it's so important to the public. And most of us physicians, when we write papers, we talk about MACE, major adverse cerebral and coronary events. Those are heart attacks, death, strokes, you name it, anything related to the procedure that could be considered a MACE. That's how we judge whether or not we're doing a good job. How many patients died? If less patients died, we consider it to be a successful procedure. But that's not how patients see it. There's a study probably in the early 2000s that looked at patients undergoing life-threatening surgery. They asked them, what are you most concerned about? What are your top 3 concerns? And most people would think, well, I'm doing a life-threatening surgery, the top concern is, am I going to live? Well, that wasn't the first response. The first response was, how much pain am I going to have? So then you would say, well, the second response was, well, am I going to make it through the surgery? It wasn't number 2. Actually, number 2 is, when am I going to be able to get back to work or back to my normal activity level? And number 3 was, am I going to make it through the surgery? So our world has turned a little bit upside down. We used to think in terms of death rates and complication rates. Now we have to think more in terms of lifestyle, because that's what really patients are focused on. So who are candidates for this surgery? Everybody. Basically, I do about 98% of my cases through a minimally invasive approach. So a lot of times they get a call and say, well, I don't see how you can do that surgery minimally invasive, but the reality is we can. And I'll show you a videotape of a case that we did. But there are two different major groups of categories of patients that are seeking out this kind of surgery. The top, and it's a little bit of a tongue-in-cheek explanation, but there's a lot of reality to it. The top one is those who need it. I'm sorry, those who want it. And there are patients, and I'll give you a case review of one patient that find out that they need triple bypass surgery, and they say, I cannot go through a sternotomy and 3 months of layup. So they seek us out, and they find out if we can do a minimally invasive approach for that person. And many of those people are breadwinners, people who have to get back to work. As you probably all know, many of our co-Americans are living paycheck to paycheck. So taking 3 months off from work is not even feasible. So it's not a medical issue, it's really an economic issue that these patients are seeking out our help. There's another group of people in that those who want it category, and they're golfers. Golfers are very unique people because when you tell them that they're going to be laid up for 3 months, they freak out and they will absolutely find some other way of getting this taken care of. So we have a lot of golfers who come to us to get minimally invasive surgery because we can get them back golfing in 10 days. But there's another category which is more serious, and that's those who need it category. I noticed over my career that we're operating on more elderly patients, more patients with more comorbidities, more high-risk patients. And the sternotomy and the open surgery just wasn't doing it for them. It was adding too much complication to their lives. So there, and I can give you just a little story about a particular patient that might give you an idea of what I'm talking about. I had an 80-year-old patient come into the hospital with a broken hip. They were getting the patient ready to have the hip surgery, to pin the hip. And during that workup, which was less than 24 hours, they came out that she was having chest pain on and off throughout the last week or two. So they did a catheterization, and sure enough, she had a left main. So now you take a lady who's been sitting around in bed, elderly lady sitting around in bed for 2 days, not eating properly, now slightly malnourished, immobile, and you're going to take her and do a sternotomy. Not a good plan. So what we were able to do is do a minimally invasive double bypass, and then literally the next day she went and had her hip pinned, and within 4 days of the hip pinning, she was in rehab getting back to life. And that is a case where you don't want to do a sternotomy on that patient. And there's a lot of cases like this. Patient selection, I think we did that already. Let's see. Okay, the next is a video clip. And I got to introduce it before it starts. It's narrated, so hopefully you have the audio going. It's about 9 minutes. I'll cut it off if I see people starting to fall asleep. But it's about 9 minutes, and it's demonstrating a minimally invasive coronary bypass surgery. It's narrated by my son, who's a cardiothoracic surgeon who just joined Baptist and MCVI a couple of months ago. So you get to meet him through this video. But take a look and see what you think. It just shows how you can do a 4-vessel bypass.
The main one is in the fourth intercostal space below the left nipple in men and in the inframammary crease in women. The other two are smaller port sites in the subxiphoid space and the 6th intercostal space anteriorly. The soft tissue retractor is used to expand the incision. The thoratract retractor is used to pull the 2nd, 3rd, and 4th ribs separately. And the World-Tract retractor is used to retroflex the thoratract retractor to gain better access to the very top of the left internal mammary artery. The crank in the middle of the World-Tract is used to pull up the sternum to gain access to the right internal mammary artery. A hook is placed in the subxiphoid incision and is pulled up by the World-Tract. The hook is embedded into the internal side of the sternum and allows much better access to the right internal mammary artery. Once this is accomplished, the pleura is dissected off the anterior chest wall using an extended bowed and a sponge stick. Pleura is dissected across the midline and into the right pleural cavity, exposing the right internal mammary artery. Once an adequate pleural dissection is done, the right internal mammary artery can be harvested using an extended bogey and a single shafted pickup, and a sponge stick placed through the 6th intercostal space. Microclips are used to occlude branches of the internal mammary arteries. A fine single shafted scissor is used to divide those branches. Access to the more superior part of the right internal mammary artery can be achieved by advancing the sponge sticks in a superior fashion to push the superior mediastinum posteriorly, exposing more of the right internal mammary artery. Once the right internal mammary artery is harvested, the attention can then be turned to the left internal mammary artery. The left internal mammary artery is harvested in a similar fashion you'll see in the inset picture. The Army-Navy retractor is pulling the internal ring of the soft tissue retractor, giving greater exposure to the distal part of the internal mammary artery. Clips are again used on the mammary side and the chest wall side before dividing with a fine single shafted scissor. Continuing more proximally on the internal mammary artery, the thoratract retractor is placed in the hook of the rule tract to retroflex it, exposing the upper branches in more detail. Again, each branch is clipped, both on the mammary side and the chest wall side, and divided. After the last branch is divided, the dissection continues up to expose the innominate vein, which marks the end of the left internal mammary artery dissection. The next step in the sequence is to create an aortic proximal. First, all the fat is removed from the anterior surface of the pericardium. Then the pericardium is opened. You'll notice how redundant the pericardium is here, as this patient has received a loading dose of milrinone prior to the start of the case. The pericardium is opened all the way up to the ascending aorta. Two sutures are placed on the right side of the pericardium, which are used to retract the superior mediastinum into the left chest. These two sutures are brought out through the incision and fastened to the drape. The rod for the octopus is then placed in the subxiphoid port. The head of the octopus is then connected to the rod in the left chest. The head of the octopus is then positioned over the pulmonary artery. Suction is then turned on, and the pulmonary artery is displaced inferiorly and posteriorly, exposing the aorta. The aorta is then dissected along the right pulmonary artery. Using a C-clamp to complete the dissection, an umbilical tape is pulled behind the aorta. This umbilical tape is then swapped out for a 1-inch packing, which acts like a sling to bring the aorta into the incision. As you can see in this video clip, the sling is being used to pull the aorta up and a little closer to the incision. Once this is accomplished, a side biter can be placed on the ascending aorta in a very similar fashion as done through a sternotomy. At this point, using a regular 11 blade and a regular punch, a circular aortotomy can be created and a vein anastomosis can be performed using a 6-0 proline in a running fashion. As you can see, a single shafted needle holder and a regular pickup is used to perform this anastomosis. Once the anastomosis is complete, the knot is tied using a knot pusher and the side biter is removed. The proximal is then inspected for any areas of leakage.
I know it's very technical. It's meant to teach other surgeons how to do it, so you're getting a first-hand look at it, at how it's done.
The octopus can facilitate the T-graft anastomosis. The lemma is marked to maintain orientation, and as you can see on the inset, the octopus is placed through the 6th intercostal space. The left internal mammary artery is then opened, and the right internal mammary is prepared for the anastomosis. This is done using a 7-0 proline. As you can see, regular instruments are being used. The strap is removed prior to tying the stitch down to prevent purse stringing, and the anastomosis is checked. Access to the obtuse marginal branches is facilitated by using the starfish, which is placed through the subxiphoid port. Once the target vessel is identified, the octopus is placed through the 6th intercostal space, attached inside the left chest, and positioned over the target artery. Suction is then turned on and the artery is stabilized. A vessel loop is placed around the coronary artery to be occluded later on.
You can see the movement.
The T-graft complex is then oriented properly and the length is checked. 7-O-proline is used to suspend the right internal mammary during the anastomosis and marks the length of the right internal mammary. The obtuse margin in this case, obtuse marginal 1, is opened and the anastomosis is created using a 7-O-proline. Because of the proximity of the anastomosis, regular instruments can be used and the knots are tied without a knot pusher. Access to the LID can be achieved by rotating the starfish clockwise. The octopus is placed through the 6th intercostal.
You can see how stable it is right between the octopus, and then out on the outside there, you can see the heart beating quite vigorously.
The left internal mammary artery is then tacked to the epicardium to maintain the orientation. The left internal mammary artery is then occluded using a vessel loop. A tacking suture is used to mark the point of the anastomosis and to suspend the internal mammary artery to facilitate suture. The internal mammary artery is then prepared for the anastomosis. The LAD is occluded, then opened, and then a shunt is placed. An undersized shunt is used in this case and pushed through the silastic occlusion. The suturing is done using regular pickups, needle holder, and a 7-O-proline. The shunt is then removed, and the last 2 stitches are placed. The occlusion is removed, the knots are tied, and protein is given. The vessel is checked.
Okay, so I know that was a little bit tedious, but I wanted you to get a feel for what we go through. It's a very complex operation, but with tremendous results. I'm going to try and skip ahead a little bit more speedily because I know that we're run out. Let me introduce you to this young lady. You can tell a couple of things by just looking at this young lady. She has this hat on because she has no hair, and she also has a chemotherapy portal in her right upper shoulder where she gets her chemotherapy. She was a lady who was going through chemotherapy for a very curable breast cancer, and during the treatment, she was getting chest pain. When they did the evaluation, they found out that she had not only coronary disease, but she also had severe aortic stenosis. So this young lady underwent a minimally invasive coronary bypass like you just saw before. And then the next day underwent a TAVR procedure, which Dr. Wynn had mentioned a little bit earlier on. So you could see how the cooperation and the hybrid approach that we have in our department, that we were able to give this lady a really viable solution. And as you know, someone in the middle of chemotherapy doesn't heal too well, so doing a sternotomy is not a good idea. So we ended up being able to create a solution for someone who may have otherwise been not given an opportunity to have surgery. So, and she actually went home this is the day of discharge. I think it's day 4, day 5. She's ready to go home and feels great about it. She ended up doing fantastic. When you can do this kind of innovative surgery, you can do a lot of cool things, and that's just one example. This is another one. This gentleman, John Regan, came to my office with repeated chest pain episodes. They did a catheterization, showed that he had severe coronary artery disease, and he was a marathon runner. And I said, oh, okay, well, I guess marathon running is not a good thing. But I don't know how he ended up getting coronary disease, probably a family history thing. But we ended up doing a minimally invasive cabbage on him, and literally 2 months later, he ran the Boston Marathon. Now, if any of you guys are runners, you know the Boston Marathon is a very hilly marathon. It's a tough one to run, and you have to qualify. You can't just sign up and go. So it's pretty impressive, his accomplishments. And that's it. I hope I gave you a little taste of how comprehensive our department is, how many different innovative techniques we have between what Dr. Wynn had shown earlier and the coronary bypass. We've got just about everything covered as far as innovation is concerned, and our outcomes are beyond compare. So appreciate your attention to both the group here and those online. Thank you very much.
As Dr. McGill was giving that talk, sitting next to me was Dr. Quesada, who's an interventional cardiologist, and he leaned over and said, "That's actually pretty cool." And it's always nice when an interventional cardiologist says what we're doing as surgeons is pretty cool. So without further ado, I'm going to introduce Dr. Quesada, who's the head of our structural heart program, and he's going to talk about some of the trials and innovative things we're doing in the structural heart and transcatheter space. Dr. Quesada.
Thank you, Tom. Thank you, Tom, and it's a pleasure to be here. I want to thank the International Department for putting this meeting together. It's an honor to see a lot of my friends who we worked through the years from Mexico, Central America, the Caribbean, and South America. It's a pleasure to have you here, and it's a pleasure for us to be here. So I'm an interventional cardiologist, and a structuralist, and we definitely do no incisions, okay? 0 incisions. But to give you a taste of what we do at the Institute, this is, I will show you 2 cases. This is a 62-year-old female who presented to the hospital with very symptomatic and congestive heart failure, pulmonary edema. Even though the STS is low, it didn't reflect how sick she was. She has severe AS, aortic stenosis, and severe primary mitral insufficiency, was in cardiogenic shock with preserved LV function. Has non-occlusive coronary artery disease and had elevated troponin because she had demand ischemia because there was no perfusion, and it was a lot of mitral insufficiency. The velocities across the aortic valve were 4.8 meters per second. It was a valve area of 0.36, a valve index of 0.36, and a DI, which is a reflection of how bad the AS is, was 0.19. With normal left ventricular function, the gradient was 60 millimeters of mercury by echo. You can see the echo here. The valve was heavy calcified in a young person, so you suspecting this patient probably has bicuspid aortic valve stenosis. On cardiac catheterization, also she has severe pulmonary hypertension, which also makes things worse, with elevated left ventricular end-diastolic pressure, which also is reflection of her, both things, the severe MR and TR. Imaging is everything. If you can see it, you can do it. So in interventional structural cardiology, we use all imaging possibilities so we can define the anatomy, so we can see what the surgeons see without going inside the body. So in the echo, you can see that this patient definitely has a bicuspid aortic valve, heavy calcified. This is a very complex disease, congenital. It manifests very early in life, and the treatment is surgery, always been surgery, until recently, and I'll talk about that. One of the things that we have today, one of the parameters is the calcium score of the valve. If the calcium score of the valve, which should be 0, and is up to 1200 in men is tolerated, but a calcium score of 2000 is telling you that that valve is heavy calcified, is one of the prognostic parameters that we look into it. But the patient has massive mitral insufficiency, which makes things very complex. You cannot treat one and leave the other alone. Or you treat both, and that's the way to go. So this patient has severe, massive primary mitral insufficiency. I'm going to go fast, and was presented in our heart team meeting, and it was felt at the time that the patient was high risk, prohibited risk for dual valve replacement surgery. So what is the alternative? I have to say the following. The heart team idea came with TAVR, but it really was brought to the Institute back in the 80s by Barry Katzen. He believed that the multidisciplinary approach to cardiovascular disease was the way of the future, and he was right. When you look at the Institute, when you do the cath lab tomorrow and the tour, you're going to see it's wide open, a lot of glass. It's pretty, but it was not designed because of that. It was designed in purpose because the cooperation of all the specialties in the care of the patient. This is a multidisciplinary approach to cardiovascular disease, and the heart team reflects that. So, and the heart team was felt that the patient was prohibitive risk, and there was no alternative. We know that when you have bicuspid aortic valve, heavy calcified, is one of the prognostic indicators for everything. It's bad for TAVR, and it's bad for surgery in high-risk patients too. But that would have been the ideal therapy for this patient, young patient with bicuspid aortic valve. We'll talk about it in a second. None of the trials included bicuspid valves, And the mortality of the patient with bicuspid aortic valve also depends upon the anatomy of the bicuspid valve. So she had all the parameters to be bad. What about transcatheter aortic valve replacement that was mentioned by Dr. Wynn before? Is the most studied procedure done in interventional cardiology. We have 4 major trials that were published, and that's what the reason it was approved. Extreme risk patients compared to medical therapy, high risk patients, intermediate risk patients, and low risk patients. All made it to the New England Journal of Medicine, and that's why its procedure was approved initially for prohibited patients compared to medical therapy, and then subsequently all the way to low risk patients. So medical therapy for severe aortic stenosis is criminal. We have the data. We have the evidence. No patient with severe aortic stenosis should be left for observation because they die. And you can answer the patient the question when they ask you, what will happen to me if we just treat me medically? Well, you have 50% chance to be dead within 1 year. And what about if you do a TAVR or do surgery? Well, you have 44 chance, in 44 months, you probably will be alive if you got the surgery. But not everybody get a benefit from TAVR. There are patients that are beyond help. And that's why patients who have an STS of more than 15%, very sick patients, they will not benefit for any measure that we do. This was from Partners trial in the inoperable patients. But the high-risk patients also benefit, and the low-risk patients also super benefit. So, going to our case, this patient had bicuspid aortic valve. None of the things that I just talked to you about applies to this patient because she has bicuspid aortic valve, high-risk bicuspid aortic valve. And not only that, patients with heavy calcification of the valve, with heavy calcification in the LVOT were also excluded. So our patient was not part of the trial. And not only that, you also have another valve that is bad, which has torrential mitral insufficiency. So how do we deal with this? The patient is considered not surgical, extreme high risk. Well, we look for alternatives. That's where innovation comes through in the real life. So we have alternatives. We have left ventricular assist devices that we can use to help us to accomplish our results in patients like this. Well, intra-aortic balloon pump is a simple one, but we can apply it to this case. What about the use of impellers? We put a catheter inside the ventricle and then we unload the ventricle. We cannot use it because we need to put a valve. And what about ECMO? ECMO is pure bypass. Well, you know what? ECMO is great. Protect the brain and the peripheral organs, but do not protect the heart. And that's a misconception. We need to unload the ventricle. Okay? By putting the patient in ECMO, we are protecting the heart, but we're not unloading the ventricle. As a matter of fact, ECMO increase the demand of oxygen of the heart. So what's the alternative? The alternative is put a device that we can unload the ventricle completely, allow us to do the valve, and perfuse the patient. So it's called tandem heart. We put a catheter, as you can see there. I don't have any pointer, right? So unload the heart. You see the catheter is in the left atrium. The catheter has a bunch of little holes. We go transeptally, and by doing that, you see the catheter inside the left atrium with a lot of holes, drain the left atrium, which is oxygenated blood, throw it into a pump, and the pump put them in the femoral artery, so you are doing complete bypass. And you can do even more. Now we have catheters that have holes for the left atrium and for the right atrium, and you can unload both ventricles. And that is complete bypass. So by doing that, we're protecting the heart and allow us to do the first procedure in this patient, which would be replacing the valve, TAVR. You can see it there. So once we did that, we do the valvuloplasty on this patient, and then now you can see that the valve opens a little bit. And then we can come and put a new valve, which is TAVR. We put an ultra balloon expandable valve, which is mounted in a balloon, and then is a very simple procedure. It really is. And we solved the first problem, which is severe aortic stenosis. Once we did that, now next step is, now what do? We still have the mitral insufficiency, but we are already across the left atrium, and to repair the mitral valve, we already have a catheter. We remove the catheter from the left atrium, and then we deal with the mitral valve. And for that, we do a procedure called TEER, transcatheter mitral valve repair, which is based on a surgical approach, which was putting stitches in the leaflet, making a bow tie of the mitral leaflets, and then we repair the valve using a mitral clip. Now we have two devices, but in this case we use mitral clip. It's the one who has more experience because we were part of the initial trials since 2005. We're the only place in Florida for 15 years, and we have a lot of experience. We have now new devices, new mitral clips that allow us to even treat more complex lesions, and like in this patient. So we have a white paper came through. So how do you decide which patient is a candidate? So the green light are the easy ones, A2, P2s. The yellow light are the more complex ones, heavy, little calcifications, a little bit of prolapse, Barlow's, and the red one, the more complex ones. Our world really is the yellows and the reds. But we know the data. We know that this patient do very, very well over time. Once you pass the first 6 months, it's comparable. The results at 6 months and 1 year are pretty good. 92.8% success rate with less than 2 plus MR, and now we have more data. It's up to 97% using the new clips, and with excellent results. Also, in patients with secondary MR, we know that from co-op that improves survival and reduce hospitalizations up to 2 years, and is better than medical therapy. When medical therapy fails, this is the way to go. What is the best therapy for CHF? We have a lot of innovation, a lot of new drugs, etc. But nobody benefit mortality as TEER in patient with CHF. So our patient was not CHF. Our patient was primary MR. That was a very high risk for surgery, prohibited, and then we could resolve the problem in this particular case using TEER. You can see here grasping the leaflets of the mitral valve. If you can see it, you can do it. I think imaging has changed our world for the better. So you can see it right now. We're trying to grip. Once we achieve, you're going to create a little bit of MS. How much MS, mitral stenosis, how much that you tolerate? You tolerate up to 6 millimeters of mercury of gradient. So this is after. In this particular patient, no MR. The patient went home and is being seen in follow-up, and she's completely asymptomatic, class 1. And this patient was in shock, dying. So the indication is for primary MR, high-risk patients. The best therapy for primary MR is surgical repair. No question about it. But in the high-risk patient, the best therapy is transcatheter therapy. And replacement is coming. And we know that the mortality depends on how much MR you left. So we want to leave the least amount of MR possible, because if you leave more than 2 plus MR, the mortality goes down. And the other thing that reflects mortality is tricuspid insufficiency. That's the way we learned that the tricuspid valve was bad, because our patients were dying. 50% mortality within 1 year of mitral valve repair if you do nothing about the tricuspid valve. And that moved our attention, I'm going to go fast on this, to the tricuspid valve. We need to treat tricuspid valve. And then reclassify that tricuspid insufficiency, which was the forgotten valve, from mild, moderate, severe, massive, and torrential, and have different implications. Around the world, multiple things were done, but the 60% of the therapy this is the international registry, was still using mitral clip. So we finished the mitral valve, and then we turned south and fixed the tricuspid valve. It was this was a very difficult procedure because it was not designed for the tricuspid valve. Now we have a device that is designed for the tricuspid valve, non-approved. This is all investigational, called TriClip. We just finished the study. It was presented in March this year, and it was very successful. Compare the inclusion criteria with severe TR. You have to have that right anatomy, of course, but the results were spectacular compared to medical therapy. There were 85% reduction of TR, with almost 20% improvement in quality of life at 1 year. There was no impact in mortality, but really, who cares about mortality? We already said it. We care about quality of life. These patients were suffering, they feel miserable, they congested, edematous, et cetera, et cetera. So we're waiting approval, going to panel in January, and hopefully it's going to be approved. I'm going to endorse myself and show a case of this trial. Is an 88-year-old patient, a female, with all the symptoms of severe TR, which is fatigue, edema, congestion. They're in the hospital with all edema, ascites, all of the above. And she had torrential TR. There is no pill whatsoever that can treat that. You can give them all the diuretics you want, that's not gonna get better. But it's the only therapy that we have approved, medical therapy, diuretics. So we were lucky enough that we could include her in this study for doing transcatheter edge-to-edge repair in the tricuspid valve. You can see I'm gonna go fast here, it's massive, no question about it. So imaging is everything. We use a special views to see the tricuspid valve, which has been very difficult, but thank God we have progressed in that. This is the most difficult part, get the right imaging. And also that the ventricle, right ventricle is still functioning. So it's very similar to the mitral valve. We go with the TriClip grasping. We plan in advance where to grasp. You can see there is a septal, anteroseptal grasping. Most of the time you have to use 2 clips, not 1, even though a week ago, probably with one of the best results with 1 clip, and there was no residual TR, but that's an exception to the rule. Most of the time we have to put 2 clips. Like in this particular case, grading is important. You can see the second clip going in. And this is the final result. Hold on a second. I didn't show the final result. Can you go back one, please? So you can get incredible results with this technology. Hopefully we're going to get approval in January, and it's one more option to our patients. Structural interventions is really has come to mature. We just passed 21 years of TAVRs, 20 years of MitraClip, and now we're in the tricuspid. We're definitely in the pulmonary for the pediatric congenital stuff, and the future looks bright. That's the final result. No TR. Thank you very much.
Thank you, Dr. Quesada. Our last speaker for the session is Dr. Tino Koehne, who's the Chief of Interventional Radiology, and talks about kind of the marriage of what Dr. Quesada said, we can't fix what we can't see. And Dr. Koehne is going to talk about imaging and fixing the disease process, structural heart disease. Dr. Koehne.
Thank you, Dr. Wen. It's a pleasure to be here. It's great to see so many friendly faces and people that we've met over the years and helped treat your patients. I'm really excited to talk a little bit about, usually I talk to you about all the things we're doing and innovating in terms of new treatments. We've talked about the thoracic, aortic, and aneurysm repairs. We've talked about treatment of peripheral arterial disease. We've talked about CLI and treating and reperfusion people's lower extremities. We've talked about pulmonary embolism in the past. We've talked about treating benign prostatic hypertrophy, all these interesting treatments. But today I'm going to change gears and talk a little bit more about imaging and really how we work together. And you've heard it already in multiple speakers today about how multidisciplinary the approach here at MCVI and at Baptist Health to try to really get the most and the best treatments by working together. And when we started the structural heart program, which you already saw from Dr. Quesada, I think it was really the challenge of saying, hey, how do we work together to get to where we need to go? And I want to say that, you've already heard it from every single speaker. imaging is everything, and we've realized that we need to kind of work together with our imaging along with our treatments to kind of maximize the effectiveness. These are my faculty disclosures. So why do we use CTA? And when you use a CTA, basically an angiogram using our CT machine, is that it's very reproducible, much more reproducible than, say, an echo. We have very small images, and because the slices of the images are isotropic, that means that in every plane, X, Y, Z, they're the same volume, we can then perform reconstructions that we can use to really model and create a lot of different things, and I hope to show you some of those in my talk. We can use the EKG so that we can gate these studies, and this is how we can create some of this information. I think CT is important because you can see the patient and get an idea of the patient, but CT will help you evaluate whether the patient is eligible for a repair, how suitable they are for the repair, and look at that specific risk. So when we're talking together, and we all get together in our heart valve conference, we start looking about each patient, and we try looking at all the different risk factors, clinical risk, structural risk, as well as some of the imaging risks that we may see for some specific patient. And then when we're looking particularly at the aortic valve complex, how suitable is that patient for treatment? And I think this is really important. How are we going to get and deliver the catheter? We've gone from really a femoral iliac approach to transapical approach. Now really we're using a lot of transcarotid approach. The best way to get there to treat the patient and to treat them safely. Why is sizing the valve so important? We can use echo. You've seen Dr. Wen, they use a sizer to size the valve. We can hopefully get an idea of the valve by imaging before you even get there. And it's important, if you're too low and if your valve is too small, if it goes too low, you get a regurgitation. If it's too high, it can embolize into the aorta. All these things, we try to minimize those risks by having the best possible sizing. How do we do the workup? You want to look at the morphology of the valve. You want to determine the access to get and deliver the valve. You want to size it correctly. And then you want to get an idea at the time of placement, what can we do to maximize our results to get the best possible results? So you can start with something like this, an image, and Dr. Casale showed you about calcium in the valve. So this is an aortic valve. All that white is calcium, very densely calcified valve. And then I can look at the valve and say, where is that calcium? Is it in the commissure? Is it in the actual valve leaflets? Is it in the outflow tract? And all this is very important because we know that if you have it in a certain part, you may not be able to expand the valve all the way. So it may not be a great candidate. Or when you look at the sizing, you want to make sure the sizing of the valves can be appropriate so that you get the best result in that particular patient. So when we look at each patient, we try to take a look at what their aortic valve complex is, and we try to maximize those dimensions so that we can then go for the best potential treatment. Here's an example of calcium. Again, looking at the calcium, where is that calcium? Is it in the left ventricular outflow tract or below the valve? Because we know that if you have calcium below the valve, particularly at the level of the non-coronary cusp, your risk of rupture are much higher. And this is stuff that we can pick up before we're actually treating the patient, so we can evaluate that patient and really with imaging start determining how we're going to treat that patient and where our risk is. This is just another example of how we use imaging to look at and measure the valve. Dr. Casale talked to you about the PARTNERS trial. So PARTNERS trial really came out the very initial trial that basically said the advantages of catheter aortic valve replacement. And it really showed a decrease in mortality at 1 year that was durable to 2 years. But to me, when we started working together as the heart team, to me, what really troubled me was the mortality at the time of placement of the valve. And that mortality I saw in death, I also saw in vascular bleeding episodes and stroke. So we worked together, the heart team, and say, I think we can eliminate those risks by having imaging ahead of time and to maximize and try to identify the best patients that we're treating. And this is just an example, the 30-day stroke risk, major complication rate, 7%, 16% out of the original PARTNERS trial. When you look at SOURCE trial, again, you can see that major vascular injury was really high, at least from my understanding, and this added a lot of procedural mortality. So I think the results of TAVR can be even better, which is what we see now after we've had 10 years working with it. But what I realized then is we can probably improve our results in TAVR even more by trying to reduce these intraoperative kind of first 30-day events. So that's why really we joined the heart team very early on in the structural heart meetings, because we wanted to look at access. We used to have devices that required vessels that were 7 millimeters. Now our devices require vessels that are 5 millimeters. So you can see the importance early on of knowing what your vessels look like, how are you going to deliver the valve, where the patient's arteries calcified. Was there something that we had to go in and dilate beforehand or put a graft? And we did all different types of things. We'd come in and help dilate the vessels beforehand, or maybe a day before treat the access vessels. So when the patient came to get the valve, we knew that all these problems, we weren't going to run into them at the day of the procedure. And this is just examples of imaging. In terms of stroke and neurological complications, again, how do we reduce that? We start looking at the calcification in the arch. Dr. Casale is really a pioneer in using devices to help prevent stroke by putting filters in the different carotid arteries while he does these treatments. The mitral valve you've already heard. So the aortic valve is actually an easy valve because you can see the aortic valve with an echo. But when you look at the mitral valve, almost what Dr. Nguyen says, it's hidden. It's kind of out of sight. So it's really critical, because we can't directly evaluate it, the value of imaging. You want to be able to look at that mitral valve, the anterior leaflet, the posterior leaflet, the relationship between that valve to that aortic valve is really critical in all these repairs that are being done in this field. And what we've been trying to get to do is, how can we use imaging so that we can get a better measurement of that valve? Because it's in multiple planes. They call the mitral valve almost as a saddle shape. So it's not just a round area, it's actually round and then comes up. So we use imaging to kind of help us and kind of create those kind of models to get the best possible measurements. So that allows us, as we do treatments, what's the best possible treatment? You can see here some representations of how we do that. Multiple publications written on this. But I think the hardest part here is looking at that when you put in one valve, how does it affect the other valve? And we talk about the LVOT, or the left ventricular outflow tract. And when you place a valve in the mitral position, you may narrow that area. And being able to model and use these type of imaging studies to tell you what's that LVOT going to look like, what we call the neo-LVOT, after we place a valve, is critical to the success of these patients. And this is something that really, again, where imaging has revolutionized and really helped us get the best results and be able to evaluate a patient for suitability. We've had patients that we've had to do procedures beforehand so that we can prepare them to get a successful report. And this is really the future. And this is what we're doing now here at MCVI. Giving you some more pictures of, again, being able to place a valve in the mitral position. How do we prepare the patient? How do we know they have the correct imaging? I'm going to move along because I want to talk about one other thing, and that is, if we have this great data, this isotropic imaging, you can then use it for a lot of things. Early on, we used it so that we can go do procedures without needing contrast or to do imaging on the table. This is an example of an overlay. So you can see the picture on the left is an angiogram, and you can see that there's an aneurysm in that aorta, in the middle of that aorta, a little kind of bulbous port. We put in the angiogram and overlaid it while the time we did the procedure so that when we're doing it, we didn't have to keep injecting contrast, and we can actually deploy the graft. You can see here the graft that's superimposed on this image. And this is really what we see during the procedure while we're doing it. And this, again, increases the ability to perform these procedures with the help of imaging and to minimize contrast and get a better result. The aortic arch is really a challenge sometimes to place a graft. Being able to have an angiogram that we have superimposed, and you can see here deploying a graft because of that imaging that we acquired beforehand, that CTA in the thoracic aorta. Same kind of technologies we can use to deploy a mitral valve and ahead of time. But I think there's much more here. I think the fact that we can do a CT beforehand, maybe we can be looking in the future to be able to get some of this information, enter it to a computer, and we can deploy the valve in a computer before we even deploy it in the person. And this is only going to increase the results. And that's really what we're trying to do. Now, here's an example of what we did for aneurysm repair. When we did that, we would take the patient's aneurysm, we would model it in a computer. We would actually, the whole team would practice that procedure before we did it. And I think that kind of patient-specific anatomy is something that we can get because of the quality imaging and because of the technology we have now. I think navigation will continue to grow, and we're going to use imaging to help us with that navigation, because you're going to be able to program, throw in the patient-specific information, and that computer is going to tell you how they're going to do it, how they would do it, and they could assist you in navigating to get to things done. But I think innovation is really important here at Baptist. And I'd like to introduce here the Ambition MR scanner. We talked about CT. What about MRI? You know, when we talk about MRI, it's a really expensive technology. And not only that, it relies upon expensive natural resource, which is helium. This Ambition scanner, we were the first in the world to have, or first in the United States to have this Ambition scanner. It only uses 7 liters of helium. So it's 7 liters and it's sealed. So that helium is there from the beginning to the end. We've had this scanner now at MCVI for 3 years with really no real hiccups, but it allows us to have now an MR that's much lighter, much easier, and the imaging that we have out of it is fantastic. And what it does in terms of the cost of having to maintain these scanners, but also the cost of the environment because of the natural resources, I think is priceless. You know, what I want to show you that when we have this type of scanner, we then are able to do even more innovation. When we talk about now in 2023, the real buzzword is, you know, artificial intelligence and AI and deep learning. And that's really what we're doing now in our MR scanners. Our scanner is being able to help accommodate each particular patient so that we can maximize the sequences, so that we can acquire beautiful sequences in the shortest amount of time and maximize quality. We're kind of been trialing this out with the Philips Healthcare, and this is kind of the images that we're trying to now are able to get in these specific patients without contrast, being able to look at like the valves and valvular disease. Here's an example, basically breath hold imaging. The patient is there breathing, and you get this type of evaluation real time of the myocardium and the heart. We'll look at the carotid arteries, and the aorta. Being able to acquire images that would take multiple breath holds, almost 60 or 70 breath holds. We now are able to acquire in 4 breath holds this type of MR and cardiac studies. And it's not surprising that we're seeing huge growth in terms of our evaluation of cardiac MRI. When you look at valvular disease, again, evaluates exquisite imaging, looking at the aortic valve in this example, looking at the mitral valve in this example, and I can show you just the series of different pathologies that we've kind of seen here at the Institute. This picture basically shows multiple patients, 10 or 12 patients with different types of a valvular pathology and their evaluation with really MR. So I'd like to conclude and say that Baptist, MCVI really working together is really a take-home. I think we deal with a lot of different and difficult patients and be able to deliver best possible care, as you've seen from the team behind me. And to me, I just want to show you some of the innovation we do with imaging that helps us deliver this. So thank you very much.
Thank you, Dr. Peña. Yeah, I was hoping to spend maybe the next 10, 15 minutes or so with the discussion and open the floor for any questions that you all might have. I'll just kind of point out something that may or may not be obvious. If you look behind me, we have a cardiologist, we have a cardiac surgeon, we have an interventional radiologist, and we have usually vascular surgery here. And I think this really is the future of medicine, kind of a multidisciplinary approach, really focused on patient care. And it really doesn't end here. It's not just a podium thing that we're doing here. Our offices are laid out in such a way where Dr. Casada's office is 2 offices down from mine. Dr. Peña's office is another door down from mine. And we really are physically in the same space, collaborating and just sharing ideas for the sake of patients. On that note, you know, Miami is known for the gateway to Latin America. And it probably goes without saying that if any of you ever want to come visit us to watch any of these procedures, it's so easy to do so. You're staying at the Hilton, and the hospital is right across the street. We have a beautiful gallery that I think you guys will see tomorrow, where you can watch a lot of these procedures. So if you have any questions, please walk up to the mic and feel free to ask any questions to our speakers. Maybe while the mic's being passed around, I'll start off with a question to Dr. Peña. You know, Dr. Peña, I think imaging is everything, and there's been an explosive amount of imaging over the past probably 3 or 4 years. Can you comment a little bit on how things were different maybe 5 years ago, where they are now, and where you see the future of imaging, whether it be CT, MRI, or maybe some other variation or combination in the future? Can you comment on that a little bit?
You know, can I speak from here? Can I?
Yeah,
sure. I think imaging has exploded in that it used to be that imaging was almost in the realm of radiology. And I think what we're seeing now is that imaging really has expanded, where every specialty really depends on imaging and good quality imaging so that they can get the results and be able to evaluate the patients. That would be my biggest thing. I think when we look at technologies that are coming, I showed you the MR and trying to basically acquire these type of images with minimal use of resources and faster sequences. I think AI will continue to grow in imaging because I think it's so much computer-based. And then the value of reconstructions, and that, you know, when I talked about isotropic, the fact that you're able that information now you can move it around. You can enter into a computer and create a patient model that you can then treat. You can then use that to create a model in the operating room, or even before you're gonna go operate. You know, they're showing you pictures, you're gonna go and do an operation where they can project the patient in, you know, what's going on inside the patient before you even cut. And I think that type of technology is gonna be revolutionary, and it's all based on imaging.
And you talked a little bit about a lot of CT imaging, or most of it at least, is done preoperatively, but there is kind of a move towards intraoperative or intraprocedural CT imaging to guide therapy, but it hasn't become mainstream just yet. Can you comment a little bit on that and what the future might hold for that?
I think that's a great question. And we see now that we have what we call something called cone beam CT, where you can use your fluoroscopy equipment to create a CT-like image. And I think that's really helped us to get a lot of information. I know Dr. Raj uses that a lot in the interventional oncology space. But now, is that where we end, or do we continue going? And I think you're seeing a lot of development of even rooms that are combined. They're gonna have CT and angiography together in the operating room, surgery room with an MR. So I think you're seeing this multidisciplinary thing, and I think it will continue to grow.
Changing gears a little bit, I want to talk a little bit about interventional oncology. Dr. Raj is really the world expert in this, and wouldn't it kind of make it relevant for our international crowd? So a lot of these interventional oncologic procedures may require repeat interventions. Can you elaborate on maybe operationally how that might come to use for patients flying in from, you know, South America?
So all of these patients are on a follow protocol that we use. So after our treatments, we'll image them at 1 month, 3 months, 6 months. Usually the primary cancers like HCC, there's a good chance that they may not require an additional treatment for 2-3 years down the road. The patients with metastatic disease, there's a good chance that they could have a lesion somewhere else. The ones that we treat usually respond very well, but that doesn't mean that they may not have something. So there is systemic treatment in addition to our ablations or transarterial treatments. But if there's any need for additional treatment, we pick it up in the follow-ups. So it all depends on the patients keeping up their follow-up appointments and imaging, but invariably sometimes they would have to come back for a repeat procedure.
And you know, within a very short amount of time, we have the Miami Cancer Institute that you'll probably see soon as well. Can you comment on your collaboration relationship with the Miami Cancer Institute in the patients that you treat, and how you leverage their technology and their physicians there as well?
Absolutely. So just like what you all spoke about in vascular and cardiac care, where it's multidisciplinary, it's the exact same language that we use in the oncology world. And there are several multidisciplinary tumor boards that meet almost every day of the week. We're very active in the GI, lung, and GU tumor boards, where you have the surgeons, medical oncologists, radiation, and interventional oncology, pathology, genetics. So we have a very well-organized tumor board system at MCI. And there are minutes that are done, and patients' histories and everything is planned in advance. So all of us get the list of the patients that are going to be discussed. It's usually about an hour and a half. And the great part is that it's a really very collegial system that we have here. No one particular specialty gets to dictate how a particular patient is treated. All of us have a very democratic system where we can talk about what's best for the patient. And it's a very gratifying experience that we have a teams like that, where we're able to work as partners collaboratively and bring each other's strengths to help the patient. So we have a very active tumor board system.
Thank you, Dr. Raj. Dr. McGinn is probably the world leader in minimally invasive cardiac surgery or coronary revascularization. And I just want to emphasize again, CABG is the most common operation we do as cardiac surgeons, but I also would argue probably the most common operation we don't do as well as we should as cardiac surgeons. I want to ask Dr. McGinn a question. You know, it's pretty clear that if I needed bypass surgery, hopefully I never will, I prefer a minimally invasive approach, but the adoption rate for minimally invasive CABG is still pretty low. Can you elaborate on why such a low adoption rate and what can we do to overcome that?
Yeah, well, that's a great question. I get asked a lot, why everybody's not doing it minimally invasive. And the answer is multifactorial, as you would expect. Like the answer to many difficult problems is multifactorial. One of them is that we're a fairly older specialty. Most of our cardiac surgery colleagues are over 50 years old, and teaching a new dog tricks may be a little difficult. The learning curve is quite steep. It takes most surgeons about 6 months to a year to really learn how to do this correctly. And most of us are very busy. We don't have time to learn how to do a new procedure, so that's part of it. The other thing is you need a lot of patience. It's an operation that's complicated, hard to learn, and you need to be able to settle in and go through that learning curve. So it's multifactorial, but one of the things we do here at MCVI is we have surgeons coming in, and they're coming in to learn how to do the procedure. We show them this video beforehand, and then they actually watch a case with a live case or two, so they can get some ideas of what they can do to bring it back to their institution. And then on occasion, we actually go out and proctor to help other surgeons learn how to do it. So we are trying to get it diffused out to more surgeons, but it has been very difficult.
You're talking about learning curve. If you were to choose one aspect of the minimally invasive CABG, which was the hardest to learn, what would that be? For me, just looking at taking down the right internal mammary from the left chest, seems like another zip code away. But what are your thoughts?
Well, it depends on whether you can do multi-vessel or single vessel. If you're talking about single vessel, the hardest part of that is really harvesting the mammary, quite honestly. That is the whole operation. When you get into the multi-vessel arena, the hardest part is really figuring out how to position the heart without causing hemodynamic instability, and that takes a little bit of time to learn.
I don't see any other questions out there. Maybe I'll wrap up with Dr. Quesada and kind of talk about the theme of heart team and multidisciplinary approach. And I think that we've seen that the most with the advent of transcatheter therapies and TAVR, now MitraClip, and tricuspid therapies. Dr. Quesada, can you comment on the evolution of how the heart team evolved here at MCVI and just kind of the day-to-day and how true of a heart team it is, or just maybe describe on how we work up complicated patients and discussions involved?
So thank you, Tom. It's very interesting because the concept of multidisciplinary approach really was born here. And before that, we all work in silos. Vascular surgeons from one side, the interventional radiologists on the other side, and that was true all over the country. The cardiac surgeons, we interact with the interventional guys because we're talking about the cases and referring cases for intervention or for surgery, whatever. But what made the difference was when we open our minds to do complex cases that requires the expertise of multiple people, multiple disciplines. And I think in the structural world, that exemplifies itself, because you need a specialty, expertise, as Dr. Peña said, in selection of access sites, and even in treat peripheral vascular disease before you treat the structural case, you have to repair the peripheral artery. Yes, one person can do that, but you cannot be expert in every single aspect. And I think the get used to just work as a team makes a difference. And case selection and discussion. And at the end of the day, the primary beneficial is the patient.
As we wrap up, I just want to kind of reiterate, and hopefully you're able to appreciate the importance of the multidisciplinary approach and institute model. Here at Baptist, we have the institute model for cardiovascular care, for cancer, for orthopedics, for neuro disease, and we think that's the future of the way the medicine is going. And you see it here, this isn't make-believe. We actually get along with each other, our offices are next to each other, we don't fight. We really are here to do what's best for our patients. I want to thank the speakers for your time today and sharing your expertise, and I thank all the audience here for traveling from near and far to visit our center. Thank you.
Thank you, Dr. Wynn, and our doctors. We're going to take a picture. I just want to say one more thing, that this team of doctors are always so ready and available to help, and with having Ambra Health to be able to upload imaging and getting information to them, it speeds up the process to try to help a friend take a look at whether it's a CT, whether it's a cardiac cath, whether it's MRs. But this is an amazing team that you have access to, and we are here through the international team to be able to help you do that. So with that, I thank you, doctors, for being with us. We are going to take the picture after lunch, and we're gonna actually go to lunch now, and we will see each other here again at 2:30, if that's okay. Thank you.
I have volume? I've got volume on. I have two. easy, right?
No, this is it. Look how easy this is. In case you forget who you are, it's there.
Thank God.
Just in case.
Thank God.
Can I have one with you? Can I have one with the team?
Oh yeah, one more. One more with Ribas.
One more with Roger. Roger in the middle.
Yeah.
In the middle?
Right in the middle, right in the middle. Yeah, there it is. I had a bigger smile on that one. Bigger smile on that one.
Because he hit you?
Oh yeah. Yeah.
Word up, you know what I'm saying? Word up, you know what I'm saying?
Welcome back. I hope everybody had coffee. I did. Do we need to stretch or we're good? We're good? All right, very good. So we're gonna proceed, and now we're gonna be joined by the experts from our Baptist Health Orthopedic Institute, which many of you know as Miami Orthopedic and Sports Medicine Institute. The moderator for this module is Dr. Charles Jordan, orthopedic trauma surgeon for Baptist Health Orthopedic Care. Joining him is Dr. Franz Larabors, orthopedic sports medicine surgeon, Dr. Juan Sanchez, orthopedic hip and knee surgeon, Dr. Roy Cardozo, orthopedic hand and upper extremity surgeon, and Dr. Christopher Hodgkins, orthopedic foot and ankle surgeon. Thank you so much. Doctors, please. Sanchez, really? That's what they put on there, Suarez, Sanchez. What do you want me to do?
It's the same thing, right?
It's Dr. Sanchez Suarez.
Dr. Sanchez Suarez.
It's the same thing.
So thank you to Baptist Health International for inviting us and for giving us some time to show you guys what we're doing at this fabulous institution. And thank you all for coming. I know that everybody here has come from far and wide, and we really appreciate your attendance and your time. And I've heard that there have been some really thoughtful discussion and thoughtful questions, and you've gotten to see a lot of some of the best world-class medicine that South Florida has to offer so far. So hopefully we won't disappoint in the orthopedic section. So my name is Charles Jordan. I'm an orthopedic surgeon. I specialize in orthopedic trauma, so the management of complex fractures and their complications. And I'm going to do a little bit of moderating, but really mostly I'm going to let these surgeons speak for themselves, because you've got a really good group of speakers. I'm very, very lucky in that I get to practice with people that I would let any member of my family have surgery with. So, and actually Suarez doesn't know it yet, but he's going to be replacing my mother's knees very soon. So that's coming up. And so I believe that we're going to start today with Dr. Larabor. Right? Am I turning these slides? Yeah, there we go. So Franz Larabor, he actually, small tidbit, we trained together at NYU Hospital for Joint Diseases. He was my junior resident. He is still my junior, but you know, I think he's trying not to be someday. He, after our residency together at NYU, he went out to the Kerlan-Jobe Orthopedic Clinic, which is a world-renowned center in Los Angeles. And he stayed out there and practiced for 6 years until we were able to finally woo him down to Miami and tear him away from the Lakers and the Dodgers and every other team that he was taking care of. So now he's here with us, and he's going to give you a talk today. And please give a round of applause for Dr. Larabor.
Appreciate it. Thanks, Charles. Cool. So I want to thank all you guys, all the physicians that came from the Caribbean as well as Latin America to come spend time with us and see what we're doing here at Baptist Health. Like Charles said, I've been here for about 3 years after I came from Los Angeles, and I'm very proud to be a part of this great group of physicians and surgeons, as well as the ancillary care, the staff, the administrators that are here at Baptist Health, and it is truly a privilege. So today my talk is on the different advancements and innovations in sports medicine. So we're currently at a very exciting time. We're at a nexus as it relates to technological advances in orthopedics. Over the last 10 years, we've seen a rapid adoption of different new technologies in the field of orthopedics. Okay, this is kind of a chart, kind of summarizing the different things that we've seen rapidly advance in the last 10 years. But today, specifically, I'm going to talk about patient-specific implants and plans, and what they can do for us in terms of helping plan our surgeries, as well as help take better care of our patients. So specifically, I want to talk a little bit about the rotator cuff. So the rotator cuff, when it becomes irreparable, has been a long-standing problem in the field of orthopedics. For those of you who are not orthopedic surgeons, the rotator cuff essentially forms a cuff of tissue around the proximal humerus and is involved in essentially raising your arm in different directions. When you've had a chronic full-thickness tear of your rotator cuff, it becomes very problematic in that the tendon itself retracts and then becomes irreparable, and it becomes very difficult for us to make that distance. And when patients have this problem, they have what's called pseudoparalysis, an inability to raise their arm. And they found that in the 70s, Charles Neer essentially figured out that if you change the actual conformity of the shoulder, okay, and you put a ball where the socket is and put a socket where the ball is, it actually essentially changes the center of rotation. So if you can see in this diagram, the center of rotation moves from moves medially and inferiorly, and what that does, it takes advantage of the fulcrum and allows to tension the deltoid and allows you to actually bring your arm up. So this is a great surgery, and it is a great solution to a problem. However, there's inherent complications associated with doing a reverse, and we're going to get into that a little bit. So, in terms of the indications for reverse, so the classic indication is something called rotator cuff arthropathy. If you saw the slide prior, okay, what happens when you have cuff arthropathy? If you see the X-ray on the right, you lose your rotator cuff, and then the actual humerus starts to escape. It starts to go up proximally, and then you get increased contact loading on the actual humeral head, and that creates rapid degeneration and arthritis. Okay. And then some of the other indications are proximal humerus fractures in the elderly, non-unions, as well as failed anatomic, which is the classic type of arthroplasty. What are your kind of irreparable cuff tears? So the irreparable cuff tears, one of the things that you look for on MRI, let's say if you have some of your patients and you're coming from the Bahamas, or if you look at the MRI, one of the things you'll see is significant amount of fatty infiltration of the actual muscles. Once you see that fatty infiltration that is more than 50% of the actual muscle belly, typically those tears, if the tendon is retracted to the glenoid, they're not going to be repairable, okay? And the patient will come in and all of a sudden they can't lift their arm, they have what's called pseudoparalysis. And what they'll do is they'll basically sit there and they'll try to lift their arm and they'll do like this, okay? You get the MRI and you'll see a ton of fatty atrophy. Those are the patients that are really good candidates for a reverse. But like I spoke earlier, the reverse has a high complication rate, okay? You can see on the right, one of the things you see there is that the actual glenoid component, that ball, is actually not where it's supposed to be. It's completely loose, okay? So the complication rate is said to be around 15 to 25%, okay? And the most common complications we have are instability, where the actual implant disengages and dislocates, infection, which is a known complication with any surgery, and then glenoid loosening, okay? So the glenoid component positioning is actually a key factor in terms of the success for a reverse total shoulder, okay? So incorrect positioning is one of the main factors for the actual component to loosen, okay? And the actual placement of that glenoid component, it can be challenging, okay? In the OR, sometimes identifying those anatomic landmarks can be difficult. However, now with the advent of patient-specific guides, it can help improve our positioning and reduce the complications associated with malpositioning and reduce the complications associated with loosening. And that's what we're going to talk a little bit about today. So patient-specific planning. So right now there's commercially available technology where we essentially take a CT scan, okay, and that's used in conjunction with specialized software to make patient-specific surgical plans and develop custom guides, which are 3D printed using the patient's anatomy. The surgeons can then take these temporary guides and jigs, and then we use them during the procedure to allow us to better accurately place the resections, which are in line with these computer-generated surgical plans. So this study looked at three-dimensional planning and the use of these patient-specific guides. They basically used the 3D guides, and they were evaluated using post-op CT scans. So intra-op, they used the guides, they placed the pin, they placed the implant, and then afterwards they took a CT scan to see how much it correlated with what the preoperative plan was. And the study basically showed that these plans were reliable and precise up within 2 degrees compared with the preoperative plan. Okay, so essentially what we do is the software is this design, we import the patient's, we get the patient's CT scan, and the turnaround is typically around 5 to 7 business days. We get the CT scan, we send it in, they give us a 3D printed guide as well as a 3D printed version. So I actually have some of it here. So this is actual one I use in the OR. So this is a 3D printed glenoid. This is the socket of one of our patients. And then they give us a 3D printed guide. So in the operating room, we take this guide. It fits directly onto the socket as such. And then you can see, so when we're placing these pins, it's like threading a needle. So having the software to accurately get the pin where you need it to be gives you that much extra confidence that you're putting all the implants in the right place, especially in a bone that's this small, okay? So if you get this wrong and then you go and you essentially over this, we end up drilling a 8 diameter millimeter hole. If you get it wrong, you don't have a lot of room for error, okay? So you can end up blowing out the socket, or you can end up not having good fixation, which leads to early loosening. So we get this guide in the operating room, we put it on the glenoid, we fire the pins, and then we have a this custom stop goes on a reamer, okay, which will tell us exactly what depth we need to ream. So all of this gives us that extra confidence that we're putting the implants in the right position. So in terms of so this is essentially what we showed you. So on the top, you see the rendition of the patient's glenoid. We have the guide pin, okay, and then on the bottom we have the depth stop. And that's essentially the 3D printed guides that we just showed here. So this is a case I wanted to show you guys. So I had a 76-year-old male. He had severe right rotator cuff arthropathy. So he had proximal migration, severe bone-on-bone arthritis of his shoulder with pseudoparalysis, inability to lift his arm, constant pain. He was only able to flex up to about 50 degrees. And a positive hornblower sign, which means he essentially could not externally rotate his arm. So his arm was essentially non-functional. He had inability to do his activities of daily living and constant pain. And these are his x-rays. So this pointer work. I don't know if you can see that here. So if you can see here, this is severe, okay, rotator cuff arthropathy. He has complete migration of his humeral head. And then you can see here, this bone over here, known as the acromion, he had been wearing so much into it, it's almost as thin as a paper, it's like a potato chip, okay? So this gentleman had severe deformity of his glenoid. So this is a very complex reverse total shoulder. So with this amount of deformity, and this is his actual glenoid, there's not a whole lot of room to maintain that fixation. And this is a 3D scan rendition showing his severe glenoid deformity. And then this is some intraoperative photos. So if you could see over here, this is the actual guide in the patient. So we essentially place 2 pins. The bottom pin is going to be where we place our central peg, which is going to be the main source of fixation for the actual glenoid. And then the top pin is going to be our depth stop for the reamer. And then once we like where our pin placement is, the guide slips off. And then we place the reamer on top. And then this is the reaming. So you can see here that this is essentially that depth stop. So as soon as this touches the top, the glenoid, I know I've gone deep enough. So all of this takes a lot of the guesswork out of doing a reverse total shoulder. And this is a post-op x-ray. So I was very happy with how overall this looked. What I'm looking here on this axillary view is I can see that central screw is going inside what's called the vault. Okay, so it's going inside the vault, and it's bicortical, so I like the fixation. So this is the gentleman at 12 days post-op. And this is before he was unable to bring his arm up. And then this is him at 7 weeks. Yeah. So that's his external rotation. So before he couldn't do that. So when he came into my office, I'm not gonna lie, I saw how significant that deformity was. And if this was 5 years ago, before we had these patient-specific implants, I would have been very nervous going into this surgery because he had very, very little bone stock. He had worn so much of his native bone that I would have been very worried if I was able to get the pin in the right place. But now with this technology, it really does take a lot of the guesswork out of it, and I could dial it in on a computer prior to even showing up to the OR. I could put the implant exactly where I want it with these patient-specific guides. So in conclusion, these PSI technology aims to reduce the procedural costs, minimize time, and maximize patient outcome by achieving a better biomechanical implant fit. And now with proliferation of additive manufacturing, which basically means 3D printing, robotics, augmented reality, AI, and orthopedics, we can expand the accessibility of a lot of this type of technology. So thank you.
Thank you very much. That was an excellent talk and really a testament to how much of an advance there's been in the treatment of patients with severe rotator cuff arthropathy. And I think Franz put it best when he said, getting that pin into the glenoid vault is like threading a needle. So the tools that we have now to be able to do that are pretty outstanding. So I believe that the next talk, if it's loaded up, are we up? Anyway, I believe that it's Dr. Suarez, right? Okay, so like I told you, Suarez is going to be replacing my mother's knees. He's as good as they come. He trained at the University of Miami and then did his fellowship in probably one of the most prolific hip and knee arthroplasty centers to train at in the world. He has an unbelievable amount of experience, and what I love about him and the way that he approaches his joints is the ability for him to be able to visualize what he needs to do before the surgery. And now he's going to talk to you about doing robotic surgery, which just turns him into a Superman for this sort of stuff. So the next guy is Dr. Suarez. Thank you.
I need sunglasses with those lights.
So thanks you all for being here. So my task is to kind of give you an idea of what we're doing with robotics and knee replacements. This is off-label use, so the robot that I'm going to show you is not really indicated for revisions, but you can get around it and get pretty good results. So these are my disclosures. None of them are relevant to this talk. So this is the American Joint Replacement Registry. It's probably the largest in the world now. And as you can see, the utilization of robotics in total knee is spiking significantly. In 2022, about 12% of knee replacements in this country were done robotically, and it's going in increase. If you look at the type of knees, the Stryker triathlon knee is the knee that has been using the most because these systems are not implant agnostic. So the Mako robot that we use is kind of married to the triathlon knee and is the most utilized. So that's why you're seeing that kind of spike. So what are the advantages of robotics? You can manage existing hardware and deformity without having to do extra work. You can obtain real-time alignment and soft tissue laxity data so you can make intraoperative decisions. You can manipulate the sizing and the position with accuracy, and you can use bony cuts for balancing purposes, and I think that's the biggest benefit of this. So in the beginning, people were like very, they were skeptical about the technology and say, why are you spending so much money in robotics if the results are not there? And now there's data to support this. This is a systematic review, and it showed lower pain scores, reduced lengths of stay, better functional outcomes at a year. So now there's data that validate robotics, at least in the primary setting. So when you do robotics, basically you're getting the hip center rotation first after you put your arrays, and then you're getting your medial and your lateral malleoli. That's basically registering those 3 points. And then after that, what you're doing is you're getting points on the femur and tibia because you get a CT scan before surgery. And what you're doing with these points is marrying the CT scan to the surgical field so the robotic arm knows exactly where that is in space. So you get about 40 points on the femur, and then on the tibia, let me go back. And then on the tibia, and on the tibia, you do the same, about 40 points. And again, and it'll tell you once you register, it'll tell you the amount of accuracy, whether you're within 0.1, 0.2, or 0.3 millimeters of accuracy. And then once you get that done, then it'll tell you, okay, this knee, and it'll tell you the degrees of deformity. In this case, this knee has about 6 degrees of varus, hyperextends 2 degrees. And then you can see how flexible that deformity is based on the intraoperative information. In this case, you're getting about 2 millimeters of laxity medially, about 2.5 to 3 millimeters of laxity laterally. And then you can also do this in flexion. In this case, we put some osteotomes, one on the medial, one on the lateral side, and we basically crank on it, and it'll tell you the amount of laxity that you have in flexion of both the medial and lateral compartment. And then it'll show you a screen like this where you can start manipulating the implant position, sizing to accommodate the balancing that you want. And everybody's different. Every surgeon goal is a little bit different. I think as the technology evolves, we're going to start subdividing patients and phenotypes, and there will be more of an algorithmic way of approaching these knees. But as of now, we're just collecting that data, but you can pretty much put it wherever you want. And then once you tell the robot, so this is where we're going, then you bring the robotic arm, and then it'll cut with accuracy. You know, before robotics, we used to do navigation, and navigation is accurate, but it's as accurate as the points that you take. With robotics, it's very accurate. If you tell the robot, cut this in 2 degrees of Varus, it'll cut it in 2 degrees of Varus. There's really not a lot of margin for error here. So, and then once you put the implants in, you can see, well, if I plan for 1.5 of Varus, am I close to that or not? And how much laxity I'm left with the trial components in place. So again, you're getting intraoperative information that otherwise you wouldn't get. Before this, you would be pretty much guessing as you did a total knee replacement. So what about robotics revisions, and can we improve what we currently do? And my answer is yes, but it's still off-label. I think, again, you can use the laxity to dictate the component position. The robot knows where the anatomy is, it knows the transepicondylar axis, it knows where the joint line is, and you can make the bone cuts without the blocks, which sometimes is very challenging to put in when you don't have a lot of bone left to work with. So let me show you a couple of examples of the stuff that you can do with a robotic, with robotics. So this is a patient that had a proximal tibia varus osteotomy in Cuba, which is not really an indicated procedure, but they did it. And now you end up with a significant deformity, and the question is, what do you do with it? So one answer is taking all the hardware out, doing an osteotomy, aligning the tibia, and doing the knee replacement. But with robotics, what you can do is then you start manipulating the implant position. So in this case, we plan to put the tibia in 4 degrees of varus, the femur in 4 degrees of valgus, and then you can start balancing the knee without having to do an osteotomy in this patient. And then you can balance the knee, and this is what you get. You did minimal hardware removal, you get a well-balanced knee, and you avoided a huge osteotomy on the tibia. So again, this is very powerful for all of you guys that know that doing a tibial osteotomy, waiting for it to heal, and then doing the knee replacement is very complex and challenging. There's another example. This patient had a distal femur fracture. They put a plate in, they took the plate out, she re-fractured, and then they put this retrograde nail in place. And as you can see, taking this nail out is very challenging. All those screws are really embedded in bone. And in order to do a standard knee replacement, you would have to take all this out, which can be a lot more complex than doing the knee replacement. But with robotics, you can plan the operation, and then you can start manipulating the position of the implant, in this case the femur, to avoid conflict with the hardware. And as you can see in this case, we're able to leave the nail in place. We did not go through all the morbidity that it takes to take all this nail out and do the knee replacement. We just trim with a high-speed burr just the tip of the nail, and we were able to do the knee replacement without the complexity or morbidity of taking the nail out. This is another one, had multiple operations in the Dominican Republic. This is an interesting case because the patient had a hip replacement that was complicated, ended up with a short leg, and they compensated by lengthening the tibia, and that went on to a malunion of the tibia. As you can see, this is what's up above this, and the question is, what do you do with this patient? You know, one option is doing a total femoral replacement. However, you can't put a normal tibial component on this tibia with all this deformity, and there's really no osteotomy that can balance this or make this tibia straight. So again, with robotics, you can plan it, see if there's conflict or not. Maybe you see the plan and you're like, well, I can't do this with the robot. But in this case, we felt pretty confident that we could do it, and we're able to do it with avoiding conflict in the tibia and the femur, and the patient did pretty good. So again, I mean, I would argue that doing this is much better for I think this guy was like 45 years old, than a total femoral replacement. Uni conversions to total knees is probably the best operations we do with the robot. You know, basically you do a routine exposure, you take the plastic out, you register around the knee replacement, you take some points on the metal, and then you insert back the poly to balance the knee. And then this is kind of an example of that. You can see that the metal looks kind of like a void space, and you take some points on the metal and a lot of points around the metal. And sometimes you got to do it a couple of times to pass the registration, but most of the time it's pretty straightforward. You can pass the registration. And then as you can see on the far left side here, you see that if you make the cut here, you still have the tibial component down there, but then you can plan for a 10 millimeter augment, and you can plan it there. So basically you make your standard cut, then you tell the robot, let's cut 10 millimeters deeper to that, and then you just limit that cut to the medial side of the tibia, and you can cut for this augment like you can see here. Pretty straightforward. Again, probably the easiest way of doing a uni conversion to a total knee replacement. And then lastly, and this is where we're kind of pushing the envelope, and I think it's been very rewarding, is doing complete knee revisions robotically, because again, you're getting information, you're getting data that otherwise you wouldn't have to make intraoperative decisions. In this case, this guy's tibia was collapsing to varus. Guy had an aseptic loosening of the tibial component. So here again, you're gonna do the points on the metal, but also you're gonna do a lot of points around the metal. And again, typically you may have to do it a couple of times to pass the registration, but once you pass it, it'll give you the information you need. You can plan it, change the angles to balance your knee. And in this case, you can see we were able to do the bony cuts with pretty good precision for this revision. Now, now you're starting to see more data on this, more articles, papers on this, on surgical techniques. The fascinating thing about this is everybody's doing it. So now you're getting all these papers and stuff. So everybody, you can learn from each other and how to do it better. So in conclusion, I think, robotic knee replacement adoption is increasing in the US at a pretty crazy speed. It offers the flexibility and accuracy required for personal alignment. Historically, we would balance every knee to neutral mechanical alignment. That's not the case anymore, and that's all because of robotics. The recent data suggests improved outcomes, and the early experience with difficult primaries and revision is very encouraging. So I think we are still in the infancy of this, and we're gonna see a lot of evolution in this in the near future. So thank you very much for your attention.
Thank you very much, Suarez. That was fantastic. And just like Larabor, I mean, it's pretty amazing how technology has advanced to be able to use these tools to guide us in surgery and improve patient outcomes. So up next now, we're going to have Dr. Roy Cardozo. I want to say he's the elder of this group up here, right? You've got to have been here at least 20 years now, right? He's been serving this community for a very long time, and he's fantastic. He trained at UC Davis and then did a hand fellowship at Wake Forest, fantastic places, and has an incredible amount of experience, not only in hand and upper extremity surgery, but in hand and upper extremity trauma and peripheral nerve surgery and repairs. So definitely a huge need in this community. So I welcome Dr. Cardozo.
Thanks for pointing out I'm the oldest person on stage. Appreciate it. Thank you all for taking time out of your busy clinical schedules all over the world to come and spend some time with us. One of the joys of being part of Baptist, I've been with Baptist now for the last 3 years, besides working with phenomenal colleagues such as these guys up here, is the connections we've fostered thanks to BHI with docs like yourselves. And so I encourage you, even if you have questions about patients as it relates to hand, to reach out, and we're happy to help facilitate that. I'm going to talk today about something a little bit different. It's a technique for fixing bone that doesn't involve plates and screws. This is my disclosure. And basically this is sort of like an angioplasty for bone, or a kyphoplasty as it were. So it's a patient-conforming intramedullary implant. And basically you put a balloon inside the bone, and then you inflate that balloon with a liquid, and then you shine a light through it, similar to UV light, and it turns that liquid into a solid. It has multiple applications. I'm going to explain my experience. This has been available in Europe since about 2014, and in the United States since about 2020. So procedural steps, I won't bore you, those of you who aren't orthopedists, with all of it, but basically you make a small perforation in the bone and you put this balloon inside. It fills the intramedullary canal. Then you put the liquid in and it inflates and it conforms to the bone. And then you shine a light through it and it turns from liquid to solid, and then you cut the tip off. Let's see if this little video plays. So if you center your cursor on the little square, it should play. There you go. So it's running. So basically you just see the balloon inflating inside the bone. So these balloons come in predetermined shapes depending on your application, which bone you're going to use it for. They have a thin wall that conforms to the shape of the intramedullary canal, so you don't need tons of inventory for different bones. And they maintain their dimensional shape. And so then this light shines through it, and there is an exothermic reaction, so it becomes warm. If you're an orthopedic surgeon, you're familiar with bone cement that becomes very, very warm. Up to 100 degrees Celsius. This doesn't get that hot. It gets to about 62 degrees Celsius and only for about 4 minutes. So it's not particularly harmful to the bone. And it has multiple indications for use. It can be used in standalone fracture care, for metastatic bone disease. It can be used as supplemental fixation for fractures around various parts of the body. It's great for geriatric bone as well. Because it conforms to the bone, there's immediate rotational stability as well. You don't always need screws depending on what sort of fracture you're using it for. And also can be supplemented with hardware. It increases the pull-out strength for screws as it drills through. So basically this slide just shows that the pull-out strength with the implant is much higher than without the implant. And it can be used, because it starts out as a liquid, you can curve it around prosthesis. You can use it in curved bones as well, which is helpful. So I'm going to talk about my experience, which is around the distal radius. I've been using this for the last 2 years or so. I've probably done about 30 cases or so utilizing the technology. So this is a typical case. It's a distal radius fracture. It's extra-articular in a patient in their late 50s. And so, of course, the options are to cast this or put a plate on this, but this technology allows minimal soft tissue and return to activity a little bit sooner than some of those other things. So this is just kind of me walking through these steps. I've put a little wire in to temporarily reduce this, and then I reamed the inside of the canal. If you have placed an intramedullary nail in a femur or a tibia, it's sort of a similar process. I put in this K-wire. This is me pushing the balloon medially to support the medial column of the radius. Then the balloon is inflated, and this is the final reduction after the implant is cut. Here's another case. So this case was a little bit different in that the fracture was at least 2 weeks old, so it didn't easily reduce. And so through an incision, I usually do a carpal tunnel release with these. So through the carpal tunnel incision, I was able to kind of minimally invasively reduce this fracture. And then this is me putting in the wire and going through the same steps again, placing the balloon. And then once again, another fracture that's fixed this way. And you can see that this is done through very, very small incisions. The incision along the palmar side is for the carpal tunnel release, and then the incision along the radial side near the thumb is where you actually put in the implant. And you can see here in this next slide, this patient is 3 days after surgery. If we click on it, the video will start. And you can see that there's minimal swelling and she's able to move her wrist. You can see that her stitches are still in place. This is literally just a few days after the surgery, which would not be her result if she had a plate and screws in. So there are many other applications for this. The next few slides are not my cases, but just to show you some of the things that it can be used for. So this is an proximal humerus fracture. This is used in addition to placing an intramedullary nail in the humerus or with a plate. This is just walking through a proximal humerus fracture. I'd have to consult with Dr. Suarez, but I think this is a knee. I don't deal with this joint very often. And this is used in addition to placing screws in a plate in a very distal femoral fracture. It can be used around prostheses as well, which is a nice addition where you probably would have difficulty placing plate and screws in that area. It can be used in pelvic fractures. Again, it's used in curved bones, which is useful. Acetabular fractures, it can help to support as well. You see the little wires in the middle picture and then the balloons occupying those areas. And metastatic disease as well, in filling voids. Because a lot of these people who have metastatic disease are ill in terms of their health, it's helpful to have a minimally invasive option sometimes. And this is in a tibial plateau fracture, once again supplementing this, and then in ankle fractures as well. So a common question I get is, how do you take it out? Hopefully you never have to, but there is a known technique. And so one of the things is this balloon shrinks about 1 millimeter all the way around once it hardens. And so it doesn't have bony ingrowth like some of the metal prostheses we put into the bone. And so there's a technique for you put in a wire and you can pull it out relatively straightforwardly. So that's the extent of my talk. Thank you very much.
Okay. Well, that's pretty interesting stuff. One of the things that never ceases to amaze me is the amount of innovation that happens in our space. And in orthopedics, there's a lot of different ways that we can solve problems. And that's something that I think is very out of the box, or at least you would think and perceive that it's something that's very out of the box. But once applied clinically, it really makes a whole lot of sense. So, and you know what, I forgot to mention, so as far as having, partners that I would let any member of my family have surgery with, Dr. Cardozo actually released both of my carpal tunnels as well. So just to let you know that I'm not just saying that. So now, I guess it's my turn, right? So I'm just going to talk to you a little bit about how I perceive the treatment of some of the most, the patients that we have that sometimes need the most help, which is the orthopedic trauma patient. But, one of the things that we see a lot in South Florida is the active elderly patient, oftentimes with osteoporotic or fragility fractures. And over the last several years, there's been a change in the paradigm in the way that we approach these fractures and the way we treat them. So, as I'm sure everybody knows around here who's sitting down, no matter what field of medicine you're in or involved with, or even if you're a physician or not, you're in healthcare and you know that fragility fractures are a worldwide problem. Just in the United States, there's 2 million osteoporosis-related fractures, and there were in 2005. The total healthcare cost was estimated to be $17 billion that one year. And the population is only aging and getting older and is staying active longer, which is also very important. And it's estimated that by 2025, the incidence and its associated costs are going to grow by 50%, or will have proven to grow by 50%. So just to start off by talking about hip fractures, because really this entire paradigm and the way that we think about treating these patients with these fractures really started with hip fractures. Hip fractures are extremely common. They're present everywhere in the world. Everybody gets them, or not everybody, but at least 300,000 people get them in the United States. And it's estimated that by 2040, it'll be upwards of 500,000. They result in decline in functional capacity, mobility, and independence in patients regardless of treatment. And they pose a significant burden to patients, families, and the healthcare system as a whole. So there was a point in which physicians started looking at patients with hip fractures and stopped looking at them like they're an elderly, frail individual, and started looking at them as a patient who may be elderly, may be frail, but also needs to have a return to their level of function as quickly as possible to avoid not only complications, but rapid decline in function. So one of the papers that I consider seminal in this sort of thought process was by Zuckerman and co-workers in 1995, who I had the honor later on, well after that, of training under, where they stated that when the factors of the patient's age and sex and the number of pre-existing medical conditions were controlled, it was found that an operative delay beyond the period of 24 to 48 hours approximately doubled the risk of the patient dying before the end of the first postoperative year. So delaying this surgery beyond that 24 to 48 hour mark basically doubled their chance of not surviving past a year. And this is due to most devastating complications were really due to prolonged recumbency, both preoperative and postoperatively, including pneumonias, venous thromboembolic events, cardiovascular complications, decubitus ulcers, and so on. So there's no question anymore, and over the last 30 years, that prompt surgery, urgent surgery, and immediate weight bearing is the way to go with these patients. And you know, that was in 1995, and this is a paper nearly 30 years later where they're still looking at this and they're still verifying that this is absolutely the case. And delays in surgery for any perceived reason that we think is helping the patient by obtaining more consults and clearances and optimization was actually hurting patients. So they said, Marenghi and co-workers said, regarding surgery within 24 hours and not more than 48 hours, with regards to that time period, delayed surgery was associated with an increased risk of 30-day mortality and other complications, and those remain significant both at 90 days and at a year out. So now this is kind of where this brings me to this particular portion of the talk. That's great, and it's great that we treat hip fractures quickly and get patients up and moving so they don't lose function. But what about every other fragility fracture that there is? We have not really thought about these historically and traditionally in much the same way. But I would like to challenge everybody in this room to look at them in the same way, because an intra-articular distal femur fracture, a proximal tibia fracture, and even at the end of the talk, we'll talk about proximal humerus fractures, and they're not even in the lower extremity. They're still fractures that significantly affect the patient's mobility, both preoperatively, perioperatively, postoperatively, and we should really be thinking about them through the same lens that we see hip fractures. So, you know, I think that some of the traditional treatments that we have may be becoming outdated as we begin to collect more and more data on these patients. ORIF, which means open reduction and internal fixation, was traditionally and still continues to be done with plates and screws. These are what we call load-bearing implants. So the weight and the forces are transferred from the bone to the implant. The implant bridges the fracture and absorbs essentially all of the weight that and all of the stresses on that part of the body. So traditionally, these would require non-weight bearing restrictions. We're not letting patients put their weight on their leg. And in an elderly patient, no matter how active they are, this is a devastating thing to have to make someone do for the 6 weeks, 8 weeks, 10 weeks, whatever it is. So this makes sense, but there is a complete paucity of literature studying the effects of surgical timing on these outcomes, even though for the last 30 years, there's been paper after paper after paper on hip fractures. So I think we can extrapolate and presumably extend some of those same strategies of early surgery and rapid rehab to other fragility fractures that would otherwise limit the patient's mobility. And like I said already, all these mobility affecting fragility fractures will result in decline in functional capacity, mobility, and independence. So these are just a couple of cases showing very, very well done surgeries, but very traditionally well done surgeries in which we're using plates and screws for treatment of periarticular and intra-articular extended fracture patterns. Plates and screws are still very useful. They afford more points of fixation than, for example, intramedullary nailing can afford. You can get much closer to the articular surface. You can compress osteoarticular fragments, and they're still very much the mainstay of treatment. However, they are load-bearing, and basically for every single one of these surgeries that you see on here, these patients had to undergo an extensive and lengthy period of non-weight-bearing restrictions. Now, intramedullary nailing is another option that we have, and this is great because as opposed to load-bearing, these are what we call load-sharing devices. Because it's positioned in an intramedullary position, we're not completely bypassing the fracture with the implant. The implant and the fracture are sharing in the load, and oftentimes we're able to make patients weight bearing is tolerated, which means we can let them start putting weight on it right away. However, we're limited in what we can use these for. These fractures really are limited to what we call metaphyseal or metadiaphyseal fractures, where we're not quite so close to the articular surface with fracture extension. Basically, you're afforded less points of fixation than a plate and screws, and generally are limited to fractures with minimal articular involvement or minimal joint involvement. So that brings me to nail plate combination techniques. And this started probably about 5 or 6 years ago. And this is one of the first papers that really described the technique and described the effectiveness of this technique, which has paved the way for more and more research to be done since then. A nail plate combination technique combines intramedullary nailing and locked bridge plating. And so then you are able to take advantage of both techniques. The plating will allow you to improve the fixation of the juxta-articular and intra-articular fracture, increase your points of fixation, while at the same time having the advantages of nailing, which are intramedullary stability and load sharing. So combining these two techniques can improve the stability of fixation and still allow for more aggressive mobilization postoperatively. So here's one example of a 65-year-old male, healthy, active, community ambulator, independent person. He has this displaced, comminuted, and unstable distal femur fracture. He has a previous femoral shaft fracture from 20 or 30 years ago, I believe it was. But this is a patient which I would have loved to use an intramedullary nail, but intramedullary nailing alone would provide insufficient fixation, especially because of what I'm about to show you. There's a lot of intra-articular comminution. If you follow the femur all the way down to the joint has several fracture fragments extending into it, which would make it so I'm at very high risk with an intramedullary nail of displacing the entire distal femur. So this is an ideal candidate, in my opinion, to avoid a significant and prolonged non-weight-bearing period with using a plate alone, and risk having him lose a significant amount of mobility and function over time. So after performing an operative reduction, reducing the length, alignment, and rotation of the fracture, I'm able to place a submuscular plate, which basically means a minimally invasive way of placing a plate up the femur and provisionally holding that alignment until we're able to insert an intramedullary nail and then go back and complete the fixation of the plate as well. So a combined nail plate technique can improve fixation over intramedullary nailing alone and improve the stability over plating alone. And this is a patient that I would immediately allow weight bearing, and as the literature is starting to bear out over these last 5 years or so, really improve their functional outcome at 3 months, 6 months, 1 year, and beyond. Here's another patient, 76-year-old female, community ambulator. She uses a walker for almost all of her ambulation. So this is someone who is at very high risk. And I don't think I need to tell anybody in here that if you take a 76-year-old woman who is dependent on her walker for ambulation, and you make her non-weight bearing for any period of time, even 3 weeks, 6 weeks, she will have a significant decline in her function and may even end up getting stuck in a wheelchair. So this is another situation in which a nail plate combination would be ideal. And I think that this is something that is important to extend into this population. This is something that really also, I didn't mention, really was popularized more in the trauma population, which is oftentimes young, healthy, active individuals who we were trying to get back to their activity quicker. But really, I think this is a more important patient population to apply this to. So after doing a little bit of planning and making sure that my provisional fixation with the plate and the screws doesn't get in the way of an intramedullary nail, we're able to perform this dual fixation technique. And although there's some technical challenges of having to watch out for one implant and the other with regards to them getting in the way of each other, this can really provide a lot of benefit to the patient. And like I said, I think this is almost the most important patient population to be looking at this with. So once again, improve fixation over intramedullary nailing alone and improve stability over plating alone. So now, let's think a little bit outside the box. Dr. Lirabor actually did an excellent job of describing the concepts behind reverse shoulder replacement, and I'm not going to go over it again because I think he did a fantastic job, and I'll actually kind of just move ahead. But I think that one of the biggest advances in this operation, and why the operation is so good, and why you saw such a great result a couple of minutes ago, is we started to look at it through a different lens and actually started restoring a more anatomic neck shaft angle. the design of reverse total shoulders began not only medializing the center of rotation in order to improve the deltoid lever arm, but also lateralize that entire construct to allow for a more anatomic neck shaft angle. So the traditional complications with reverse shoulders of scapular notching, tuberosity, migration, displacement, and non-healing because of excess tension, and acromial fractures and deltoid atrophy due to excess tension on the deltoid were also essentially eliminated in the literature. And unlike the other problems that I told you that really don't have a lot of literature yet supporting it, this is something that has been studied extensively over the last many years, probably 20 years or more. Reverse shoulder replacement for fractures have been shown to have either equal or superior results in head-to-head studies with hemiarthroplasty, with open reduction internal fixation, and even with non-operative treatment. So, as far as reverse shoulder replacement, it essentially completely replaces hemiarthroplasty for me in all but special circumstances. 4-part fractures, fracture dislocations, 3-part fractures, and especially, like I was saying throughout this entire talk, in elderly but very active individuals or elderly patients that are at risk for losing their mobility. So the bottom line, I think, is the most important. This is done, we do this for fractures in patients who depend on their arms for mobilization. And traditionally, not only do we think of hip fractures, but perhaps we're even thinking of lower extremity fractures, but we really need to think about upper extremity fractures too. And so here's an ideal patient for this. This is a 79-year-old female. She's a household ambulator. She really doesn't walk much outside the house, but can get around in her house with a walker. And this is somebody who's teetering on the point of becoming essentially wheelchair bound or bed bound. She can get herself up, she can push off with her arms out of a chair, help herself up, sometimes with assistance, sometimes without, pull herself up off of a bed, but she needs that walker for mobility. So she needs her arms just as much as she needs her legs. And this is something that I think we should be looking at. So this patient has a fracture. It's a displaced 4-part proximal humerus fracture. In many situations, this is not an extremely terrible fracture. She may end up with some subacromial impingement because of the superior migration of the tuberosity or the relative inferior migration of the surgical neck. But this might even, in some situations, be a patient that you might treat non-operatively. But in this particular patient, I think you'd be relegating them pretty much in the same way that a patient with a hip fracture would, to a very poor result. So a reverse shoulder replacement, in my opinion, a press fit reverse with anatomic tuberosity repair can provide this patient with excellent results. And the reason why is because the combination of doing this also with using a cerclage, and I use a suture-based cerclage in the metaphysis in order to prevent fracture propagation during humeral preparation, but also in order to incorporate it into my tuberosity repair and increase the stability not only of my tuberosities for future shoulder function, but also for stability of the implant, allows me to be able to make these patients weight bearing as tolerated without any restrictions. So in a patient like this, and probably deviating a lot from the traditional, not only indications for this surgery, but also the traditional postoperative management of this surgery, this is a patient that I would allow right away to use their arm in any way they need to for transfers, in order to be able to push themselves off of a chair, to pull themselves up out of bed, and to use their walker without any restrictions whatsoever. So, as I've run out of time, one quote that I think really sums up this entire talk was actually from that first paper by Liparachi and Yoon that I quoted. And they said that with the elderly population staying healthier, more active, and living longer, the low energy fragility fracture is increasing in incidence. And with morbidity and mortality similar to that of the hip fracture population, the goals in operative treatment require urgent operative fixation to allow for early mobilization. And that's that. So thank you for staying awake through that talk, I think, or for waking up during the clapping. But we've got one more talk for you in which you definitely will not fall asleep on. So Christopher Hodgkins, what can I say about him? He's Haji, and we trained together also. I'm also very lucky that a large number of the people that I practice with, I actually got to be in the trenches with. And Chris Hodgkins and I were fellows together at the Florida Orthopedic Institute in Tampa, and we both worked together in the trenches at what was at the time, and probably still is, the busiest level 1 trauma center in the state of Florida. He's a foot and ankle surgeon, foot and ankle trauma surgeon, and he's gonna talk to you about some really, really innovative techniques for fracture fixation.
to present to our international colleagues. And thank you to the International Department for putting this together. Thank you for the invite, I appreciate it. Thank you, quick shout out to my research slaves over there for helping with my slides, Danae and Paloma. Oh, I'm not sure they deserve a clap, but anyway. Thank you to my colleagues for some great talks there. So I realize that I'm the only thing standing between you and happy hour, so I'm going to get through this quickly and hopefully have a little bit of fun as well. So a couple of disclosures first. I am an Arthrex consultant. I am going to be discussing the use of some of the products, but I have no royalties in these products. And I was a believer and a heavy user of intramedullary nail fixation for fibula fractures long before I engaged with them. I engaged with them because I saw the genius of these products and I wanted to try and make them better. I genuinely believe that this is a better way to address ankle fractures. Learning objectives today, we're going to show how I think we can improve treating ankle fractures. We're going to look at the advantages of the nail over the plate for fibula fractures, and we're going to look at some groundbreaking research that came from Baptist Health Orthopedic Care. And I'd like to set the scene here. So an ankle fracture has always been thought to be an intern case. Even when Dr. Cardozo was a resident 100 years ago, it was still an intern case, and it still is, and nothing has really changed. But these fractures, these injuries are not without complications, such as wound healing problems and the need for hardware removal. And so we looked at if there was a better way to do things, and we've subsequently published the largest single surgeon series of fibula nails in the world, and we've had some great results, and I'm going to report some of them to you. So I think that ankle fractures are actually very difficult, and I think simple fractures even are difficult, and I think we all have the wrong mindset. And that's because these are very complex injuries of not just bone, but also soft tissue and cartilage. And I think too often we just see the bone, and then we fail to address the rest of the components of the injury, which leads to poor outcomes with very poor salvage options in what is frequently a very young population. And so I think the solution is a comprehensive approach that considers not just the bone, but also the ligaments and the joint injury as well. And I'm guilty of this too, but my X-ray vision is frequently very short-sighted. And so I try not to see just the bone, but rather to see this, the three-dimensional dynamic bone and soft tissue anatomy, and try and address each one of these components. And so when I see an ankle fracture and treat an ankle fracture, I try and address these following areas. I think a pre-op CT scan is valuable, arthroscopy, minimally invasive fixation of fractures, addressing the ligamentous injuries, introducing biologics, and then following our outcomes. And we're going to touch on these areas a little bit here. I think a pre-op CT scan is incredibly valuable and always changes my surgical plan. This is an intra-articular fracture. It deserves a CT scan. I think ankle fracture arthroscopy is very valuable also to identify and treat chondral injuries and ligamentous injuries and instability, confirm reduction, and document pathologies, particularly in our elite athletes. I use the ankle fracture nanoarthroscopy. It has a very minimal setup. It's quick, easy, and staff-proof, very small camera, almost leaves no surgical footprint whatsoever. I scope every single ankle fracture. I don't get paid for it. It takes me longer. It's more difficult for me and the staff, but having seen what I've seen scoping ankle fractures, I can no longer not look in the joint. We've proved that ankle fracture intra-articular pathology is over 80% in these fractures, and so for the sake of a quick, easy plug-and-play technology, I scope them all, and it's amazing what you will see. I think we all frequently ignore ligamentous injuries, which may be the most important, and now there's technology which allow us to address these with flexible, minimally invasive hardware. And the internal brace technology also allows us to repair, reconstruct, and reinforce all of the ligamentous injuries around the ankle, which leads to better results. And don't forget about biologics and wound care. It's playing a much bigger role in my practice and in orthopedics in general, particularly non-operative orthopedics. And finally, we need to monitor our outcomes to prove that this is the right way to do it for better outcomes for our patients. And thankfully, Secondaries Baptist and our foundation, we have OBOD, which is a research tool, which is allowing us to prove this to us, our patients, and the rest of the world. And we did this for the fibula nail, and we've recently published a groundbreaking article in the Journal of Orthopedic Trauma, consecutively looking at our consecutive series of fibula nails. So that's my first goal, how to have this comprehensive 360-degree approach to treating these ankle fractures. Now, my second goal is to treat these minimally invasively and maximally effectively. And we do this with the fibula nail, which allows minimally invasive fixation of the fibula fracture. And I'd like to talk to you about my journey a little bit about why I started using the nail. And the truth is, initially, I'm embarrassed to say it, but I didn't want to use it. And I don't want to admit this, but Charles actually stimulated some of my interest in it because I saw him doing it. I'm like, what's Charles doing in that OR over there? And I saw he was doing it. I was like, well, I got to start doing that. And so I'm embarrassed to say it, but initially I was a very big naysayer about the nail. But since then, I've now implanted over 300 nails, which is a lot more than Charles, by the way. And but what changed and what made me go from being a nail skeptic to a nail lover? And I think many surgeons have the same anti-nail stance that I had, because traditional ORF of ankle fractures is actually okay, and it is okay. The old nails had no proximal fixation, so the devices weren't great. And also the nail had very narrow indications. And again, I was very short-sighted about the nail because there's nothing wrong with traditional open reduction and internal fixation techniques with a plate and nail construct for ankle fractures. And I'm not saying there is. What I am saying is that maybe we can improve and do it a little bit better. Also, this idea of no proximal fixation, because the nails on the market weren't able to hold the reduction, but now newer nails have proximal fixation, and this proprietary technology which allows us to hold that rotation. And again, the nail was presented to me for soft tissue compromised patients, and it really works very well in these particular patients because it respects biology with minimal disruption of soft tissue, blood supply, and periosteum, and so it's a quicker, safer, and better technique, and I think everyone would definitely agree with this. So I did my first nail in such a compromised patient, but during that nail, I thought to myself, why am I reserving this respect for biology for only my high-risk patients? Why am I not applying this best surgical principles to all of my patients? And thus my first nail literally became my last plate. And this is how I manage ankle fractures in 2023. They all get a CT scan. They all get a nanoscope. They all get minimally invasive fracture fixation. I look hard and address ligamentous instability, particularly the syndesmosis and the deltoid, and I'll consider biologics, and they all get a fibular nail. Again, all my fractures get a fibular nail. There's no selection process here. And whilst this always raises some eyebrows in the audience, I challenge surgeons to ask themselves, why not apply the same surgical respect and biology to all of your fracture patients? The nail allows a much more minimally invasive and biology-respecting approach, thus avoiding stripping the entire fracture and adjacent fibula and respecting biology. It's not only smaller incisions, but it's a much smaller surgical footprint. But it's not about cosmesis, it's about much more. It's about biology, which leads to much faster healing. Add to that the biomechanical effects of the load-sharing Boehringer device. We're also bone grafting our fracture, increases our biologic and mechanical advantage. It's a much quicker surgery for me. And here's a quick video just to show how easy it is. And I'd just like to point out that unlike my colleagues here, we don't have a robot that does our surgery for us. We have to do it ourselves. Can we have some volume, please? Volume. We just have some cool music, but can we fix the volume for the last slide? So there you go. Very, very easy and all done minimally invasively through very small incisions, which makes patients very happy. These patients have far less pain and swelling, which leads to earlier restoration of motion, strength, and comfort. Patient on the left, 2 weeks out from surgery, allowing full manipulation of the ankle. This week, the patient is 6 weeks. Like Charles said, we want to get these people up and moving much more quickly for better outcomes. This patient walked into clinic at 6 weeks without her boot on, which I've never seen before. She had a scope, Villoch, deltoid repair, and a tightrope. These patients are self-regulating, which I'd never seen before. This is an athlete that we cleared to return to play at 3 months, but apparently he'd cleared himself a month before that. It's just leading to improved outcomes and much happier patients in my practice. So it's all well and good for me to stand up here and tell you that, but prove it. Show me the literature. Well, the nailing's been around for a long time, and even these old devices and old papers with no fixation and closed reduction techniques still fared better than plating in terms of morbidity and complications. There's more literature out there proving that the nail is definitely better than the plate. You'll see here that the early nails had a lot of failures. And this particular paper showed that the importance of this paper was that nails need proximal fixation to work. So even all this old literature with old devices and old techniques still fared better than plating. So out with the old and in with the new, we now have 2 randomized controlled trials proving that nails are more effective than plating with better results and lower complications. All the literature out there supports nailing over plating. And this is my fibula series. We had the same experience. And as I say, we published this more recently in the Journal of Orthopedic Trauma. George Fleitas here, great medical student, helped me with all this data. I'm going to skip through these slides a little bit because they're very details that we don't really need to consider for this kind of presentation. But one of the interesting things was that we don't have to wait to operate with the nail because it doesn't matter how swollen they were, because if operating through smaller incisions, you can do it immediately. Only 8% of my cases were truly these percutaneous small incision cases. I open almost 100% of my nails now with only a 2 or 3 centimeter incision to get a perfect reduction. We're going to present this here, but the Villoch results, this is our data. In our first 100 nails, 0 non-unions, 0 wound complications, 0 loss of reduction, fast bony union, fast motion, weight-bearing activity, and only 1 hardware irritation from a screw that I left proud. That was my own fault. We have much more to come. We're publishing our 200 series soon, and we've got 50 with patient-reported outcomes. We had a couple of complications in these highly comminuted fractures. I had to convert them to a plate intraoperatively because they're very difficult to fix even with a plate. However, we now have a plate-assisted nail techniques, which allows us to fix these incredibly complex fractures through incredibly small incisions like this, which benefits the patients enormously. We did have a complication of a neuroma. The key take-home points: that this is the largest single surgeon nail series in the world, 0 wound infections or complications, and this is with a mini open reduction, which doesn't negate the advantages of the nail, and with no implant removal or second surgeries, because it's a no-profile construct. In the future, as I say, Obert is helping us get great data on these. We've submitted our 200 nails, and we have our patient-reported outcomes coming. A couple of case examples for you. The fibula nail fits everyone. There's a lot of people who say it can only fit certain fractures. I can make it fit any fracture. This is our standard Weber B patient that we saw a little bit earlier, fixed through a very small incision there. This is her walking at 6 weeks, golfing at 8 weeks. The golfers out there will see her swing plane comes a little over the top, but that's not any fault of my nail. Here she is at 10 weeks at water skiing. I think this woman just enjoyed pushing my buttons because she knew it scared me to death, but I got some great videos, and you learn from these patients because you learn what you can get away with, and we're still great friends. So here's a Weber B with a deltoid fracture, these higher Weber C fractures fixed perfectly with the nail. Here's a bimalleolar ankle fracture, which was traditionally would have been fixed through an enormous incision like this. But now the nail allows us to fix it through incisions like this that you see on the bottom there, and I'm sure you'd prefer the one on the bottom. Here's a trimal fracture, great motion very early. Even comminuted fibulas fractures, even fracture dislocations can come together nicely with the nail. And this is a transverse diabetic fracture, very complex fracture fixed through very small incisions, definitely very difficult, but well worth the extra effort. Here's one with a distal tibia fracture. Unfortunately, this was the one where screws had to be removed because I left them proud. Segmental fibula fracture fixed very nicely with the nail. It's ideal in bilateral cases, like Charles was saying, because I can weight bear these patients immediately. In these very complex pilon fractures, we now nail a fibula immediately. And it works for everyone, even in professional athletes. This is Aaron Ekblad. He gave permission to present this. He had an awful ankle injury in the playoffs a couple of years ago. Here's his nanoarthroscopy. He had multiple loose bodies that we fished out from the joint. We did a very comprehensive repair, medial lateral ligamentous repairs also. Here's his intraoperative stress and his final films there, and he's back playing at elite level and was in the Stanley Cup final last year. Again, the Villoch fits all fibula fractures. So why the fibula nail versus a plate for every fracture? Well, the nail is superior to plating. It's quicker, smaller incisions, it's biologically advantageous, mechanically advantageous, less pain and narcotics, less swelling and stiffness. If you need more, and you shouldn't, there's less wound issues, less superficial and deep infection, less non-union, less hardware irritation, less second surgeries, and less complications. So it really shouldn't be while the nail versus the plate, but really, why not? So in conclusion, the nail is safe and superior. It will become gold standard. There's no doubt that this is a better way to fix ankle fractures. And this is a quick little video showing why we do what we do and how much we enjoy it. Do we have some volume? No. There you go. Thank you very much.
So
before we start with question and answers, can we have another round of applause for everybody who gave talks today? And for everybody from the other sessions too, from neurosurgery, from MCVI, and for everybody else who presented today. I will say that I'm very glad to have ushered in a new era for Dr. Hodgkins in his surgical practice. It was like, for me, it was, again, with the active elderly patient, it was always a cringeworthy moment to have to make an incision this big to fix a fibula fracture. And when I started doing minimally invasive techniques and not having to worry so much about skin breakdown in patients who already have very poor skin below the knee, and having them come in and from their first post-operative visit 2 weeks later, they're moving their ankle as if they never broke it, and it really makes a huge difference. Let's get started with questions. If anyone has questions in the audience, if not, we'll start doing some discussion as well. Does anybody have any questions for us? Yes, in the back, please.
Conventional knee replacement surgeries. You mentioned the improvement in functional outcomes. What about the patient-reported outcome measures between conventional and robotic-assisted total knee arthroplasty?
Are our mics working? Is he able to speak from from there? Okay, perfect.
So that's, that's the million-dollar question. And now there's papers out there that suggest that the PROs at a year are better. Now, what I would submit to you is that the patient-reported outcomes that we use are garbage, and they don't have the granularity to differentiate the minutia of satisfaction of a patient. So they're very crude tools that we use as like a 12-question questionnaire. And what we need to be working on is like better scores, like the forgotten joint score and stuff like that, to be able to determine. I think the biggest difference is in the early post-operative function of these patients. They recover more predictably. But your point is well taken. I think we need to do more work on that. But I think that you will see significant advances in that front as we move forward.
So if anybody has any other questions for Dr. Suarez with regards to total joints, robotic total joints, or anything like that, it'd be nice to kind of segue from one sort of question to the other within that topic. If not, anyone else can ask us anything.
Thank you. The question is probably for all of you. It's related with a specific situation. What about patients who has inherited connective tissue diseases like Ehlers-Danlos? A lot of them practice sports, especially because of their hyperlaxity, hypermobility. They are prone to have several, sometimes very grave lesions. Do we expect more post-operative complications or less successful recovery, in fact?
So that's a good question. What do you think with connective tissue disorders such as Ehlers-Danlos? Does anyone want to comment?
Yeah, so for myself as an arthroscopic sports medicine surgeon, most patients with hyperlaxity, number one, they end up with increased risk for dislocations, joint breakdown, soft tissue tears. So many of us see patients with hyperlaxity, and yes, they are at high risk for complications. Let's say if you repair their labrum, they are at risk are at a higher risk than the general population for let's say after a labral repair, dislocating again. And that's something obviously we take into account. But depending on the procedure, it has different kind of risk profiles. So let's say if you have arthritis, I think it's less of a risk if you're in the older population. But let's say versus a 20-year-old who plays football and tears their labrum and now they're dislocating. So it definitely depends on the actual surgical procedure. It depends on the age, because as we age, we lose a little bit of flexibility. So there's it's kind of multifactorial in terms of their risk factors, but that's something that obviously we all take into account.
I think it's interesting that you bring up Ehlers-Danlos. so I see a lot of patients with ligamentous laxity in general. If you explore the literature, you know that ligamentous laxity is a spectrum. And so there's lots of people who are diagnosed with Ehlers-Danlos who have ligamentous laxity. And some of the things I see, especially when I see a young person, somebody who's 25, like, why are you in my office if you haven't had an injury? There's lots of people who have aches and pains. And a lot of times, those people tend to have ligamentous laxity. And some of my job is to kind of do a laxity examination or flexibility examination and kind of determine that. And a lot of it has to do with educating that patient on what to do. And I think somebody who doesn't take the time to kind of look into that would perhaps rush to do a procedure on somebody who actually doesn't need a procedure. And some of those people who have had surgeries, justified or otherwise, because they have this collagen disease, or collagen doesn't always behave the same way as you'd expect. And ironically or counterintuitively, some of those people develop contractures around the joints that have been operated on, which I've seen. I saw a patient who had a thumb ligament repair done, and this postoperatively, this poor woman developed this severe pain and contracture around her hand, and she had a diagnosis similar to Ehlers. So something to take into account as well.
That was an excellent question. Anyone else? Any other questions? I have one for Dr. Hodgkins. How has your postoperative protocol and time to weight bearing changed since you've been doing fibular nails?
Yes, it definitely has. And I definitely weight bear them all more quickly. I think that the caveat to that, I've actually got a very complex post-op protocol, is that in grossly unstable ankle fractures with a complete deltoid tear and complete syndesmosis tear, just because you stick a nail up them doesn't mean you can weight bear them immediately. So yes, in the very simple fractures, definitely. Sometimes we hold patients back simply because of the amount of swelling that they're going to get from the big incision. I'm not worried about that now. So there's some fractures I'll weight bear immediately. But so yes, it has, but there's still certain cases where you need to hold back.
Yeah, and I think that's one of the challenges that I continue to challenge myself with when I take care of somebody who happens to be older and I want them to get back to weight bearing quicker. I've really pushed the envelope over the last several years on weight bearing, even including immediate weight bearing, because of everything that I mentioned in my talk. Does anyone else have any other questions?
Charles, I do.
Yes.
Okay. First of all, very inspired, guys, from your presentations. I realize I've been in the administrative office too long, because coming here and you guys, it brought me back clinically, really inspiring. And so my question to Dr. Ribas is, for your, and I'm very familiar with your case study, because talking about an arm that couldn't move, I'm very familiar with that, with him. What were your restrictions post-op? Did you have any restrictions post-op? I know Charles, Dr. Jordan mentioned, you want to get the arm moving on the reverse shoulder, but on your technique, is there any restrictions?
Yeah, so I actually get them. I get them. Same with Charles. I get them moving right away. With reverse total shoulder arthroplasties, as opposed to anatomics, you're not as worried or reliant on the subscapularis to heal. So once you put those implants in, there's a good fit. You have good fixation. I get them moving right away, because in my opinion, the longer the shoulder is a joint that inherently loves to get stiff. So the faster you get them moving, the better their outcome. And you can see him by 6 weeks. I mean, he had essentially normal range of motion. On average, reverses in general get about 130 degrees of forward elevation. I mean, he surpassed that by a lot. So I think the faster you get people moving, and the better our techniques get, the more confident we are in our fixation intra-op, we can leave there and say, okay, get moving right away. And the faster people move, they get less muscle atrophy, they get less stiffness, and they have overall better outcome.
Awesome. And then for Dr. Cardoso, are there any restrictions to use the balloon procedure?
So I have a fairly strict indication for the balloon. So it's certainly not for every fracture and for every age group. So at least in my practice, since I don't see much tumor or metastatic disease, I use it strictly for patients in their 50s or above with sort of osteoporosis or insufficiency fractures. Speaking to some of my colleagues about insufficiency fractures, it's a great solution for that. But it has to be a specific sort of fracture typically to use the balloon.
And early weight bearing allowable, or?
So that's one of the benefits, yeah. So they don't, at their first postoperative visit, they're already in a splint and starting therapy immediately. They can start weight bearing as it relates to the upper extremity at least soon.
Awesome, thank you.
I think I saw a couple of hands go up. How about you guys back there?
Hi, just to say, it's really good to hear a presentation with some detailed outcomes data, and a number of speakers have touched on that today. So thank you. But it was a general question, but I think yourself or this panel might be able to answer it for me. Is if I want to look at outcomes data for this panel or any of the other speakers today, is that something that Baptist publishes? Is it something where we can go and have a look at physician outcome data? It's just a knowledge question for me.
I can talk about that. So we collect patient-reported outcomes, and I think the 20 most common operations that we do through a platform called OBERT, and depending on the surgery is the PROs that we collect. For knees and hips, we do PROMIS, Who's Junior or Coos Junior. That is something that we publish every year in a supplemental of orthopedic care that we have. So that is data available. We also use OBERT because we can compare ourselves to other institutions that use OBERT. So that's something that we leverage.
Is that by institution though, or by
so
surgeon?
in the United
So
States,
if I want to choose the best surgeon for my patients, can I do that through that system?
That's a great. I don't know if you can. I don't know if there's a dashboard that you can access and look at the PROs of me versus one of my total joint colleagues. I don't think you can do that currently.
Okay, thank you.
Ed, I don't know if you have anything to add to that, but I don't think that, we use it internally and to compare ourselves to other institutions. I don't think we have a tool right now that you can go in and divide by surgeons. And one of the things that I'll tell you is sometimes it's hard, like collecting PROs preoperatively to a 1 year postoperatively, which is clinically relevant, is extremely difficult in our current environment. So we have a team that does that, but we need to continue to get better at our hit rate with these patient-reported outcomes.
Anybody else? Any other questions? So, just a couple of comments. I do think that, Dr. Suarez mentioned that we have an annual publication in which we're not only showing some of our patient-reported outcomes and some of the outcomes and innovations that we're adopting in our practice. There's also, I think one of the things that our leveraging of these sorts of databases and technologies has allowed for is a lot more of an increase in our ability to publish our outcomes and to show how we're using these innovations in order to improve patient outcomes. So that's that. Anyone else have any other questions? Yes, ma'am. Anyone have a microphone for right here in the back?
Do you use PRP intraoperatively?
So, does anybody here use PRP intraoperatively?
PRP?
Yeah.
Occasionally.
Occasionally? Can you speak to it?
So one thing I do use for treating non-united fractures is something, it's similar to PRP, it's BMAC, it's bone marrow aspirate concentrate. So I harvest bone marrow from the posterior superior iliac spine and concentrate that and inject that, and I have some results around that I'm happy to share, but similar to PRP. Occasionally I will use PRP.
Anybody else using PRP in the operating room?
For us, it's the upfront cost that, for me, is a challenge to the patients. The patients have to pay upfront, which they don't want to have to do that, and they already have their deductibles and co-pays. So I just don't know if it really just affects the outcome, intraoperatively as it does for, let's say, non-operative treatment of tennis elbow or even rotator cuff bursitis. If you're going to the OR, I just have trouble, placing that burden of cost to patients when they're there for me to fix this problem and not to use PRP.
Yeah, and there is an increasing body of literature actually on BMAC bone marrow aspirate, concentrated bone marrow aspirate, which I think will show some really promising results, and that may actually drive some of our payers to start covering that. Anyone else? What other biologics would you guys say are very useful in particular surgeries, especially ones you may have presented on today?
You know, I use a lot of stem cells. I think I do a lot of complex fusion cases, and I think unless you have a fusion rate of a non-union rate of 0, it's hard to justify not adding some biology, because the cost of that second surgery to the patients and everything else, just the physical and mental cost as well as the financial, is huge. So I use a lot of stem cells.
Yeah. Anybody else?
Yeah, I use placental-based ECM grafts, which I know you use as well. Has been shown to decrease the incidence of fibrosis. They have a lot of anti-inflammatory cytokines. They help with pain control. I've had some very good results with it, especially with rotator cuffs, ACLs, and some of my other arthroscopic cases.
Yeah, I have some experience with placental extracellular matrix, and I've noticed the same results. Much more decreased inflammation and pain control, and also in patients, especially ones who have shoulder surgery, elbow surgery, places that are known to get extremely stiff. It's really, I think, over time going to show to have some pretty incredible results as well. Okay, so I think we have Dr. Ribas patiently waiting to give you guys some remarks, and I'd like to thank you all for your attention and for being here. It's really a privilege for us to be able to come up here today and talk to you guys, so thank you.
Thank you, Dr. Jordan, and I want to thank the whole team, Dr. Suarez, Dr. Larabors, Dr. Cardozo, Dr. Hodgkins, Haji, and I very impressed with the moderation. Thank you for getting this done. But I want to be able to apologize for one thing. How does a person go through Manmeet Ahluwalia, Murguzaran Manaharan, Dr. Guenther Koehne, Dr. Dabus, let me see here. I went through Dr. McGinn, Dr. Narayanan, Dr. Wynn, and I get Dr. Larabors correct, which I was practicing, and then I call my friend, Dr. Suarez, Dr. Sanchez. I don't know. And you know how they are. You saw how they interact. So I'm going to catch hell for 6 months for this. So I would just like to say, please pray for me. And my sister's in the audience, and she's probably going to tell my mother that I messed this one up too. So there you go. That's where I'm at. So, here we go. So this has been really exciting, being able to be with all of you again, especially in a post-COVID world. I got myself really excited on the opening day, and some people asked me if I was nervous, and I was just, no, man, it's really cool to be around our people again. So I want to thank you all for being here, first of all. On behalf of Baptist Health International, I would like to thank all of our speakers, our moderators, for taking the time to share their knowledge. And as we come to a close today, I would also again express my gratitude to all of you who've traveled from afar to be with us here during this time of year. And thank you for participating in what's been so remarkable symposium. Again, it goes without saying, I know you have choices. I know you can go other places, and you choose to be here with us, and we really appreciate that. We're proud of the efforts and dedication of our doctors and staff in making Baptist Health a global leader in healthcare, the premier provider for this region in quality care. And we hope your time was very productive, and that we fostered the key relationships. I hope you got that this was not just one way. This is a two-way relationship, and that is key to what we do. And I also want to, two things, if you don't mind, if you give me the time, but you can't have this level of physicians that take care of million-dollar athletes and high-level people if you don't have the right administrative team. And at the end of the day, to be able to pick up the phone and call somebody and get help whenever many of you call me or Dr. Hakim for help. And so with that, with the leadership of the CEO of Doctors Hospital and West Kendall Hospitals here, Lourdes Boy is here in attendance. Please, round of applause, because VP Ed Garabidian answers the phone at any time, any question I have, and I said, who's the best for this? Ed's always there to answer the phone call. And our BHI team, be remiss if I didn't, my right hand in when it comes to this clinical stuff and carries the big load, Dr. Galit Hakim of the international team. Raul Lopez, our AVP of marketing business planning. Julianne Dominguez, our AVP for analysis and finance, and our finance team that's here. You know, Raul's got a great team too. You know, he's got Damari Martinez, our director. This all, can we thank Damari and team for everything they've done? I always tell everybody that I put our team, and there she is, there, Damari, there we go, right there. And her team, you know, Yanette and Carla and these people, some of these folks were up until 6 in the morning getting this place ready and getting everything done. Lady, and God, I'm missing people. I'm sorry if I do. Yanette, even Alyssa, who's is first time with us, and it was my surprise. She's actually a daughter of Maria Freire, who's here helping us, also a big help. My physician relations team, what a team. I mean, I've never gathered so many great doctors at one event. Annie and Yami and Bibi, I mean, what a team. Thank you guys, I really appreciate it. And then with that, I have some housekeeping. We're gonna take a picture outside, and hang on, because I wanna make sure I got the latest instructions. I follow what they tell me. Sounds familiar. We're gonna be, tomorrow morning, there's gonna be breakfast at 8 a.m. The tour of MCVI, the bus departs at 9:30 in the morning. Again, we're gonna take some pictures now of the whole team so we can send it to everybody later on. I thank you and enjoy the rest of the afternoon. On behalf of BHI, thanks again for being here, and God bless you. Thank you.